Yeah, we have kept it on mute, sir. We will start the audio shortly.
We'll start in another 2 minutes. A very good morning to all. A very good morning to all. I, Dr. Prajakta Shitore, welcome you all, teachers, seniors, and my dear friends, on behalf of SOGS for the conference on revisiting ultrasound. Almost 25 years back, this technique of ultrasound and machines was so new to us, and we were unaware where will it lead to. And today, we are in the world of ultrasound with Dopplers, and fetal medicine goes hand in hand. But even after 25 years from today, I am sure we will be at such a conference with the same name, Revisiting Ultrasound, with newer techniques and high-end machines. I again welcome everyone and hand over the mic to Dr. Ashwini Pawar and Dr. Priyanka Kade to start with our first session of Revisiting Ultrasound.
Good morning all. We are starting with our first session. Chairpersons for our first session are Dr. Sadhna Deshmukh. She is owner and consultant at Suyesh Nursing Home, worked as a consultant at Ashwini Sahakari Rugnalaya Solapur, and she is known as Nightingale of SOGS. I welcome Dr. Sadhna Deshmukh.
And second chairperson is well-known Dr. Sumit Chamaria. He has a MS DNB OBGY, 3 years fellowship in fetal medicine, well-known consultant at Sunrise Hospital, Solapur. He has done 3 years long-term fellowship in fetal medicine at Dr. Suresh, Chennai, and received Best Paper Presentation Award at CUSSP 2016-18 and certified member of FMF London for NT-scan. Dr. Sumit Chamaria, welcome.
We hand over mic to chairpersons. Thank you.
Good morning, everyone. Respected speakers of our day, Praveen sir, Dr. Kulkarni, Megha Kamlapurkar, Dr. Ajit Gandhi, and all the respected teachers and my dear friends. It's a great pleasure to have all the prestige. I mean, we are very privileged to have such faculty for today's talk, and I'm sure we are going to collect leaps of knowledge and go home back. May I introduce our first speaker, Dr. Ajit Gandhi. He's a stalwart in fetal medicine from VMMC Solapur and a consultant at Unique Hospital over here. He's a very popular sonologist since 80s. And his report can be underlined by each and every one of us. He's recipient of various awards. He's a diplomat. He has done a diploma in endoscopic surgery from Kiel, Germany, and has performed many surgeries till date. He's a master in prenatal diagnosis, genetics, and has done over 200 intrauterine transfusions for fetal anemia. He's a certified examiner of FMF London. He's contributed 1 year to National Birth Defects Registry at Mediscan. His knowledge of fetal medicine is like a Indian musical raga, Indian classical musical raga, where he can go to any depth and play at any length on each and every topic of fetal medicine, and like senior performer of musical raga can play with all those suras and go to any depth in the music. Same way, he can go at any length and any depth of fetal medicine. So he's a highly respected person at Solapur, and he's a helpline for all of us. I welcome you, Dr. Ajit Gandhi. I'm sorry if I missed some of the introduction.
Thank you, dear Sadhna, Sumit, and all the august audience. I'll be the opening batsman for today. I'm going to speak on first trimester screening. It's a panoramic view of what has happened in the past, where we are and where we are heading. It's something which perhaps we are going to have more of a dialogue rather than a one-way speech. Okay. Today, I bring you a bunch of roses, as this program has coincided with the Valentine Day. Today is not the Rose Day, today is the Kiss Day. Kiss is a sign or symbol of a passionate empathy, passionate affection. It's a great coincidence that today this conference is held, and this passion and affection as a professional we must use towards the fetus. We see to it that we make his journey in the womb comfortable and make him see the light of the day on this earth. We are meant to facilitate him to be born for a sick fetus, for a problematic fetus. And it should not be something like what I say, the NOC. See, this reminds me of our hospital license. 25 years back, when we opened the hospital, just what we did is we got a piece of paper stating that you can run the hospital. This is your hospital license. Now, if you have to run the hospital, you have to have hundreds of NOCs. This is something similar the fetus is also going through. 25, 35 years back, when I started the practice, there was no much worry. Just we had to see that patient goes through a safe labor and gets a baby. Now today, the fetus has to get so many NOCs. Is that I'm not a Down syndrome baby. No, I don't have the heart disease. No, I don't have the renal problem. No, I don't have the CNS problem. And then only after clearing all these NOCs, the fetus sees the day of the light. So it should not happen this way. We should, yes, we must exercise a judgment where there is no quality of life, or where there is no chance of a successful life. There we must take the painful decision of terminating the pregnancy. There is no doubt about it. But it should not be like you see a cleft lip and you jump to the conclusion of terminating the pregnancy. So there are so many conditions which are manageable, which are treatable, where the baby can have a good quality of life, can have a longevity of life. Yesterday, I was reading about a journal in a December 2021 issue of ISOG. There was one article on the diagnosis of bicuspid aortic valve. And the authors had proposed that we should proceed with the diagnosis of the screening for the diagnosis of bicuspid aortic valve. Now, this is a condition which is compatible with life. This condition gives some morbidity, some mortality after 50s, in the 70s. So are these 50 years of life are wasteful years of an individual? What right we have got to kill such babies where the anomalies are compatible with life? They create, because these all things are now manageable. You have all surgical remedies for this. A person can have a near normal life. So is this justified? So it should not be. We should have a balance where the baby should benefit, the mother should benefit, and overall the society should benefit from what we are doing. And it should not be excesses where we just keep on killing the babies for the small trivial reasons. Now I come down to my topic is the first trimester screening. Now the very word first trimester. What is first trimester? Is from the day of conception till 12 weeks. Now of this, the particular, it's not 12 weeks for screening purpose. It's usually taken as a period from 11.4 weeks to 13.5 weeks, or in the terms of CRL, it is between 45 to 85. That is the current practice. Now there are some papers, there is some literature where the focus is now shifting from 8 to 10 weeks for diagnosing major anomalies, for diagnosing chromosomal defects, for diagnosing genetic defects, but still they are in the research stage, and still these things are not yet ready for the clinical practice. But maybe that after a few years, we will be doing so, we don't know. No, that is about the first trimester. Now, next slide is a screening. Now, everybody knows the meaning of screening. Screening means we suspect some condition and we take out a population or a cohort of individuals who are likely to have a particular condition. Now, it doesn't mean that all which we have taken out or we have screened out are affected. Is few of them are affected, few of them are not affected. So this in a scientific word, we call them as false positives, false negatives, true positives, and true negatives. And then you have to understand 4 terms which while you are doing the screening. That is, one is the sensitivity, the specificity, the positive predictive value, the negative predictive value. These 4 things are what the words are self-explanatory. I did not have to go into the meaning of all these words. How you derive them, just simply remember this particular chart and you will be able to derive your figures. What is sensitivity of your work? What is the specificity of your work? So that if you remember this chart, you will be able to derive your own figures. Now, why we do the first trimester screening? All of us are doing the first trimester screening. What is the intention of doing the first trimester screening? Shall we compile those things? Why? What is the information we derive after doing the first trimester screening? Those are many things. Those could be maternal. Those could be fetal. Now, if you look at the look back, the screening concept came somewhere in the 60s and 70s. Okay, this screening concept came with for the diagnosis of Down syndrome. This is a Western philosophy, and perhaps I think the reason for this is the more leading people were the UK people, because in the UK they have a national health system where everything is linked against the costs, and perhaps it could be the reason that the birth of a Down child is a burden to the society was a concept perhaps which might have been born in the UK, and with that the things must have started rolling down to diagnose the Down syndrome. And in the 60s and 70s, it was noticed that the women who are more than 35 have the higher incidence of Down syndrome. Now, with this thing in mind, the people started looking how to diagnose the Down syndrome. And then in those days, the only thing which was available was a amniocentesis. It was a second trimester diagnosis, till the CVS was in a developing stage. And then those people started to doing the diagnosis of Down syndrome with the help of amniocentesis in the women who were more than 35 years of age. But then it was realized that if only age is the criteria which is used for screening for the Down syndrome, only 3 out of 10 Down syndrome will be diagnosed, if age is the only criteria used. So you are missing out 70% of the Down syndrome only if the age criteria is used. And then the scientists started looking for improving this detection rate. 70s and 80s was the time where many markers or the solutes in the blood were checked, how they behave, how they increase, how they decrease, and so many. There are about 18 markers which were checked in various combinations, permutations, and in 1989, that triple test came to in a clinical practice. The triple test was introduced in 1989, and the people started using the second trimester screening. Simultaneously, it was the first time, the focus was slowly shifted to the first trimester. There were many markers which were again tested for the first trimester. Now, another breakthrough which came in the 90s, somewhere around 1993, that the first report of increased nuchal translucency in a Down's baby was published, and the attention was drawn to the ultrasound signs of possible Down's baby. It was the nuchal translucency which was published in 1993 by the Kypros Nicola of fetal medicine and those people. And then it was realized that with ultrasound, you will be able to diagnose the Down syndrome. And it took 2000 to make it more perfect, and a combined screen was developed. It was PAPE, free beta ECG, and the NT. And with the beginning of this century, the people started practicing the blood markers along with the ultrasound. The FMF has taken a good lead. They developed a meticulous method, a protocol, a certification to make this useful. In 1997, a scientist, Lowe, he first found that there is a circulating fetal DNA in the maternal blood. He could detect the SRY gene, and with that SRY gene, he could predict that this could be a male boy, or if it is absent, then it is a female. That happened in 1997. And it was for the first time, it was realized that fetal DNA circulates into the maternal blood. Actually, the history of finding the fetal cells in the maternal blood is 100 years old. It was at one autopsy of a preeclampsia patient. It was noted that there were some trophoblastic cells present in the lungs. This discovery was about 100 years ago. But presence of fetal DNA took 100 years, and it was somewhere in 1997 this was noticed. Now, the peculiarity of the DNA is that it's very fast cleared from the maternal blood. Now, fetal cells can stay into the maternal blood or maternal marrow for years together. So if you want to use the fetal blood, there would be a confusion, because if it is a second pregnancy, you would not know whether this fetal DNA, this cell has come from the first pregnancy or a second pregnancy. If there is an abortion which was unnoticed, then you will have a confusion. So those all things were there when people were looking for the fetal cells. But now this was not the problem with the DNA. DNA, it gets cleared from the maternal blood very soon. So that was one breakthrough. And after that, this was particularly used for the diagnosis of sex. Of course, that was not permitted in our country, so it never came up in our country. And the second application of this in the earlier days was to diagnose the Rh positive or negative fetus. That is how the journey of the fetal DNA started somewhere around the end of the last century. Now, the major breakthrough came in 2000. In 2010, when the next generation sequencing was put into the practice. Now we'll come to it when we go for the NIPT in my subsequent talk. Now we come back to the why. Now the first thing is to assign, why there should be a first trimester screening, is to assign the gestational age. It's very important. And perhaps up to the 12 weeks, you're assigning the gestational age is accurate to the extent of plus minus 4 days. So you don't miss the opportunity to assign the proper gestational age, the proper due date. Almost 50% of the women are wrong in their dates, or their dates are due dates are different because of the irregular cycles. So this is very important. And the next very important thing is stick to that assigned date till the end of the pregnancy. We still find so many reports, gestational age so-and-so, EDD so-and-so. You take the next report, it gives you a different EDD. You take the third report, you get another different EDD. The EDD would not change. The growth will change. Remember this in mind. Whenever you do the ultrasound, just take some efforts, spend some time, go through her records, find out the first trimester scan. Invariably, usually, everybody has a habit of putting the EDD with the CRL scan. Use it. Don't assign a different date because I have not done this scan, this scan is wrong, and this date is wrong. This will not happen. Unless you have very grossly measured the wrong CRL, this will not happen. So you stick to the date which is there in her report. If the patient has come later in the pregnancy, or if you yourself have done, stick to that, and then as the pregnancy progresses, you evaluate the fetus for the deviation in the growth with reference to the assigned EDD. Now, second is to detect and eliminate the chromosomally abnormal fetuses. That is something where the screening started, and now we'll be elaborating more on this after we finish off this slide. Then, prediction of PIH. We'll come to that again. And lastly, it is the diagnosis of multiple pregnancies, its chorionicity and subsequent management. This is very, very important. In the afternoon, we are going to have a good session from Praveen sir about the multiple pregnancies. So I'll not be covering this particular topic. We'll be having this in the afternoon. Now, after preparation of this slide, I had two more points in this mind about the 11 to 13 week scan. Why we do is a diagnosis of possible genetic disorders. Now, this is one thing which now we must include in the first trimester. There are beta thalassemia traits, there are cystic fibrosis. SMA is quite common in our area. So these are the things which you need to work out and do the prenatal diagnosis. The process should start in the first trimester. Okay. And last is to make some money so that we can pay the EMI and earn for our family. So that is again our objective. Let us not run away from the facts. Now, to detect and eliminate chromosomally abnormal fetuses. As we know, there are 46 chromosomes, the 44 autosomes, and one is a pair of sex chromosome. The chromosome 21, 13, 18, and sex chromosomes are the most vulnerable chromosomes for abnormalities. They can have the trisomy. There can be an aneuploidy. So we all know that 21 trisomy, 13 trisomy, 18 trisomy, the Turner syndrome, the Klinefelter syndrome. So these are the common chromosomal aberrations which occur in a fetus, and there could be a great fetal loss with all these anomalies. If you take about 80% of the 13 and 18 trisomy fetuses die in utero and are eliminated by the nature by the time they reach the full term, between 12 and full term, 12 weeks to 40 weeks. Almost 80% of these fetuses are eliminated by the nature. We don't have to do anything. 13 and 18, hardly they see the daylight of this earth. And also the Turner syndrome. The Down syndrome, about 40% of the Down syndrome, they die between 12 weeks and 40 weeks. You don't have to do anything. So it is still we wish to diagnose it. Perhaps this particular thing has got a little medical legal angle, because if there is an intrauterine death, unexplained, the things the patient, the relatives, they keep on troubling us why this has happened. If we have an answer about it, yes, this is the particular cause. That could be one reason. Now, how to screen? As I was telling you about the age, then came the blood markers, then came the NIPT and the ultrasound. There are various combinations which have been tried. The maternal age alone, the maternal age and serum biochemistry, the maternal age, nuchal translucency at 11 to 13 weeks, maternal age, NT, PAPE, free beta ECG. Perhaps this is the most appropriate combination for the present day, our circumstances, where we will be able to detect 85 to 90% of the chromosomally abnormal babies. So your detection rate is 9 out of 10, you will be able to diagnose the chromosomally abnormal babies. Now there is a rider, there is a hitch. I'll come to it in a moment. Now, the rest of the things, maternal age, NT, nasal bone, 90%. Maternal age, NT, NB, PAPE, and free beta ECG, the detection rate would go to 95%. Now these figures are the literature figures. Those people, those scientists who have worked under the stringent conditions have applied the quality control at every stage, and they could derive this figure. Is it the reality with us? Have we checked our figures? We have been doing all this. Does anybody has the statistics about this? Can anybody tell in the audience that you have the statistics that my detection rate is so and so? Now I'll describe you 3 different circumstances about a Down's baby. One circumstance was with a very senior gynecologist family, where in her family there was a Down's baby born after doing the the antenatal care is given by herself by the senior colleague. So it was a very embarrassing situation. And then I came in the picture, and I don't use he and she, whatever he and she, he wanted to convince him that Down's baby can be born. It was very difficult for me. I had to lie. I had to lie a half truth, because I use this, it is 90%, so it could be that you are in 10%. And this scenario was like the Down screen was not done in this particular pregnancy. Being a senior, still it had not come in the practice standards, in the implementation, and naturally the screen was not there. This was one scenario. Now another scenario was with a busy gynecologist colleague, had done a screening, then the Down's baby was born. The relatives came to me asking how this has happened. Again, I had to lie. Yes, this 10% can happen this. No, why I lied? I'll show you one example after this slide. Then you will realize what is happening, what we are doing, and what we are supposed to do. The third scenario is of a case which happened somewhere in the 2020. This is from a Chennai, the IVF conception, age 40 years. Then she was offered the NT-scan, which was being done in 2020. Now remember that there is a lot of change in the quality of the NT-scan. What was being done in the 2020 in 2000 and 2020 is quite different. Now this case landed up in the consumer court. Gradually it moved to the apex, the national forum, and national forum one day mailed me that I want your opinion about this particular case, that whether this particular doctor is at fault for not doing the justice to the patient. Then I gave a reply that this case is in the 2000. In the allegation of the patient was that should she had done a marker study with the NT, my Downs would have been diagnosed. So then I gave the justification that when it could be that it has come to your court in 2020, but then you have to see to the contemporary practice trends and the science which was prevailing in 2000. And what was there in the 2000? Still those marker strategy was not fixed. The NT criteria were not very clear. And in those days, she had offered the what best she can do for the patient. So she can't be held guilty for this particular baby being born with a Down syndrome. And the court has accepted my opinion, and maybe the result would come in the favor of the gynecologist. So we all know this. PEP is decrease in all. It's increase in some, it's decrease in some. We all, everybody remember about it. Now, again, a hitch, which I'll come to it in a moment. A proper NT. What should be a proper NT? See, unless you have this kind of image, you should not be satisfied with whatever screening has been done. I'll be showing you some images after this. See, there are some criteria, like should be a mid-sagittal section, should have some pocket of liquor, baby should be in the neutral position, you must use a magnification, should be able to see the amnion. You put the caliper end to end. And once you are satisfied with such kind of image, then you look at the anti-measurement, which is being included in your screening calculations. You can use any statistics. You have the FMF statistics, you have the perinatology.com statistics. So you can calculate the risks and come to the conclusion that this could be a high risk or a low risk. But remember, at the background, the quality of the NT image is very, very, very important, which we forget. We see very funny images. I don't want to show all this. I have a collection of almost 1,000 images which I had done, but then it would be something discouraging for the audience. It's not, that is not the intention of this particular conference. But then we must do a proper NT. And for this, the most important thing is the time. You must give adequate time to get such kind of pictures. It takes about 10 to 20 minutes to do a proper NT scan. The other day, somebody was telling that some medical officer from corporation, I do 25, 30 scans in a 1 hour. It's something, it's a gross injustice, a criminal injustice to the patient. How you can do 30 scans in 1 hour? That is just not possible. Why you are doing this? Why you are cheating the patient? Better you don't do, you tell that I don't do it. What is wrong in it? This is a typical increased NT. You can see that the nasal bone is hypoplastic. You can see a grossly NT, it is about 6 millimeters. So this fetus is highly likely to be affected. Nasal bone. Must see a clear nasal bone. What you must
Yeah, there was a slight network connection at the venue hall. We are reconnecting. Sorry for the inconvenience. Apologies. Yes, yes, we are still live. Just give us 2 minutes. There was a internet disconnection at the venue, so just give us 2 minutes. We are coming back again.
to the Mumbai office. So it takes about, so it's almost 4 days have elapsed in between the sample collection and the date of reporting. Now, PAPE and free beta HCG are heat sensitive, are time sensitive. If they are not properly stored, if they are not properly frozen, the values would change. If there is if the sample is not, ideally it should be processed within 6 hours, if not at least 24 hours. If it is delayed beyond that, the PAPE would decrease. The free beta HCG component would increase, and then you would get a wrong calculation. Is this likely in this particular case? This is one error which has happened in this case. Now, let us go to the next slide. Now, here is the report. Can you see this NT image? Chairpersons, will you pass this image? So, depending on this particular NT measurement, the risk has been calculated. So the whole data which is being fed to the software for calculation of the risk is wrong. Now this patient, because once you have opened this chapter, you have to close it. This patient has now to undergo an invasive test. Now, if this kind of screening is going on, then what is the purpose of doing the screening? Does it serve any purpose? I wish to ask all of you that after doing screening, how many of you have got chromosomally abnormal babies? How many Downs, 21 trisomies you had diagnosed in your practice in last 3-4 years? Can you recall your figures? Anybody? Just as a formality, just as a medical legal safety, we are doing this. Has it served any purpose? If we don't do it meticulously, what is the fun in doing this particular test? Why we are asking the patient to spend on this particular thing? He spends 2,000, 3,000 rupees on the NT scan, another 2,300, 3,000 rupees on the markers. And at the end, if he gets a Down's baby, why he should not be angry with us? It's fortunate that the patients which I quoted, nobody asked about the data. If they would ask about the data, or the matters go to the court and the court asks them, what is your data? Where is your data? How much you have detected so far? What is your detection rate? Because you know the judiciary is also getting wise. They are also reading the medical literature. They are also trying to understand the things. And the thing like what happened in the National Forum has sent for opinion to me. Like it might go to anybody. It might go to Sumit tomorrow. And if he sees this kind of picture, do you expect him to say that this is correct? Is it Sumit? I don't think so.
Yes, sir. Correct.
So if you want to do a down screening, do it thoroughly. If it is not done, you can declare your policy. Down screening is not done in my clinic. Or whatever possible ways. If you are doing only double marker, then you tell the patient that this double marker can detect only 7 out of 10 Down syndrome. There is a chance that 3 I would miss. You make it clear to the patient. He should not be under impression that this test has been done, so baby has no Down syndrome. And if the patient gets tomorrow Down's baby, what answer we have got? How we are going to show the face? So whatever screening strategy you adopt, you be clear to it. This is possible. This is not possible. That way we must go. We should not conceal the facts, or we should do something which is not justified. The patients are wise. They would come one day or the other, they would realize this. And what would happen then? If it ends up into a legal battle, we have to shell out crores of rupees. Whatever we have earned for our lifetime, we just pay in a moment. So just, I'm not making you, this is not to discourage. This is just, I'm bringing a point so that we do it thoroughly, properly, so that there should not be any finger pointing to us that you have done something wrong. That is more troublesome. That is more torturous. Now I come down to so what I said about the screening, the present day strategy for us, if we now this brings me to one more point, that if we are going to do a kind of marker screenings, we must do two things. That is what I believe, and organizations like ours should take a lead in developing such things. Number one is to pool the data. See that what is the detection rate for all of us, whether this test is performing well. And secondly, the company who is offering the service must be transparent to give you the screen positive rate, the false positive rate, the detection rate. So all those data the company must provide to you when they take your sample for screening. Now, in this particular case which I have shown, it's a big company, but they haven't shown the kind of method they have used to analyze this blood sample. These are the Delphia or Cryptor analyzers, which are calibrated, which you need to calibrate. The FMF has elaborate guidelines how to calibrate them and how to periodically audit them to have a meaningful report. None of these companies, they follow these guidelines. None of these companies, they tell you about which machine they use. It is the Delphia if you have to use, you have to have a batch of 50 or 100 at a time to run to make it viable. Now a kit of Pepe and free beta HCG in a good quality kit costs you about 500 rupees. If you consider the cost that they are offering you at 1,000 and 1,200 rupees a Pepe and a free beta HCG, have you ever thought of whether this is feasible, this is possible? Are they giving a proper report? Because if they are spending 500, 600 rupees only for the kit cost, the logistics, the human resource, the machines, all this, can they afford in 1,000 and 1,200 rupees? Is this report reliable? Have you ever thought of? No company gives on what analyzer they have done, what kind of, what is the statistics. If we are going to do all this, we must do at the organization level, at the individual level, and ask for these figures. Now I come to the next is a non-invasive prenatal testing, or NIPT, which is perhaps the new direction where we are heading to, and those Pepe and free beta HCG perhaps would become a thing of the past in the coming future. Now, what is NIPT is, I spoke to you about the free DNA, the fetal free DNA in the maternal blood. Now, with the advent of next generation sequencing in the clinical practice around 2010, this NIPT got a meaningful clinical application. Now, what is the next generation sequencing? What is the concept of next generation sequencing? Just to make it very simple, I would put this way. Now, see, we have 46 chromosomes. All these 46 chromosomes will have some material, circulating material in the maternal blood. Okay. Now the fetus is also there. So those all 46 chromosome material of the fetus will also come into the circulation of the fetus, of the mother. So there are total 92 say chromosomal material of the chromosomes will be there in the maternal circulation. Okay. Now imagine that these are 92 rows, and every one of you represent one gene. Okay. So now what is done is a parallel sequencing. What are those genes? Right now we don't know. Once you do the sequencing, this is oversimplification of the concept just to make you understand. What you do in sequencing is just you identify those sequences and just see to it that from which chromosome those sequences have come. The Human Genome Project has defined all the 46 chromosomes and the gene mapping. So you know which gene comes from which chromosome. So now this all 92, those are mapped. You put it on the rack properly on the chromosome 1, 2, 3, 4, 5, 6, 7, 8, and like that. The 92 are over, and still there are 2, 3 are left. Now that extra material is something which is a trisomic material. Now from the sequence, you know that this is a trisomic material. So that extra material tells you that this is a trisomy. Now there are two methods. One is a massively parallel sequencing. Massively parallel sequencing is what I described just now. It's just you sequence all those things which are there in the circulation. That is a massively parallel sequencing. Now there is another method, is a targeted sequencing. Just you do the sequencing of a particular gene which is there on the chromosome 21 because you want to know whether there is chromosome trisomy 21. Now there is one PLCA4 gene on the chromosome 21 which is very unique, and you do a sequencing for that particular gene, and if you find that there is an extra genetic material, that means this is a targeted parallel sequencing, and you find that this is a trisomy 21. So this is a very simplified concept that what is a massively parallel sequencing. Now there are other methods which are evolving, but they haven't come much to the practice. Even the understanding about all those, about all these techniques, mine is also not very good. So I'll not be describing those.
So can you please go ahead a bit fast? We are running short of time.
Yes, this is the, okay.
Sorry to interrupt you.
How much time is left for me?
You can take 5 more minutes.
5 minutes. Okay, ठीक है, चलो.
Thank you.
Hey, restart. क्या हो गया ये? Restart को क्यों हो गया? चलो, ठीक है. Major congenital anomalies, just I'll put in 2 words. At 11 to 13 weeks, you will be able to diagnose all the major congenital anomalies. 2-3 tricks or 2-3 important tips are: do a transvaginal scan. Transvaginal scan gives you a more clear resolution, a better resolution because of high frequency and the closeness to the fetus, so that you will be able to pick up the cardiac anomalies, the CNS anomalies, the limb anomalies, the trunk anomalies. So all these major anomalies, almost all of them should be diagnosable at the 11 to 13 week scan. Cardiac anomalies, yes, you can diagnose, but with a pinch of salt. That don't make a hurry to terminate them. A thing which looks like fellows in the first trimester may turn out to be a DORV in the second trimester. So these things may happen. So when you pick up something, you keep it under follow-up, do it, repeat it every 2 weeks or 3 weeks, and complete the diagnosis by 16, 18, 20, depending on your expertise and the comfort level and your quality of machine, and then only take a decision. There is no hurry. You have a limit now increased to 24 weeks. But before that, you must see that this is an anomaly. Number 2 is whether this anomaly is solvable. Now, about the cardiac anomaly, not all cardiac anomalies are bad anomalies, or all the anomalies you need to determine. The anomalies like Fallot's tetralogy, they are now surgically very correctable. 80, 90, 95% of the good results are there with anomalies like Fallot's tetralogy. So your counseling must include all these plus and minus things when you deal about an anomaly. काय झालं? हँग झालं? पुढे सरकत नाहीये. Prediction of pH. Very important thing, very simple thing. If you spend at least 5 minutes to take a proper uterine artery Doppler, you should be able to predict whether this patient has a risk for preeclampsia. As you know, this is one of the great killer or maternal is contributing to the maternal mortality. What you do is you take the uterine artery, you utilize the maternal characteristics. It's very important. If the mother has hypertension, if she has a background of SLE, if she is obese, if she has a history of previous preeclampsia, if the mother had her mother had a preeclampsia. So those risk factors you just take into account. If you don't have a software, even if you list down all those in your case record and just put a tick mark to this, these are the background risk factors, and then your uterine artery showing abnormality, she is a candidate, she is a high risk patient, and you know that the remedy is aspirin. Now, aspirin has proven beyond doubt, and at least it changes the outcome in 50% of the patients. That is the international statistics, and I agree to it because I have been using aspirin since 1993. And the dose for aspirin is 150 milligram per day. Remember this. Don't use the absurd dose of 75 and 15, all those. It's 150 milligram. Remember this. Now, about the uterine artery, you look at the uterine artery PI. You can take it transabdominally. You can do it transvaginally. Uterine artery PI cutoff for the first trimester, we take it as 2.4. For the second trimester, we take it as 1.4. If it is more than that, this patient is at particular risk. Now, one of the observations which I have done personally is there are two sets of patients. Number one, who show a high PI value in the first trimester, maybe 3, 3.2, 3.4 like that. In the second trimester, there is a subset of patients who will continue to have a high PI value, 1.82 like that. These are the patients who would subsequently develop a bad preeclampsia. Now, there are other group of patients where the first trimester shows 1.8, 1.7, 1.9. So it essentially is in a low risk or is below the cutoff. But then the same resistance continues in the second trimester. Now, these are the patients who would develop a preeclampsia, but not like the first group. So this is an observation which I made over the years. Maybe that we have to put it in a more statistical way before we publish it. But that is one thing. Now, about the PI, if your second trimester PI is more than 2, and at the same time, if you are finding that there is a growth deviation, these are the patients who would do worse. They will develop the severe preeclampsia very early, maybe 23, 24, 25 weeks, become bad proteinuric, will have a fetus which grows to hardly 405 grams and will end up in intrauterine death, severe preeclampsia, HELP, and all those things. So this is a particular subset of patients which you must pick up, because these are the patients who will have a high morbidity. They will have a 20 times more mortality compared to the late onset preeclampsia. So yeah, at least if you fail to detect the other patients, the patients who have a PI value more than 2 in the second trimester, don't neglect them. Those are the very highly vulnerable population. Yes, this I spoke already. Aspirin is the remedy. This is the meta-analysis of a very large trial which was published long back in 2013, and now is beyond that the aspirin must use in the practice. Multiple pregnancies we are going to have in the afternoon, so I'll skip this totally. I think I have finished. Thank you.
Thank you, sir. That was an eye-opener for all of us. And I'm sure people will become more aware and understand their responsibility. So there are a couple of questions for you. Someone has asked, which lab do we send dual marker and triple markers?
Sorry?
And do we need to know what machinery they are doing it, and how, if something wrong happens, will be the culprit for the same? How to decide which lab we should send dual markers?
Which lab?
Laboratory. Do we need to know the authentication of the laboratories?
See, after doing all those things, I have now stopped doing the double markers.
Oh.
I rely only on the nuchal on the proper NT scan, and there I use all those parameters: the NT, the NB, the ductus, if it comes to the FMF angle, and then I calculate the risk, which gives me more accurate risk calculations than adding to the markers, because I have used all this and I haven't satisfied with any of the labs which are available around us. And as I said in my lecture, that if we are going to do this, we should do as a collective effort. We should have at the organizational level, ask some data, some statistics for ourselves. We do our do the data collection and see all the false positive, false negatives, and all that.
And in the current practice, would you be liberal to do NIPT than going for dual markers and this directly? What is the future role of NIPT?
About the NIPT, which test to choose? Okay. See, I heavily rely on the NT scan. If I find something is abnormal in the NT scan, I would prefer to go for a microarray than a NIPT. Okay. If I find that there is only an increased risk because of the NT, NB, and DV, then I would prefer to go for a NIPT. Now you have to understand something about the NIPT. NIPT, number one, it has come from the commercial segment of the world. No government has done this research. This has come from all the private laboratories who have invested a huge amount and they have come out with the NIPT. That is number one. So the figures quoted by the laboratories, you don't believe at their face value. What the literature states, for trisomy 21, the NIPT detection rate is to the tune of 99%. For trisomy 13 and 18, it is somewhere between 92 to 95%. And for the sex chromosomal aneuploidies, the detection rate may be as low as 89 to 90%. NIPT does not recognize balanced translocations. NIPT has a limitation in a condition called as confined placental mosaicism. What is confined placental mosaicism? Is the while development of the embryo, some of the cell lines, they develop the aneuploidy and they just grow only in the placenta and not in the fetus. So the placenta would show you a mosaic picture of an aneuploidy, and this is one limitation where the NIPT may not detect the abnormality. Then the NIPT has another limitation. If by chance, if the mother has any other abnormalities, like if she has a tumor, or it's a very hypothetical condition, the mother has some chromosomal abnormality, then the NIPT may give you a wrong report. So these are all limitations of the NIPT. So to take home message, if there is a fetal abnormality you detect, prefer microarray and not NIPT.
Hello. It was an excellent presentation, Dr. Ajit. There are certain things that I wanted to make sure. There is one was the question whether we are liable if we suggest a lab and there is something wrong with the lab report. I don't think we are liable for that. There was a question stating that are we liable? We are not liable because the responsibility lies with the lab which does it. You are only a sample giver. You have given the sample. That's all. Beyond that, you have not done anything. So we are not liable for it.
In this particular scenario, then it would be the patient who should select the lab. Then the responsibility would go to the patient. If I recommend a lab or I send to a lab, I think the captainship responsibility lies on me and not the lab. It will be a sort of a
if you say
collective.
that it's a vicarious responsibility, yes, but then basically I don't, I think we are not bound.
Principally, yes.
That is one. Second important thing which I want to tell about NIPT is the present thinking is that what we do is what is called as the NIPT. Yeah, NIPT is nowadays being done even before the first trimester. That is almost about 8 to 10 weeks of gestation. The reason is that if you do an NIPT and you say that, or there is a high risk pregnancy where you did an NIPT and proves to be positive, which is almost 99% sensitive, in those situations, there is no reason why the pregnancy should be continued. First point. Second important point is that there is what is called as developed as a pre-NIPT scans. Another important factor which we have to keep in mind is what is called as the pre-NIPT scans. The pre-NIPT scans are extremely important now because quite a few number of abnormalities can be detected or made out by the pre-NIPT scan. Particularly when you are doing a transvaginal examination in the first trimester, you do pick up quite a number of abnormalities which were hitherto not found. So this NIPT is one thing which prompts you to be much more alert, because as days are progressing, probably our role in doing an NT may go off. In the sense, we may not be struggling to get an NT, because the present generation thinking is that we need to do an NIPT. If NIPT is normal, then we progress on to the second trimester and first trimester. First trimester scan is basically to evaluate the structural abnormalities rather than the aneuploid detection. So that is the change in thinking that is happening now. So I think NIPT has a very important role. I think we need to accept it. There is no option for us, because yes, all said and done, the companies are projecting it, but that doesn't mean anything. Because yeah, if there is something good, we have to accept it. There is nothing wrong in accepting something which is good. So I think we have to start now doing what is called as the pre-NIPT at about 8 to 10 weeks or 10 weeks of gestation, ideally 10 weeks of gestation. And before that, I would definitely ask you all to do a pre-NIPT scan, because that is one thing which is really, really picking up, and you'll feel so, so clear in your anatomy, detection of anatomy in that pre-NIPT scan. And I would advise that it should be practiced by all of us.
Thank you, sir, for the insight.
Sir, if there is a history of previous baby with Downs, in such cases, would you prefer NIPT or should we go for invasive? If there is a history of previous child with Down syndrome, so in this patient, NIPT you will.
Doubt about it. Yeah.
With the previous Downs,
I think it's.
with the previous Downs, the risk of Down syndrome is increased by 0.75% in the subsequent pregnancies. It is particularly the translocation Downs, the risk is more. But again, the translocation Downs incidence is very low. It is 1 to 2%. 99% of the Downs are the spontaneous Downs.
Thank you, sir. Thank you so much. It was a wonderful talk and discussion. We can have it later on, or because we are running short of time. He's already explained, I think, the PI values and uterine artery Doppler to predict.
Yes, I have explained that. What? Achha, okay.
Okay. Anyway, I think we will end up the session, and maybe some lunch break we can go on with questions. Yes,
Now
may I
we'll
hand over to
talk-
Sumit?
Talk by Dr. Anirudh Kulkarni, sir. Sir is a professor of radiology at Aurangabad, director and faculty at Scholar MD. His areas of interest are the ultrasound guided interventional procedures, the procedures of the neck, the GUT, and fetal intervention, CVS, amnio. Sir is great in this. Sir has contributed 2 chapters in the textbook of radiology, which is widely used by the budding as well as the practicing radiologists throughout the country. Sir has 23. Sir has almost 24 publications in the indexed journals, both national as well as the international ones. He's a reviewer at the British Journal of Radiology for the GUT section. And he's an eminent figure in the national and international conferences. Besides this, sir is also into film watching and is an avid traveler. So next time, whenever we are planning post-corona, any travel plans, we can include sir in our travel plans. Yes, over to you, sir. Thank you.
Thank you very much for a wonderful introduction. And we'll start with the session. More or less, this deals with very practical problems that encounter day-to-day practice, that is low implantation of sac, no financial disclosures, no corporate disputes. The things which have been taken from the internet in terms of article has been duly acknowledged. And if at all, if you find some of the names on the images, particularly belonging to patient, then that is just mistake by my technicians. There is no purposeful intention of showing those images containing the names. So thank you very much for the same. Usually, I like this person very well because apart from the cricket, he has done a lot of good things in terms of giving good quotes, where he says that the talent is the most useless virtue to possess, because what you do with that talent is more important. It is finally, if you try to compare it with our imaging, then protocols, that is the most important thing. And everything that you do, if you do with got a lot of love and passion, then probably you can overcome the talent if it is not there with you. So, and I think I am one of the prime example for the same, because during my undergraduate and PG days, I was a quite average student for that matter, but still I could manage with those. So just get into this, some of the important articles which I want to mention in terms of literature, which is freely downloadable and available on the net. That is low-lying gestational sac in early pregnancy, an algorithm approach. And secondly, what are the different complications that can occur that case? So whenever we do ultrasound for early pregnancy, We usually see that the implantation of blastocyst is in upper part of the cavity. So we comment about decidual reaction, presence or absence, its nature, interdecidual signs positive, double decidual sac sign positive, fetal pollen activity, and we don't try to overcome the timeline as far as appearing these events are concerned. So this is classically intradecidual sac sign, which is usually seen in 4 weeks plus kind of a days. Then the next event usually happens is a appearance of a classical yolk sac at 5 weeks plus. And again, most of these events are happening in upper part of the cavity. So we are not worried about any of the complications for that matter. And then the next event is the appearance of a fetal disc or a fetal pole along with the pulsations. Usually on transvaginal high frequency transducers on sonoembryological mode, you can get it at early as closer to 6 weeks nowadays. So what is mean by low implantations? We have seen the events in a normal cavity when it is there. Low implantation is identified when the lower sac, lower border of the tropoblastic tissue is less than 5 centimeters from the external cervical os. So you take a measurement from external cervical os to the with the chorionic reaction over there. And if it is less than 5, then we say that it's a low lying sac. So this is how this is the way in which we should measure. The next thing is that during the eyeball technique, initially what you get is you see that the more or less the endometrial cavity up above is empty. Now can you appreciate the empty cavity over there? And the entire sac along with a good chorionic activity or tropoblastic activity is located here. So next thing that I am going to do is a measure distance of lowermost pole of chorionic activity to the external os. If that is less than 5 centimeter, I am going to label it as a low lying sac. So whenever there is a low lying sac and there is a vaginal bleeding or a pain, then at the same time, it's my duty to differentiate it from different conditions, like whether it's a cervical stage of miscarriage, whether it is a precursor of moderate lateral placenta, whether it is a cervical pregnancy, or whether it is a cesarean scar pregnancy. And the ultrasound findings that we get at this period of time will give you a clear-cut guidelines or clue. The first thing that you should look at whenever there is a bleeding PV in a low implantation sac along with pain is that whether the chorionic reaction of the gestational sac is getting tented, what you can say tented, or a triangular appearance where it is getting stuck or adherent to the, if at all, any previous scar which is present into the uterine cavity. So if that is there, then again you start suspecting about something or the other. So again, a major distance. The next thing that one should do after saying that it's a low implantation sac is look for what is called as a sliding sign. So what is the sliding sign? It is done on a dynamic transvaginal scan. The suspicious area can slide over the cervical canal or a myometrial stripe. Then we say that the sliding sign is positive. When the suspicious gestational sac or a tropoblastic reaction is fixed and moves along with the dynamic pressure over the cervix or the myometrium over there, the sliding sign is negative. So the inability to displace the gestational sac from its position at the level of internal os or the scar by gentle pressure, either by the transducer or by manual examination, will say that it's a sliding sign is negative. And when we say that the sliding sign is negative, then again we need to look into that pregnancy with great details. So there is an absence of peritropoblastic activity, then we are not worried much. The sliding sign is positive, that means probably we are dealing with cervical stage of miscarriage. So absence of peritropoblastic activity, sliding sign positive, look into the criteria of cervical miscarriage. And second, presence of a peritropoblastic activity, sliding sign negative, and then look at the number of scars that the patient may harbor and look for the cause sign. So I will discuss the cause sign in the next few minutes. So we need to see whether gestational sac is in the myometrial stripe, whether gestational sac is scar near the scar where the deficient myometrium is 1 to 3 millimeter, and gestational sac is implanted at cervico-isthmic junction where the myometrial stripe adjoining to that is equal to 5 millimeter or more than 5 millimeter. Now, if it is in the cervical myometrium, we know we are dealing with cervical pregnancy. If it is 1 to 3 millimeter, we are dealing with the caesarean scar pregnancy. And if it is at the cervicoisthmic area where 5 millimeter or more is there, then we are suspecting about what is called as the morbidly adherent placenta, and further complication if the pregnancy continues needs to be sought in that direction. So all cervicoisthmic implantation that do not fulfill the criteria of cervical pregnancy or a cesarean section pregnancy, those all should be monitored very, very closely for placental inhomogeneity at the later period of time. So what is crossover sign that I mentioned just now? So on transabdominal scan, this is a sagittal section in which you take a line from through the fundus and the internal os reaching up to the external os. So this is one sagittal line. The second sagittal line is superior to inferior, which is perpendicular to this line. And then look at the gestational sac in relation with this sagittal line. Now cos1 is more than 2/3 is above the sagittal line, which has got a poor prognosis, wherein this kind of a pregnancy will have loss of myometrial stripe, loss of serosal surface, and extending into the bladder in eventually 3rd trimester, where we call it as a morbidly adherent placenta and various complications of the same. When it is cos2, that is less than 2/3 above the sagittal line, then we are below the sagittal line, then we are not much worried about those. So one is a sliding sign and second is a crossover sign. Now, as we have seen earlier, we need to see for cervical stage of miscarriage by stating that when the sliding sign is positive. So products of conception or sac, which is detached from the fundus, will have this kind of appearance where the cervical canal will be ballooning, there will be inhomogeneous areas within the sac, and on many occasions we'll have a normal collapsed sac-like structure within the cervical canal. So ultrasound wise, the cervical canal is ballooning up, which is held up by the external os. There is no peritroplastic activity over there because the sac is detached from the fundus and coming into the cervical canal, and sliding sign will be present or positive. We will be able to move very freely the myometrium and sac independent of each other. Now, can you appreciate here? The cavity is completely empty over here, and you can see that the products of conception in terms of a collapsed miscarriage area within the cervical canal quite nicely appreciated over here. So we need to look at absence of a peritroplastic activity and sliding sign, which is positive in case of a cervical miscarriage. Just to ascertain in terms of clarity of terminologies that we use, less than 10 weeks is embryo. Thereafter, we call it as a fetus. And just to emphasize what is miscarriage, miscarriage is a clinical natural process. And what is abortion? It's a patient's choice to termination. So these are the clear terminologies. So we will not say inevitable abortion while reporting ultrasound. We will say products of conception in the process of miscarriage within the cervical canal. And in case of post-MTP patient, when you want to label it as a RPOCs or enhanced myometrial vascularity, that will be complications of abortion process for that matter. So clarity in terms of terminologies that we use for while reporting is very important. Now, in terms of a cervical pregnancy, the visualization of a gestational sac or a topoplastic mass below the level of internal cervical os. Now, it is identified by the insertion of uterine artery. As we know, it is closer to the internal os. It is usually classically described as an hourglass kind of a cervix with a absent cervical, absent sliding sign. So presence of a sliding sign, absence of a topoplastic activity is a cervical stage of miscarriage, but absence of a sliding sign with presence of a topoplastic activity and a peritroplastic flow in cervical region is cervical pregnancy. So we need to differentiate cervical pregnancy from sometimes polyp. If they degenerate, there may be few cystic areas within the cavity that should not be taken into that consideration. And between the internal os, the tropoplastic reaction, there is a definitive amount of cervical canal myometrium which is demonstrable in those conditions. So we need to clearly differentiate cervical pregnancy from caesarean scar pregnancy, from polyp and the cervical stage of miscarriage. Now coming down to cervical pregnancy complications, bleeding due to severe uterine artery rupture can occur in such patients, or on many instances, you will find that they present with a hemoperitoneum, and it is very difficult to comment whether the pregnancy was there previously in the cervical age or not. So extreme complications of cervical pregnancy are quite known. Embolization and hysterectomy with uterine artery ligation are the common techniques probably which are used. Now this is classical cervical pregnancy. You can see, I can make out the internal os which was proximal to this area. I can see the remaining portion of the endocervical canal very well. I can also document about the good amount of myometrial stripe which is anterior superior to this lesion. This is a classical, what is called as a cervical pregnancy. Here again, peritroplastic activity was quite nicely demonstrated and the sliding sign was negative. So it is a classically cervical pregnancy. Now coming down to lower segment scars, it is very important whenever there is a low implantation sac, we should train ourselves to identify how does the normal lower segment scars they look like. Now here you can identify very well. Can you see this scar over here? Now, these are multiple other features also in terms of adenomyosis and endometrioma, but we need to train ourselves to identify single uterine scar, two uterine scars or multiple uterine scar more than two in a normal non-pregnant status, because that only will enable us to demonstrate when there is a low implantation sac, what is the relation of low implanted sac with the previous multiple scars. So this is how the various scars they look like. On the left side, you can see there are only two scars. Here you can appreciate only two scars, but here you can appreciate three hypoechoic stripes which are extending from the seroidal surface more towards the internal os region. So these are the three scars. This is different, but here you can appreciate three hypoechoic lines. Here you can appreciate two hypoechoic lines. So two scar, three scar, or multiple scar for that matter. There are various morphologies which are described in the literature, which are starting from just indentation from the seroidal surface up to a teardrop sign where an anechoic area will be seen as if it is a, what you can say, at the level of internal os or just proximal to internal os, which is nothing but a classical lower segment scars. So identifying normal lower uterine scars, single or multiple, is very, very important. Now coming to cesarean scar pregnancy, it can be partially or fully embedded into the scar area. As the number of sections goes on increasing, again the probability of low implantation along with cesarean scar pregnancy is very high. Again, it is a common precursor for presence or absence of a morbidity adherent placenta in due course of time. What are the ultrasound features that you can expect in case of a cesarean scar pregnancy scar? Is an empty uterine cavity, empty cervical canal. There is a gestational sac or a topoplastic sac embedded in the lower segment cesarean scar with a heterogeneous irregular thinned out myometrial stripe, which is ranging between 1 to 3 millimeter. When it is 5 or more, still the pregnancy can continue and get converted into morbidly adherent placenta. Again, the sliding sign will be negative. So gestational sac that fills the niche of the scar completely with or without presence of a fetal pole and negative sliding style also favors cesarean scar pregnancy. So these all criteria, if they fulfill, particularly thinning of the myometrial stripe anterior superior to the scar area over there, will fit into that. So there are two types of cesarean scar pregnancy, what is endogenous and exogenous. In terms of endogenous, the implantation on the scar with growth more towards the uterine cavity. And if it is exogenous, it is deeply embedded into the scar with growth more towards the bladder area. When it is endogenous, means going towards the uterine cavity. Exogenous means more going towards the, so thinning, absent, heterogeneity and irregularity of a mass effect, which is extending into the bladder area, that is the area where we are more worried about. Now, for years together, we used to diagnose cesarean scar pregnancy by using 2D mode, but the MPR and 3D modes, they are helping us a lot in terms of a diagnosis. So 3D will show ballooning of the cervicoischemic region with a normal appearing cervical canal over there. The multiplanar imaging will show deficient anterior myometrial at the uterocervical isthmus, and which becomes, our job becomes more easy. In terms of grading, we have seen that if the sac is embedded less than 50% of the myometrium, it is called grade 1. And as the amount of myometrial embedment by the cesarean scar pregnancy goes on increasing, the grade goes on increasing. So where there is a bulge out of the myometrium and involving the serosa is grade 3. And there is amorphous tumor-like mass with a rich vascularity, definitely it is a higher grade. And in those patients, probably MRI can be a problem solving tool, but more or less ultrasound gives a very, very good significant positive findings. So here the sac is well placed upper in the cavity. As it is, it could be brushing the lower segment cesarean scar, it could be involving partly, or it could be completely involving the niche of the cesarean scar. So as it is completely involving, the likely likely complication of such disease is quite more. Now let us take one case. Now can you appreciate here, there is a well-formed gestational sac along with the fetal pole, and yolk sac is well appreciated, where the complete pregnancy is embedded into the niche of the scar per se. We are not able to demonstrate any kind of a myometrial stripe anterior-superior to the chorionic tissue over there. Now, what we did in this patient was we did an intervention by using transvaginal guided needle. So we have put in needle into that sac, we aspirated that, and we introduced methotrexate into that. So initial step is to aspirate, but little amount of anechoic fluid adjoining to that needle is mandatory. And later on, you can introduce the methotrexate into that and just observe that. Now here you can appreciate little bit of nibbling will destroy the gestational sac along with yolk sac over there. And again, the methotrexate will, if you do a little bit of nibbling, the absorption of methotrexate locally from that area also will be good. So if there is a decrease in the beta HCG value by 15%, then definitely the satisfactory result is achieved. And then frequently, then you can follow the beta HCG level every weekly till it becomes to the normalcy. Now let us assume that between day 4 to day 7, after giving intra-sac methotrexate, if the values doesn't fall by 15%, then you can give an additional intramuscular methotrexate with 15 milligram per surface body area, and just again evaluate once again between after that injection between 4 to 7 days and look for reduction in the beta HCG value by 15%. If that occurs, then probably your net result is achieved. But if there is a plateau or subsequent increase in the value of beta HCG or further bleeding complication in terms of a pain or bleeding into the adjoining structures as well as POD, then probably we'll feel that our intervention in terms of methotrexate for this cesarean scar pregnancy is failed. And under those circumstances, all those pregnancy will be treated depending upon the clinical condition of the patient. So this is another case. Here you can see here the gestational sac was little bit more advanced with the tropoblastic activity. We have done the MTS intervention to this patient, and eventually later on you can see that there is a little amount of heterogeneity involving the scar area which will be seen, or in many instances if there is a lot of vascularity which it takes more time to reside. So initially up to 6 weeks of period, those area will behave like an enhanced myometrial vascularity which may persist. And always remember telling to the patient that with initial intervention of MTX needle, probably the beta HCG will increase a bit and then it will start deteriorating fast. So explaining the patient that initial rise of beta HCG after first intervention may not be that important for us. So there is one more technique which has been expressed in the literature, that is using 12 French or 14 French silicone balloon typical Foley's that we use, where if the sac size is small and doesn't have a fetal pole with activity, the chorionic reaction is less. In all the circumstances, you can inflate that balloon in the cervical region. This also has been used for cervical ectopic pregnancies as well. So cesarean scar pregnancies where the anterior myometrial stripe is well appreciated and we are not, where the serosal surface or the bladder is not involved and the sac size is less, we can use this technique, and we have done for one patient. And then you keep it for 3 days. After keeping it for 3 days, then you can remove it, and because of the sclerosis in that region, that complete area will get necrosed. There will be bleeding persistently over a period of 1 week or so. After that, this patient belongs to Dr. Prashant Dingole, and we did this, I think, 2 to 3 years back. So this one more technique has been mentioned in the literature, but still the more popular nowadays is methotrexate injection along with intramuscular systemic methotrexate if at all it is required. As I have stated earlier, there are many patients in whom if you treat with methotrexate and still you can see such kind of a having higher levels of beta HCG, it was a plateau and eventually landed with total hysterectomy. And on hysterectomy, we proved that it was nothing but a scar pregnancy involving the anterior lower segment. Now, just to wind up with the precursor of morbidly adherent placenta, we need to understand all the complications related to low implantation are also associated with, say, areas like advanced maternal age, multiparity, multiple myomectomy, scars over the year, history of previa. So all these will lead to what is condition which is called the morbidly adherent placenta. Again, low implantation by definition means less than 5 centimeter, and it is more deviated toward the scar, that is particularly the sac which is over there. Now we have seen already about the crossover sign. I will just once again mention the same. The line, that is a sagittal line from the fundus to the external os, which is going to the internal os and the sac region. And again, if it is 2/3 above the sagittal line, the other line, that is the superior inferior line within the gestational sac, which is perpendicular to this sagittal line. If it is more than 2/3 above the sagittal line, it is a poor prognosis, and if it is less than that, the prognosis can be good. So this is, so in terms of moderately adherent placenta or a PAS or placenta accreta spectrum as it is called, what are the markers which should raise an alarm in your mind? That is low implantation in first trimester, inhomogeneous placenta, particularly in case of a second trimester malformation scan, presence of irregular placental interface between placenta and myometrium, placental holes, lacunae, or what, they are not typical placental legs that we get, but when you get a buttonhole kind of appearance within the inhomogeneous placental substance, and the patient already have previous multiple scar and low implantation scar in early pregnancy, that should raise your suspicion of PAS in those individuals. Myometrial thinning, bulging of placental tissue into the bladder, and a chaotic verticular branching kind of vascularity from the mass into the bladder. Again, this is higher grade of, that is what we call the placenta increta or percreta. So whenever we document low implantation in early pregnancy, we need to monitor for inhomogeneous placenta in second trimester, and in third trimester, just look closely for the placental holes or inhomogeneity between the retroplacental halo and the myometrial substance. Now this is classical placental holes, and here you can see there is a inhomogeneity in the placenta. The serosal, that is a retroplacental halo, is completely lost. There is a thinning or irregularity involving the bladder serosa over there, and not only that, you can see multiple speculations from the placental substance reaching up to that area. So what is mean by placental holes or lacunae are the anechoic spaces within the placenta surrounded by the placental tissue from all ends, and usually they are equal to 5 millimeter or more than 5 millimeter. They should be clearly distinct. Normal placental legs needs to be clearly distinctly separate from these individuals. Again, rather than primarily labeling placental holes or buttons in third trimester, always look for previous history, previous low implantation sac in earlier pregnancy, or inhomogeneous comment as far as second trimester malformation scan. Now this is classically placenta increta, where there is a lot of complete loss of myometrial stripe and mass-like appearance entering into the bladder area. Here you can appreciate a lot of lobularity. Still there is a serosal surface outline is maintained, but it is interrupted one. In terms of vascularity, when you within the placental substance, which is extending into the myometrial stripe, and when it is increta, you will find that this is also extending beyond the surface of serosa of the bladder into the bladder lumen. So this vascularity, if it is parallel, don't worry about the same. When it is perpendicular, the placental substance branching and entering into the myometrial stripe and serosa of the bladder, then we are worried more for that. So these all are the ultrasound suspicious criteria for increta or morbid bladder. What are they? Heterogeneous placental ecotexture, irregular placental holes, loss of retroplacental hypoechoic halo, which is a feature of normalcy, thinning of adjoining myometrial strip, absence of decidua or a serosal bright line That is a surface, there is an interface between the uterus and the bladder. So this bright line of hyperechogenicity will be absent in many individuals. And in later cases, it will be bulge of placenta into the bladder, branching vascularity, which is invasive type. So what are the steps that we have followed whenever it's a low implantation type? So we have seen with eyeball technique stating that the upper part of the endometrial cavity is empty. It is not showing any features of gestational sac. The sac is in the lower part. So then look for any history of scars or placental abnormality in this pregnancy or previous pregnancy. And then we measure the distance. When we measure the distance, if it is less than 5 centimeters from the external os, then we are sure that it's a low implantation sac. As soon as that we look for what is sliding sign and crossover sign. Depending upon the sliding sign and crossover sign, we follow the algorithm which we have discussed already. The sliding sign is positive. There is absence of peritoplastic flow. We know that we are dealing with cervical stage of miscarriage, which could be an intact sac, which could be a collapsed sac, or some kind of products of conception within the cervical canal. If there is a presence of a peritoplastic show and the sliding sign is negative, then I need to consider about 3 options. That is gestational sac in the myometrium of the cervical region, which we call it as a cervical pregnancy, where the sliding sign will be negative. Then gestational sac with a deficit myometrium between 1 to 3 millimeter with previous history of multiple scars. Think of cesarean scar pregnancy. And when it is 5 millimeter or more than 5 millimeter and the gestational sac is at the cervico-isthmic junction, then apply the COS criteria, draw 2 lines in the sagittal plane on transabdominal scan. If it is more than 2/3 or less than 2/3, depending upon that, you follow those patients meticulously for suspicious moderately adherent placenta or PAS in 2nd trimester and 3rd trimester. In 2nd trimester, comment regarding inhomogeneity of the placenta, which needs to be commented. And in 3rd trimester, look for the aggressive signs of morbidly adherent placenta in terms of loss of retroplacental halo involving the serosa, branching vascularity, which is extending from the morbidly adherent placenta into the myometrium and the serosal surface. So this is how. So the important point to remember is all cervico-isthmic implantation that do not fulfill into the criteria of cervical pregnancy or cesarean scar pregnancy with anterior myometrial thickness deficit, which is greater than 5 millimeter, needs to be followed. If it is continued pregnancy, then possibility for a morbidly adherent pattern. So I have already mentioned, you can take a picture of the same and you can follow this article. It's a wonderful article giving a typical mathematical approach to low implantation sac. Thank you very much. You can put any questions if at all there to my email or maybe on the Twitter handle. If at all anything we want to discuss, we can discuss with the panel.
Thank you, sir, for the wonderful insight on the lower implantation sacs. So first, the take-home message is in the earlier, for our dating scan, we should be doing the transvaginal scan. Still, we see many times that the transabdominal scan has been done. So transvaginal scan during the dating scan is a must. And we can now, as a take-home message, start following simpler rules, which sir has told us about: the 5 centimeter length rule, the crossover sign, regarding the sliding sign. So we should start implementing these in our day-to-day practice, and will be useful to us as we see the increasing number of cesarean sections, scar pregnancies these days.
Thank you very much,
Any
sir.
questions from the audience?
The wonderful part whenever Dr. T.L.N. Parvil sir is with you is that you are never afraid of any questions from the audience as well as from the. So because you can just have a look at him and he can also realize that you are uncomfortable giving answer to the question. So immediately he will take over. So I will try to answer the question. If it is beyond my capacities, sir is here. Don't worry.
Thank you very much, sir. I request chairpersons Dr. Sadhna Deshmukh madam and Dr. Sumit Chamaria to felicitate our speakers. Ajit Gandhi sir. Thank you, chairpersons, to conduct this wonderful session. I request Dr. Zamre Madam to felicitate Dr. Sadhna Deshmukh Madam.
The organizing committee for people to give us an opportunity to chair the session. Thank you. Thank you so much.
Thank you, sir. I request Dr. Prajakta to conduct inauguration session.
I request our MOH, Dr. Basavaraj Lohare sir, to please join us on the dais. Sir is working in public health department since 2002. Sir is an MBBS DPH. He has worked as a superintendent in sub-district hospital, Panvel, and as an MOH at Panvel Corporation. And at present, he is a MOH of Solapur Corporation MOH, working here since last 5 months. I welcome you, sir, on the dais. Please come. I request our guest of honor for today, Dr. TLN Praveen sir, Dr. Aniruddha Kulkarni sir, Dr. Megha Kamlapurkar madam, and Dr. Ajit Gandhi sir to please take the seat on the dais. I request our SOGS President, Dr. Aboli Velankar Madam, and our Secretary, Dr. Archana Shah Madam, to please accompany our guest and take a seat on the dais. Light is considered as a symbol of prosperity, auspiciousness, and abundance. Light brings brightness with it and dispels the darkness. So I request all the dignitaries on the dais to please come forward for the Deepa Prajwalan, the auspicious lamp lighting ceremony. you all the dignitaries from the bottom of my heart. Now I request our President of SOGS, Dr. Aboli Velankar Madam, to say a few words.
Good morning, everyone. Respected teachers, seniors, honorary guests, and friends. And our chief guest, Dr. Lohare today. Today, I feel very much privileged to be here on the dais to speak a few words as the president of our prestigious Obstetric and Gynec Society. Our society has always been active, enthusiastic, helping, and a happy society. It is just like a family to all of us. The previous presidents and the office bearers always did a great job each year, and the bonding and the growth of our society has reached a great height. I feel very much motivated and responsible for keeping up the pace of the activities of our society. In the present year, we have all gone through tough times due to COVID. The journey from seminars to webinars was a challenging one. In the beginning, there was lockdown and there were webinars, then hybrid meetings, and then physical ones. Arranging, postponing, rearranging, canceling, we have experienced everything. The topics chosen today may seem to be common, but considering their importance, there is always the need to update them. Updates are necessary to keep us all performing at the best, and many of us feel more confident and secure about it. Each topic has been modulated accordingly for the benefit of all of us. Today we have with us renowned speakers who are working practically in the fields and on ground levels and have a lot of work experiences. We are very much delighted to hear from them and hope this conference enlightens all of us, and we may have many more such activities. I thank all the audience to attend in large numbers, and I hope that you will be with us hereforth. Thank you.
I request our MOH, Dr. Lohare sir, to please say a few words.
गुड मॉर्निंग टू ऑल. आज खरं तर मला वेलणकर मॅडमने फोन केला की आपली CME आहे, तर मी आपल्याशी संवाद साधण्यासाठी खास आज आलेलो आहे. आपल्याला माहितीच आहे की बऱ्याचशा गोष्टी आपल्याला माहिती आहेत, पण त्या गोष्टी रिवाइज करणे आणि थोडंसं रिफ्रेश करणं गरजेचं आहे असं मला वाटलं, म्हणून मी एक 5 मिनिटं आपला वेळ घेईन. आता सध्या आपल्याकडे शहरामध्ये धडक मोहीम चालू आहे. इन्स्पेक्शन आमचे डॉक्टर्स येऊन करतायत, पण त्यामध्ये मी पण ज्यावेळेस गेलो 5-6 सेंटरला व्हिजिट केली, त्यानंतर बऱ्याचशा त्रुटी आढळून आल्या ज्या की डॉक्टरांना माहितीच नाहीत. असं होतं की असं वाटतं की माहिती नाही का मुद्दाम करतायत, असं व्हायला नकोय. आणि इट इज नॉट एक्सपेक्टेड फ्रॉम the educated persons. Such mistakes are not acceptable. अशा काही मिस्टेक आहेत ते मी एन्युमरेट करतो की ज्या इट इज क्वाइट अनएक्सेप्टेबल मिस्टेक्स आय हॅव सीन आफ्टर इन्स्पेक्शन ऑफ द सम sonography center, which is very serious and it has to be taken very seriously. But on lighter mode, I have just informed them you don't do such mistakes again. I will enumerate that mistakes. First is the machine is kept without any board display. No certificate has been displayed. Nothing is there. Only machine is they are using the machine. Such kind of practices are happening in some hospitals. I have informed them, don't do such activities. The second thing is people are filling the F form, but not signing the report. They have not signed the F form. For how long? 5 months, 6 months. They have not signed a single F form. It is very serious offense. An incomplete F form is also taken as an offense, and in PCPNDT Act, there is no minor and major offense. All offenses are considered as an offense. It has been treated equally. There is no administrative or other offenses. Such separation has not been done yet. Other thing is that I have noticed some people are using the machines in portable mode, which is very serious. It has been stopped year back. And they are also asking me how we can use the 2D echo machines if we are having a serious baby, all the things. If such provision is available in PCPNDT Act, then I will give a permission to you. But after the amendment, portable mode of sonography has been stopped.
There is some audio issue. We are just rectifying. There is internet issue at the hotel. So
And it is
just
very
give us
difficult. We are also short of manpower. A registration certificate, which has been issued to you in duplicate. One has to be displayed at the reception area, another at the where the machine has been kept. But in institute, they have to take a color Xerox or either a normal Xerox, and they have to display where is the machine has been kept. If they are having multiple machines, more than 2 machines, 8, 10 machines, so they have to take a Xerox of that certificate and display there. And the person who is doing the sonography, who has been mentioned on that certificate, they are only authorized to handle that machine. No other person can handle that machine. If he is a sonologist, gynecologist, and he came there and he is using the machine, he has not been on that certificate name, and he is using that machine, then it is illegal, it is a breach of PCPNDT Act. That time you can say, डॉक्टर लगेच विचारतात, आपल्याला बुद्धिजीवी लोकांना जास्त प्रश्न पडतात. असं होतं की ते म्हणतात की आम्ही आता पेशंट बघतोय, हे करतोय. यू टेक एक्स्ट्रा नेम्स, यू पुट एक्स्ट्रा नेम्स, नो इश्यू. आपल्याला असं वाटतंय की आपल्याला ह्या डॉक्टरांची नावं कमी पडतील, डॉक्टर बाहेर जातील, तर तुम्ही 10-12 डॉक्टरांची नावं टाका, काही प्रॉब्लेम नाही. यू टेक अ कन्सेंट, यू टेक अ अफिडेविट, सबमिट दॅट, विल गिव्ह अ परमिशन, नो इश्यू. बट डोंट allow to use unauthorized person. One thing. Then apply for renewal at least 1 month prior of expiry of registration. Then carry out procedure only by doctor whose name has been written in Form B. Then conduct procedure only at an approved place. आता जे place approved नाही आहे, तुम्ही जर प्लेस चेंज करणार असाल तर यू हॅव टू टेक द परमिशन. देन अदर थिंग विच आय हॅव सीन इन इन्स्पेक्शन that some doctors are sending the machine to the for repairs without taking permission of appropriate authority, that person also taking the machine for repair, which I have seen only in Solapur city. It is not like that. You have to take a permission of appropriate authority while handing over your machine, which has been mentioned on the certificate. It has to be, you have to take a permission, and the person who is taking a machine for the repair, he also submit his PCPNDT registration certificate. He has to apply to appropriate authority. He has to take a permission, then he can repair the machine. After repairing machine, he can give to that doctors. But without intimation, if you are handing over the machine to repair, then it is also a violation of the act. Then you will be punished under PCPNDT Act. Then previously it is like that ki एक डॉक्टर दुसऱ्या डॉक्टरला सोनोग्राफी मशीन विकू शकत नव्हता. पण आता ऍक्ट मध्ये अमेंडमेंट झाल्यानंतर आपण डॉक्टरांमध्ये मशीन विकू शकतो. पण विकताना त्यासाठी तुम्हाला MOU करावा लागतो, एक ऍफिडेविट करावं लागतं. म्हणजे लिहून देणार, लिहून घेणार, आणि जे डॉक्टर विकत घेत आहेत त्यांची सही आणि ज्यांनी विकतायत त्यांची सही लागते. त्यानंतर ते ऍप्लिकेशन तुम्ही सबमिट केल्यानंतर आम्ही परमिशन देतो and it is valid, so you can sell the machine, or either you can send to the refibrisher आहे किंवा कुणाला सेल करताय, कंपनीला बायबॅक करताय, त्यासाठी देखील तुम्हाला परमिशन घ्यावं लागते. नंतर दुसरी गोष्ट अशी लक्षात आली की काही ठिकाणी आम्ही MRC नंबर दिले होते, पण MRC नंबर लावले होते पण नंतर ते खोडून टाकले कोणीतरी, आणि त्यांना MRC नंबर ही माहिती नव्हती आणि स्क्रॅच केले होते ते नंबर. तर असं करू नका. स्क्रॅच झाले तर आमच्याकडे त्याची लिस्ट असते, तुम्ही तुमच्या मशीनचा जो नंबर आहे MRC तो लिहून घ्या, परत तो स्टिकर बनवून त्याला चिटकवा. नाहीतर कोण स्क्रॅच केलं त्या ह्याच्यात तुम्हाला शोध घेता येणार नाही, तुम्ही नसताना कुणीतर केलेलं असेल. पण ज्यावेळेस मशीनवर MRC नंबर नाही तर लगेच तुम्हाला अप्रोप्रिएट अथॉरिटीला कॉन्टॅक्ट करून तो MRC नंबर घ्यायचा आणि त्या मशीनला लावायचा आहे. नंतर फॉर्म सर्व भरायचे आहेत, भरून ते व्यवस्थित जतन करून ठेवायचे आहेत. मेंटेन द रजिस्टर, 5 column रजिस्टर ऍज पर रूल 9(1). नेम ऑफ द वुमन, सिरियल नंबर, नेम ऑफ वुमन, कंप्लीट ऍड्रेस, नेम ऑफ स्पाउस, फादर अँड डेट ऑफ द प्रोसिजर. नंतर दुसरी गोष्ट आहे, ज्यावेळेस तुम्ही रेकॉर्ड मेंटेन ठेवता, रेकॉर्ड ठेवताना तुमच्याकडे रेफरल स्लिप पाहिजे, एकतर सेल्फ रेफरल किंवा दुसऱ्या डॉक्टरने पाठवलेलं. नंतर तुम्हाला हार्ड कॉपी मध्ये त्याचं प्रिंटआउट काढून ठेवायचे आहे. नंतर थर्मल प्रिंट काढून ठेवायची आहे. आणि जे फॉर्म आहे त्याचं तर तुमचं रजिस्टर असतं, आणि कन्सेंट, या गोष्टी सर्व प्रिझर्व करून ठेवायच्या असतात. कारण उद्या चालून काहीतरी असे कॉम्प्लिकेशन होतात, कुणीतरी तक्रार करतं, आम्हालाही माहिती मागतं, तुमच्याकडेही कधी कधी अशा तक्रारी येतात. तर असं काय व्हायला नको, त्यामुळे रेकॉर्ड व्यवस्थित पाहिजे. आणि टाइमली सबमिशन ऑफ रिपोर्ट इज मस्ट. प्रिझर्व रेकॉर्ड फॉर 2 years, and if any case is going on in court till it disposed of. हे रेकॉर्ड तुम्हाला 2 वर्षापर्यंत ठेवायचंय, पण जर केस जर फाईल झाली असेल एखाद्या केस मध्ये तर ती केस डिस्पोज ऑफ होईपर्यंत त्याचा रेकॉर्ड प्रिझर्व ठेवायचा. नंतर तुमचे बोर्ड आहे ते इंग्लिश आणि मराठीमध्ये पाहिजे, बाहेर पण पाहिजे रिसेप्शनच्या तिथं, आणि जिथं सोनोग्राफी मशीन आहे तिथं पण. नंतर जर तुमचं समजा ओनरशिप चेंज झाली, एखादं हॉस्पिटल बंद झालं, तर तुम्ही ते सर्टिफिकेट ट्रान्सफरेबल नाहीये. You have to surrender that certificate to the appropriate authority. The person who is taking over, he has to apply fresh. Then write a name and designation of person performing procedure under his/her signature, and write the date of procedure also. Keep all records, D, E, F forms as applicable. G forms if invasive procedure is there. Sonography plates, referral slip. Do provide record for inspection to appropriate authority or a person authorized. Ask copy of inspection report to appropriate authority after inspection is over. Do make appeal to state appropriate authority under Rule 19(2) if agreed by decision of district or corporation appropriate authority. Then these all are the points which you have to follow, because I have seen so many cases that they are not maintaining the records, and that's why, because of lack of records or not proper records, the cases has been filed. So be careful and follow all the rules. Thank you for calling me, and thank you all.
Thank you, Lohare sir. I request Aboli Velankar madam to please felicitate our MOH. Thank you, madam. Thank you all the dignitaries on the dais. We move on to our second session. I request Dr. Ashwini Pawar madam and Dr. Priyanka Kade to take over.
Thank you, Prajakta. We are starting with second session. Chairperson for our next session is Dr. Rohini Deshpande. She is consultant obstetrician and gynecologist in Solapur since last 28 years. She is having main interest in imaging in obstetrics and gynecology, endoscopic surgery for infertility, perinatology, adolescent medicine. She has contributed chapters in various books. She has presented lectures, papers at various conferences. She is president of MOX 2018 to 2020. She was the past president of Solapur Obstetric and Gynec Society. She was organizing secretary of AICC RCOG and organizing secretary of 17th IMOX conference. She is having very active academic and academic career. Welcome, Rohini madam.
I asked Dr. Vaibhav Meru sir to come under us. He is a radiologist, chairperson. Dr. Vaibhav Meru sir, he is a radiologist. He has a work experience last 22 years in field of radiodiagnosis and specifically in ultrasound, digital X-ray, CT, MRI, mammography. His qualifications are MBBS from Amravati and DMRD from Belgaum. And he is a FM operator for anti-scan, Doppler study, preeclampsia and cervical lens assessment. And
It's there.
professional work experience. He is owner, director, and consultant at Prism Diagnostic Center, Solapur, with CT scan, digital X-ray, and sonography. MRI training under Dr. Meher and Dr. Inde Talwar in Bombay Hospital. Worked as a MRI consultant at SP Institute Neuroscience, Solapur, and working there, and work as a lecturer in Department of Radiodiagnostic in GN Medical College, Belgaum. Welcome, Dr. Meru.
We hand over mic to chairperson. Thank you.
Hello.
What did you press?
Hello.
Volume.
Good morning, everyone. Welcome back to the second session. My job is to introduce Dr. TLN Praveen sir, which is, I suppose, it's an opportunity for me because he's such a towering person in the field of radiology and imaging.
Hello.
I will give it short introduction. He is not new to the Solapur medical fraternity. He is visiting Solapur since 2017. He's briefed us about various topics on ultrasound. He's been here for a couple of times. We know him all.
Yeah.
Actually, he's he works
Yeah, I know.
as a director to the Abhishek Institute of Imageology, Hyderabad. He is passionate about the fetal medicine, working in fetal medicine last for 35 years. His passion for looking in the fetus and performing invasive procedure.
Dr. Meru,
Yeah.
can I make use of this time for my lecture?
Oh, thank you, sir. Please go ahead.
Thank you.
Oh, sir.
Because your biodata is endless.
Endless.
Where is it? It's not good. Yeah. Yeah.
Okay. Shall I go? Yeah. Good afternoon. And before I start, I would like to really thank the SOCs for giving me this opportunity, all the office bearers. And most important thing is that I'm sorry, I didn't realize. Most important thing is one of the major attractions for me to come to Solapur is Aniruddha. I always enjoy his company, and he's a great brainstormer. He gives a lot of ideas, and that makes me work and go ahead. Now, today, one of the important topics that we are going to talk to you about is the ectopic pregnancies. As we all know, it's one of the terrible clinical situation that all of us will get into, and which definitely needs a complete holistic approach in evaluation, diagnosis, as well as the management of these ectopic pregnancies. So keeping this in mind, let us first start off with the definition of ectopic, because quite often we have to be very clear what we really call it as an ectopic pregnancy. The most important thing is that the implantation of the embryo, if it happens outside the endometrium, then only you call it as an ectopic pregnancy, as we all know that one. That is the definition which has been proposed by the ACOG. Then what is the holistic approach which we are going to take? We need to understand the clinical presentation. We need to understand the biochemical parameters which we are going to take into consideration in evaluating this, and at the same time the ultrasound features and management strategies that are available with us. The reason why we need to know all these things is, as we all know, diagnosing an ectopic pregnancy is definitely associated with a lot of apprehension to the patient, to the clinician, to the imageologist. At the same time, unless we have a holistic picture about the whole of the total scenario, clinical scenario, it becomes very difficult for us to come to a conclusion as far as the ectopic pregnancy is concerned. That is the reason why we need to have an holistic approach. Now, we all know that there are classically clinical triad, which is called as the period of amenorrhea, lower abdominal pain or cramping, as well as the spotting or vaginal bleeding. And associated with it, whenever there is the pregnancy test or the urine pregnancy test comes positive, you need to demonstrate the gestation cycle in the uterine cavity. And then if you don't demonstrate, then you start thinking in terms of a possible ectopic location of the gestational sac. Now, this sort of a presentation, clinical presentation, can be seen in various other conditions like early pregnancy. Maybe the implantation that is the pre-implantation, where you may not have been able to make out the gestation cycle within the uterine cavity. Then also patients will come and present to you with lower abdominal pain, some amount of implantation bleed, as well as period of amenorrhea. And then there can be a failing intrauterine pregnancy. That is, it could be a product of conception. And at the same time, it can be a PUL, pregnancy of unknown location. It could be a persistent PUL, or it could be a failing PUL. All these conditions also will have a similar clinical presentation. And of course, most important thing, ectopic also has to be kept in mind. Now, we need to know a little bit about the hormonal evaluation. Particularly, the present scenario is that most of the women, when they miss their period, the first thing they do is to get a urine test done at home. Once the urine test comes positive, We all know that the urine test comes positive because it starts detecting the HCG levels by about 7 to 8 days of post-conception. But then negative pregnancy test, urine pregnancy test, does not rule out intrauterine or extrauterine extrauterine pregnancy. So that is one thing which we have to keep in mind. That is the reason why we started using the hormonal assay, particularly the serum beta HCG titers. Now, when we take the serum beta HCG titers, it's, as we all know, it's a chemical test, first and foremost thing, and it actually looks for the beta subunit of the human chorionic gonadotropin, and it is usually detected from 11 days after the conception. That is one. Second is, when is the pregnancy test confirmed? When the beta HCG titers are more than 25 international units per liter, then only you will start thinking in terms of a possible pregnancy test. So whenever it is the beta HCG titers are less than 25 international units, then you need to be suspicious but not a confirmatory of a pregnancy, whether it is intrauterine or extrauterine. Now, can the serum beta HCG tell us the location of the pregnancy? No, it cannot tell the location of the pregnancy, because it only tells that there is a pregnancy because it is what is being secreted by the trophoblastic tissue. It only tells that there is a active trophoblastic tissue, beyond which it cannot tell the location of the pregnancy. Now, there are certain things that have been designed in the form of what is called as the discriminatory zone. What is this discriminatory zone? We all know that whenever the beta HCG titers are between 1,000 to 3,500 international units per liter, if the gestation sac is not demonstrated on transvaginal examination within the uterine cavity, we need to think in terms of a possible ectopic location. That was the teaching which we all have undergone. But the recent bulletin being published by the ECOG very clearly says that no more we are going to follow this discriminatory zone. The reason is that there are umpteen number of papers that have been published stating that the gestational sac could be demonstrated as early as 800 international units per liter. Not only that, the gestational sac could not be demonstrated even at about 3,500 international units of, per liter. So keeping this in mind, the relevance of discriminatory zone in identifying an ectopic pregnancy has gone out of vogue. That is one important point, that message that you need to carry out. Now, the second important thing is what is called as the doubling time. We all know that whenever there is an intrauterine gestation, there will be doubling. That is the reason why we start doing what is called as the 0-hour and 48-hour beta HCG titers. Whenever we do a 48 hours beta HCG titers, we expect it to double the 0 hours beta HCG titers. Actually, to be very appropriate, it should be about 66%, not the double, that is not the 50%, but it is 66%. But then there are recent papers that have been published which say that the raise or the doubling or the raise in the beta HCG titers depends on the initial beta HCG level. That is, at 0 hours, if it is, let us say, it is about 1,500 or less than 1,500, the doubling occurs about 49% in 48 hours. Whereas if you have the initial beta HCG is 3,500, the raise is not that much. It is only about, let us say, it is about 33% only. So again, this doubling time cannot be taken into consideration as far as deciding the location of the gestation sac is concerned. So that again is not a very useful tool. The only tool that has been of some use is the decline in the beta HCG titers. If there is a decline by about 13% in the beta HCG titers, we know that there is a pregnancy. We don't know the location of the pregnancy, but one thing we know is that it is a failing pregnancy. At least that way we are much more sure. So that to that extent, the beta HCG titers are going to help us. Not only that, now we have what is called as the PVL protocols, wherein we try to use the progesterone along with it, so that in the first initial stages itself, you do a progesterone, and if the progesterone is more than 20 nanograms, we know that it's a viable pregnancy, and if it is less than that, we know that it's non-viable pregnancy. That itself will prove that either it is a failing pregnancy, intrauterine pregnancy, or a failing extrauterine pregnancy, or a failing PUL, right? So this is the basic concept that we need to carry as far as the biochemistry is concerned. Now, coming to the ultrasound and identification of ectopic pregnancy. Before we go into evaluating the ectopic pregnancies, we need to define what exactly is intrauterine pregnancy. As I said, whenever you have a gestation sac within the uterine cavity, that is within the endometrium, you call it as normal intrauterine pregnancy. And the endometrium, as we all know, is basically between the interstitial tubes, that is the intercornal region to the internal os, is the endometrial lining of the uterine cavity, and the gestational sac should be implanted within the endometrial cavity. That means that whenever there is a breach in the endomyometric junction, then you think in terms of an ectopic pregnancy. So the basic criteria that is required in order to label a pregnancy as an ectopic pregnancy on ultrasound is whenever there is a breach in the endomyometrial junction. Without the breach in the endomyometric junction, you should not label it as an ectopic pregnancy. Right. Now, so we have an ultrasound examination and we have the positive pregnancy test. There are 5 clinical scenarios that you are going to get into. One is that it could be a definite intrauterine pregnancy, where you can demonstrate a gestation sac, fetal node, yolk sac, cardiac activity within the uterine cavity. That is one. Second is the probable intrauterine pregnancy, where you have a pre-pregnancy hyperplasia or thickening of the endometrium, it shows that there is a priming up of the endometrium. Along with it, you may find a gestational sac-like looking structure within the primed up endometrium, which also is a possibility that it could be because of a probable intrauterine pregnancy. That is 2. 3, a definite ectopic pregnancy, where you can definitely demonstrate a gestational sac, fetal node, and the yolk sac or the cardiac activity outside the uterine cavity, which is the third possibility. Fourth possibility is that there is an inhomogeneous mass in the adnexal region, extra-uterine, extra-ovarian, which could be a probable ectopic pregnancy. And the fifth one is PUL, where you cannot demonstrate the gestation sac either in the uterine cavity or extra-uterine location, or there is no products of conception within the uterine cavity, then you label it as a PUL. So these are the 5 clinical scenarios that we come across whenever we find ultrasound examination plus the positive pregnancy test. Now, how do we classify them? There are various methods by which you can classify ectopic pregnancies. You can say usual, unusual, intrauterine, uterine, extrauterine, as well as tubal and non-tubal heterotropic pregnancies. All these things based on the location, you can classify them. So these are the various things. You take the extrauterine, I just show you the images. I'll take you through each one of them, and I'll give you a detailed explanation for each one of them. Now, we know that there are various ectopic pregnancies, and 95% of them are tubal ectopic pregnancies. So we will start off with the tubal ectopic pregnancies. First and foremost thing is, as far as the tubal ectopic pregnancies is concerned, not only that, any ectopic pregnancy for that matter of fact, the management strategies that are available with us is the expectant management, or we have a conservative management in the form of systemic methotrexate or an intrasac methotrexate, minimally invasive methotrexate, intrasac methotrexate, as well as the surgical management, that is the laparoscopy or laparotomy. So these are the various management strategies that are available with us. Now, after thinking about these things, let us get into extrauterine ectopic pregnancy, the commonest being the tubal ectopic pregnancy, which accounts to almost about 95% of the cases, in which quite often the uterine size will be normal or slightly enlarged. There will be increased thickness of the endometrium, basically because of the decidual reaction. It is very difficult to differentiate between an endometrial hyperplasia, different decidual reaction, as well as the pre-pregnancy hyperplasia. So just because of that, you cannot say. Only thing is, sometimes you do find what are called as pseudo-sac or a pseudocyst formation within. You can see this pseudocyst formation within the uterine cavity, which may prompt you to think in terms of a possible decidual reaction. Now, the other situation is that there will be a pseudosac formation within the cavity. As you can see here, you can see an ectopic pregnancy outside the uterus, and also you see a sac within the uterus. Here, you should not confuse this with a heterotopic pregnancy, because this is one of the features which you have to keep in mind while dealing with the tubal ectopic pregnancy. Next is the presence of hemoperitoneum, where you can see the free fluid in the Douglas pouch as well as the Morrison's pouch, plus at the same time presence of a gestational sac with the fetal node, extra-uterine, extra-ovarian gestational sac. And if you do a 3D rendering, you can beautifully demonstrate the tube, the femoral end, you have the gestational sac. So this is how we are going to, but then I don't say that 3D is required. There is no need to do a 3D at all. Only thing is, it's for your confirmation, or at the same time for your increased confidence level, you can do if it is required. Now, whenever we have this one, let us come to the application of Doppler in tubal ectopic pregnancy. Doppler has really no role to play as far as the confirmation or diagnosing of an ectopic pregnancy. Basically, we all know that whenever we have a wrong notion stating that ring on fire appearance is a feature of ectopic pregnancy. No. If you take the statistics into consideration, the ring on fire appearance is much more commoner in a corpus luteal cyst than an ectopic pregnancy. The commonest feature or the commonest Doppler feature which you come across is what is called as the chaotic appearance, or the sparse dispersing vascularity which you see in the non-homogeneous adnexal mass. So this is the classical Doppler feature that you find as far as the ectopic pregnancy is concerned. Now, there was a systematic review which was published in 2016, where they said that if you find an ultrasound examination, if you find an empty uterus, the positive predictive value of an ectopic pregnancy is only 62%. Whereas if you find an adnexal mass, the positive predictive value goes up to 83%. If you find, along with the adnexal mass, empty uterus and a free fluid in the Douglas pouch, your diagnosis will go up to 73%. But if you find the adnexal mass plus the fluid, and then your positive predictive value is 93%. So what we need to look for is an adnexal mass, which is usually non-homogeneous, plus minus presence of the fluid in the Douglas pouch, which is the one which is going to prompt you to think in terms of a possible tubal ectopic pregnancy. Now, this is the classical example, but then this accounts to only 20% of the cases. This sort of a classical gestational sac, fetal node, yolk sac, cardiac activity outside the uterus going to account only for 20% of the times. Whereas the commonest presentation is what is called as the blob sign. This is classical blob sign, where you can see the ovary, and there is a non-homogeneous adnexal mass. On color Doppler, you find that there is increased vascularity, and this has a positive predictive value of 95%. So this is what is the one which you are going to commonly look or find as far as the transvaginal examination is concerned. So this is what is very, very important in our day-to-day practice. The second important sign is what is called as the bagel sign, where you find this sort of a bagel-like structure, which you can see here, and you put the color Doppler on, you find that there will be skirting vessels, which is accounting only to about 20% with positive predictive value of 95%. So a classical gestational sac, fetal node, yolk sac, cardiac activity is only 20%. Bagel sign is only 20%, whereas the other part of it is basically because of the inhomogeneous vascular adnexal mass, extrauterine, extraovarian, is the one which is going to give you a positive predictive value of 95%. Now, how are we going to manage this? We all know the management is either the expected management, where suppose if the size of the sac is very small, at the same time, you don't find that the patient is absolutely stable. Now, the management strategy basically depends on the patient's condition. If the patient is unstable, if the patient is having severe pain, there is no reason why we need to do anything else. There is no reason to do a repeat ultrasound. There is no reason to do a beta hCG titers, straight away take her to laparoscopy. Two, if you have a patient who has an adnexal mass on ultrasound and you find that the patient is stable but has severe pain, in that situation, probably you may wait for a 48-hour beta hCG titers and repeat a transvaginal scan. Or the third one is the one where we are going to get into a picture, is that when you have a stable patient, adnexal mass, no pain, beta hCG titers shows that there is a raise in the beta hCG titers without a proper gestational sac being demonstrated intrauterine. Those are the patients where you may have to do certain conservative managements, either in the form of a systemic methotrexate intramuscular or in the form of a transvaginal intrasac methotrexate injection. So this is how we have to categorize. It is a very, very clear protocol that has been decided by the ACOG, which shows that this is the way you have to follow, because the risk of losing a patient, risk of getting into catastrophic situations are very high if you don't follow this protocol. Now, what are we going to do? We are going to do, for example, when you have a sac which is less than 7 millimeters and you have a cardiac activity plus minus, and you don't have a adnexal collection, that is the Douglas pouch collection, under the ultrasound guidance, you can put the needle inside the sac and inject about 1 ml, that is about 50 milligrams of methotrexate, and come out. So quite often, the intention of injecting methotrexate as a cytotoxic drug is to ablate the trophoblastic tissue. Please remember that I do get quite a few questions saying that, can we inject potassium chloride? Potassium chloride is not going to ablate the trophoblastic tissue. The aim of an ablation of an ectopic pregnancy is to ablate the trophoblastic tissue. So you need to inject a cytotoxic drug not a potassium chloride, which is only which will produce only a systole, not the ablation of trophoblastic tissue. So that is one most important message that you need to know. Now, coming to the ovarian ectopic pregnancies, they are very, very rare. They are about 1 in 12,000 pregnancies. The most important thing here is that the gestational sac is implanted in the ovary. It looks like an elevated disc sign with the trophoblastic tissue at the rim. If you put the color Doppler on, the trophoblastic tissue takes up the color and it lights up. So you have an elevated disc with a peripherally increased vascularity, which is very, very classical of a ectopic pregnancy, ovarian ectopic pregnancy. The differential diagnosis is the corpus luteum. As we all know, corpus luteum is quite often a cystic structure. Not only that, you do find that there is some fluid collection. Sometimes there can be hemorrhage. Sometimes there can be a clot within it, but then it never has what is called as an elevated disc sign. I will show you the example so that you can understand it very clearly. See, this is the classical example where grayscale shows that is the ovary. You have an elevated echogenic disc which is seen here, and put the color Doppler on. You find that there is a rim of vascularity all around the trophoblastic tissue, which is very, very typical of an ovarian ectopic pregnancy. So this is how you are going to diagnose an ovarian ectopic pregnancy. Now, management of ovarian ectopic pregnancies, nothing. I mean, unless the other ovary has been removed before and now she has only one single ovary where there is an ectopic pregnancy, in that situation, you do an ultrasound guided or a systemic methotrexate or couple both the things together, or else you are going to subject them for surgical exploration. Third one is the abdominal pregnancy, which is absolutely rare, and it's very, very rare, and quite often it is accidentally detected. See, there was a case where we have identified an abdominal pregnancy as late as 32 weeks of gestation. It was absolutely unintentional, which was accidentally we detect. How do we detect that? The reason why we detected it or we suspected it was unusual presentation, persistent unusual presentation, persistent unusual lie, and at the same time very superficially placed. And we were fortunate that we could demonstrate we could not demonstrate the myometrium, and at the same time we could demonstrate some sort of a myometrial structure which was within the pelvis. So these are the things that we made us think in terms of, but then we didn't diagnose an secondary abdominal pregnancy, but we said that it could be a possibility. But when they operated, it was a secondary abdominal pregnancy. So quite often it's an accidental detection that you make up as far as the abdominal pregnancy is concerned. This is the typical example where you find that is the bladder, transabdominal extension. It is actually the panoramic view where you can see the uterus, which is absolutely empty, and you find the gestation sac, trophoblastic tissue, and the fetal node, which is outside the uterus, which is typical of a secondary abdominal pregnancy or abdominal pregnancy. Now, coming to the heterotopic pregnancy, this is one of the interesting things that we come across off late, particularly with the increased assisted reproductive techniques being followed, where we find a concomitant intrauterine, extrauterine ectopic pregnancies. Now, initially, when we were students, we were said, if you demonstrate a gestational sac within the uterine cavity, you can rule out the possibility of an ectopic pregnancy, but then it's no more true. It is now, the incidence is almost 1 in 7,000, 3,000 pregnancies, where you can find an intrauterine, extrauterine ectopic pregnancies, that is heterotopic pregnancy. So the learning point here is that just because you have seen a gestation sac within the uterine cavity, you cannot rule out the possibility of heterotopic pregnancy or a concomitant extrauterine pregnancy, particularly when you are dealing with patients who have undergone assisted reproductive techniques. So this is one thing we should keep in mind, and remember we are liable to it. So we have to identify, or we have to look for the extrauterine ectopic pregnancy in spite of demonstrating a gestation sac within the uterine cavity. Now, the possibility is that what we need, this is the classical example where you can find that there is an intrauterine gestational sac with the fetal node, and there is another gestational sac with fetal node outside the uterus, which is concomitant. Here we have an intrauterine within the uterine cavity, as well as gestational sac in the cervical canal. So these are the typical cervical ectopic pregnancy with the intrauterine, that is heterotopic pregnancies. This can be present in anywhere. It can be a heterotopic pregnancy in the cesarean scar. It can be a heterotopic pregnancy in the ectopic, that is the tubal ectopic. So the associations can be varying. It can be varying. So how are we going to deal with this? So this is a classical one where you can see that there are 2 gestational sacs. This lady has undergone embryo transfer. There are 3 embryos were transferred. 2 of them got stuck in the cervix, and 1 got implanted in the uterine cavity. You can see that the uterine cavity one, I'll show you 1 second. These are the two gestational sacs with us stuck in the cervical canal. And there was one more thing. Yeah. Sorry. Yeah, this is the gestation sac within the uterine cavity, and these are the two gestation sacs in the cervical canal. So this is a classical cervical ectopic with intrauterine gestational sac. Now, how are we going to management? Management strategies are very, very interesting. We all know that most of these women are conceived after assisted reproductive techniques, so they are very, very anxious to continue the pregnancy. So our main aim will be to preserve the intrauterine pregnancy. So in order to preserve the intrauterine pregnancy, there are three things that we need to do. One is that it could be a laparoscopy. But then whenever we use laparoscopy or a laparotomy, the possibility of surgical mortality or morbidity, as well as the anesthetic morbidity, we have to keep in mind. Second thing is we cannot give a systemic methotrexate because it's a cytotoxic drug. Third thing is to do a transvaginal ablation. In this, previously, what we used to do is under the ultrasound guidance, we used to put the needle within the gestational sac and aspirate the gestation sac completely, make it collapse, then introduce hypertonic saline in order to produce sclerosis, so that hoping that the sac gets sclerosed and so that the trophoblastic tissue gets ablated. But there are umpteen number of instances, that is, at least in my experience, I have done almost about 18 cases of heterotopic pregnancies, of which 4 of them came back with a very vascular trophoblastic tissue in spite of doing all these things. Now, the latest literature says that you still can do what's called as intra-sac methotrexate injection. The reason is that the concept is that as you are putting in within the sac and there is no systemic distribution of the methotrexate, you still can do an intra-sac methotrexate ablation rather than a systemic methotrexate ablation, which can go into systemic circulation, which can result in cytotoxicity. So that is the reason why of late there are some workers who have practiced it in almost about 4 cases. The literature says in which they found that there was no cytotoxic effects of the viable fetus, which continued to deliver. So these are the things. Here we can see that there are the 2 cervical ectopic pregnancies you play under the ultrasound guidance. You put the needle inside, aspirate the sac completely, and then put hypertonic saline so that you know that it is available. Now this is the one. Post-ablation, you can see that the cardiac activity is still persisting within the intrauterine pregnancy, and this lady continued to term and delivered. Now, the second thing is uterine ectopic pregnancies. Now, coming to uterine ectopic pregnancies, based on the location, you can categorize them, or based on the common occurrence. The interstitial ectopic is the one which is very common. Next comes the cervical scar, as well as the cornual and intramural. Now, coming to the interstitial ectopic pregnancy, we all know that the tube has got 4 parts. That is the interstitial part, isthmus, and then the ampulla and the fallopian tube. Now, the location of the gestational sac within the interstitial portion. The interstitial portion of the tube is about 8 millimeters in diameter and 2 centimeters in length. If there is a gestational sac which got implanted in that particular area, then only you call it as an interstitial pregnancy. There is one most important thing that we have to keep in mind. And these are called as pregnancies near the uterotubal junction. This is the new term that has been introduced, wherein they have categorized in 2021 journal, white journal that has been published, in which they have very clearly stated that the pregnancies now are going to be categorized as pregnancies near the that is the uterine ectopic pregnancies, as pregnancies near the uterotubal junction. Now, when we talk about the pregnancies near the uterotubal junction, there are 3 things that we have to keep in mind. 1 is the interstitial pregnancy. 2 is eccentrically located normal intrauterine pregnancy. 3 is the cornual pregnancy. Cornual pregnancy is one thing which we have to keep in mind. This is one. As I take you through, I'll give you a very clear concept about what is angular pregnancy, what is cornual pregnancy, why do we mistake a cornual pregnancy for an interstitial pregnancy. Interstitial pregnancy is not a cornual pregnancy. Please get that term out of our minds, because that is going to create a lot of problems, because the management strategies for a cornual pregnancy is entirely different from the management strategies for interstitial pregnancies. Now, keeping that in mind, when are we going to define an interstitial pregnancy? We all know, even though the gestational sac is located closer to the uterotubal junction, The most important criteria which is going to differentiate between an eccentrically located normal intrauterine pregnancy from an interstitial pregnancy is the breach in the endomyometrial junction. Suppose, for example, you can take this particular one. This is a 3D reconstruction where you can see the myometrium, you can see the endometrium, you nicely see the endomyometrial junction. There is absolutely no breach in the endomyometrial junction, isn't it? Whereas here, you can see that this is the endometrium, this is the myometrium, the gestational sac is absolutely out. That is, it has already breached the gestation, the endomyometrial junction, and it is extending outside. So this is the classical interstitial pregnancy. So this one has to be very clearly understood. Now, when do we call it as an interstitial pregnancy? As we all know, when you do a 3D rendering, you can see nicely the interstitial portion of the tube, and on grayscale, when you can define a line which is continuous with the endometrial echo is what is called as the interstitial line. And if you demonstrate a gestational sac located in this particular interstitial line, then on the grayscale, then you call it as an interstitial pregnancy. This is one thing which I wanted to very clearly convey so that this confusion is not going to take place. Now, how are we going to diagnose it? First and foremost thing, we all know that the uterine cavity will be empty. Second important thing is, I'll show you here. You can see that the interstitial, this is the interstitial line. You can see the gestation sac which is located in the interstitial line. You do a 3D rendering, you can clearly demonstrate that the gestation sac is outside the endometrium. You do the 3D rendering again, you find that there is absolute thinning of the myometrium. So these are the features which are very classical of an interstitial pregnancy. So this is when you are going to label it as. You may have asked me a question saying that, is it required that every time you need to do a 3D rendering, which I don't have? No, I don't think it is required, because first and foremost thing is you have to start learning to identify this interstitial line. Once you start identifying the interstitial line, you can easily identify the gestation sac which is located in the interstitial line. Once you can identify the gestation sac within the interstitial line, it has to be interstitial pregnancy with the breach in the endomyometrial junction, at the same time thinning of the myometrium. So these are the features which will prompt you on grayscale examination to identify the interstitial pregnancy. Now, this is classical. These are the same things which I have shown you. Now, what are the treatment options? Now, the treatment options again is the expectant management, but then it is high risk patients, which are particularly when they have undergone assisted reproductive techniques to conceive, they are very, very anxious to continue the pregnancy. This is the situation where we need to take certain calls. Now, do we have to give a systemic methotrexate? Yes, 50 milligrams of single dose intramuscular methotrexate can be given in this situation. And local methotrexate infiltration also can be. When do you decide to operate on them? There are certain protocols laid down in order to choose the method of management of these interstitial pregnancies. One second now. So the treatment options based on two factors. One is the location of the gestation sac. If the gestation sac is on the extreme end of the tube, that is closer to the tubal portion than the endomyometrial junction, those are the patients who are at risk to get rupture. So they are easy to manage laparoscopically. Whereas the ones which are located closer to the endomyometrial junction, these are the ones which are difficult to manage laparoscopically. And those are the patients where you can do an ultrasound guided intrasac methotrexate injection. So this is one thing which can prompt you. Not only that, there has been a systematic review in evaluating these the strategies followed in managing these patients. One is that location of the yolk sac. What they found was that the patients who had the gestation sac pointing laterally are the ones which were subjected for laparoscopic excision, whereas the ones with the yolk sac which was pointed towards the endometrium were taken into intrasac methotrexate injection. And the success rates are very, very high. So these are the two things. Second important thing is that most of these patients are very anxious to conceive again. So if you give a methotrexate and you ask them to wait for, let us say, 6 months, I think it's not practically possible. So those are the patients, again, who prefer to get a laparoscopic resection rather than a methotrexate injection. So this is very, very clearly stated by the ACOG bulletin, which has been published in 2020. Now, as I said, this is how we are going to categorize. You can see the yolk sac here. The yolk sac, which is pointing laterally, is the one which has to be subjected for laparoscopic resection. This is not the one which we would like to do a intrasac methotrexate injection, because it is quite peripherally located. Yolk sac is directed outwards. And if you try to push the needle in, there is always a possibility that you can rupture, and laparoscopy becomes much more easier in managing these patients rather than the methotrexate, intrasac methotrexate injection. So this is a classical case where you can see the interstitial line. You can see the interstitial line leading to the gestational sac, and you can see the gestational sac with the yolk sac. I have magnified the image, and under the ultrasound guidance, I have introduced the needle into the sac, and then once the needle is properly placed, and then you inject about 1 ml of methotrexate and come out. So this is how we are going to ablate the ultrasound guided intrasac methotrexate for interstitial pregnancies. Now, other situation, this is again the same. Okay. Now, this is what I was very much interested in conveying, is what is called as the understanding the angular and the corneal pregnancies. The angular pregnancies, by definition, is the implantation of a blastocyst medial to the uterosacral ligament or the uterotubal junction. So, how are you going to define? You draw a line along the lateral margin of the uterus, which is not intercepting the interstitial portion of the tube or the corneal portion of the uterus. The ones which are medial to that are called as angular or eccentrically located normal intrauterine pregnancies. The ones which are laterally located to this line are called as the interstitial ectopic pregnancies. Am I clear in this one? Because this is an extremely important factor, and my purpose of coming here will be, I will be very happy if I can convey this particular message. So we need to understand what is an angular pregnancy, what is a corneal pregnancy. That is one. When do you call it as a corneal pregnancy? We call it as a corneal pregnancy, which is also a normal pregnancy, only when we have a gestational sac which is implanted in one corner of the bicornuate uterus or one half of the septate uterus. That means, obviously, it means it's a normal intrauterine pregnancy. Am I correct? So remember that when you say a corneal ectopic pregnancy, remember this term, corneal ectopic pregnancy, that means you have a unicornuate uterus where there is a uterine abnormality which is associated with a rudimentary horn which may or may not be communicating with the uterine cavity. If the gestational sac gets implanted in that horn, then only you call it as a corneal ectopic pregnancy. Am I clear up to this now? Because this is a very, very important factor that has to be understood in our day-to-day practice, because management differs. In case if it is a intrauterine, suppose for example, you have a bicornuate uterus with a gestational sac in one of the horns, do you consider it as an ectopic pregnancy and operate them? Would you not allow them to continue the pregnancy? In the same way, if there is a septate uterus and you have a gestation sac in one of the halves of the uterus, will you not allow them to continue? You don't ablate them. So your definition of these things have to be very, very clear. So when once you say a corneal ectopic pregnancy, it means that there is a rudimentary horn where there is a uterine abnormality, particularly in the form of a unicornuate uterus, and that horn may or may not be communicating with the uterine guide. So they have designed this way. So if you keep this picture in mind, it is very clear. This is a classical interstitial ectopic pregnancy, isn't it? That is one. Two, this is a rudimentary horn, unicornuate uterus, which is not communicating with the uterine cavity. And this one is a rudimentary horn, unicornuate uterus, communicating with the uterine cavity, gestational sac located. All these things are ectopic pregnancies. Okay. Whereas here you have a bicornuate uterus with a gestational sac, a gestational sac and a septate uterus, eccentrically located, a normal intrauterine gestational sac. These are all normal pregnancies. Am I clear? So this image, if you remember, I think you'll be very, very sure about what you are dealing with. Now, as I said, the corneal pregnancy, that is corneal ectopic pregnancy, where you can see that that is the horn, and that is the communicating horn where there is a gestational sac. This is the rudimentary unicornuate uterus or a unicornual uterus, and you have a gestational sac which is there, which is a 3D rendering which we could do. Now, cervical pregnancy. Again, cervical pregnancy is an item. Do I have time? Can I continue? Is that okay? Yeah. Sorry. I think I will be overshooting because there are a lot of things to be told. That is the reason I'm sorry to take a little more time. Okay. Whereas the cervical pregnancies are quite often iatrogenic. The classical features are very clearly, when you do a grayscale imaging, you find that the gestational sac is located beyond the internal os. That is one. But then you may ask me, how do I know which is the internal os? So in that situation, what we can do is, when you find the gestational sac within the cervical canal, that is the one which you have to think in terms of possibly beyond that one. That is one. Two, whenever you find this sort of phenomenon, you find that the uterus is not enlarged, cavity is clear, empty, uterine cavity is empty, but at the same time, the cervical canal is obliterated and there will be ballooning of the cervical canal, ballooning of the cervix. So this is a classical 3D rendering of the same patient where you can see the uterus is normal, the endometrium is clear, thin, thick, but at the same time, you can find that there is a ballooning of the cervical canal with a ring-like echo and the gestational sac. And if you put the color Doppler on, the trophoblastic tissue takes the color and you can see the cardiac activity also in this one. So this is a classical cervical pregnancy. Now, again, this is again another case of cervical pregnancy where you can see the cervical canal, you can see an empty uterine cavity, cervix, ballooned up cervix, you can see the ballooned up cervix with the fetal count. So these are the classical examples of a cervical management. Now, management, as Aniruddha has shown us, that there could be a dilatation curettage. Not only that, you can use a Foley's bulb to obliterate. The major problem which we found, because I think in late 90s and early 2000, we used to do this technique of inflating the bulb and leaving it. But then patient used to have severe pain, lot of discomfort. And then ultimately they used to result in necrosis, pain, fever, sloughing, all those complications were there. So that is the reason why we stopped using that one. And now at present, what we do is we practically go into the cervical canal. See this one, this is the gestational sac with the fetal node. And under the ultrasound guidance, you can easily put the needle in, aspirate the sac, put methotrexate into it, and ablate the trophoblastic tissue. So this is how you try to do it. Now, coming to the cesarean scar pregnancy, I will not take much of the time because Aniruddha has very nicely told about the various aspects of the cervical scar pregnancies. Most important thing which I want to convey is that the thing is that cervical scar pregnancies are two types. Pardon me? Oh yeah, I'll finish off in the time. Oh, yes. There are two types. One is the exogenous variety, the other one is the endogenous variety. That is what you need to first and foremost define. The exogenous variety is the one which is going to cause rupture. The endogenous variety is the one which is going to develop into normal pregnancy, but with associated problems like placenta previa or placenta accreta spectrum. So this is very, very clear. Now, how are we going to define it? You have the crossover line. If you draw a crossover line, the one which is more than 2/3 away from the crossover line is the one which is going to develop into an exophytic or exogenous ectopic pregnancy, cervical scar pregnancy. The one which is less than 1/3 within the uterine, within the cervical canal region, in that situation, you call it as endogenous one, which gradually migrates into the uterine cavity and it stays there. But the only complication that you have to keep in mind is the placenta previa as well as the placenta accreta spectrum. So these are the two things that you need to make. So this is a classical case where you can see that this is an exogenous one. You can see the vesico-uterine recess and the gestational sac is almost abutting the vesico-uterine recess. Put the color Doppler on, you find abundant vascularity. These are the ones which are going to rupture. So this is one thing which you have to know. Now, if you have the endogenous one, you can see here, you can draw a line, the crossover line, and you know that this gestational sac is gradually migrating into the uterine cavity. And this is what is called as the endogenous variety of the ectopic pregnancy. So this is one. You can see the uterine cervical canal. You can see the endometrial canal. It is neither in the cervical canal nor in the endometrial canal, and it is just above it. But then if you draw a crossover line, it is almost cutting across the gestational sac. So you know that this is what is going to develop into an endogenous variety of cesarean scar pregnancy. So this is again absence of the vascular. Okay. So this is now what are the differential diagnoses? Differential diagnosis is the cervical pregnancy as well as the abortion in progress. Now, Aniruddha has very clearly told us how to differentiate between, so I don't want to waste time on that. He has taken us very nicely. Management, again, he has shown us the management also where you can nicely put the needle into the cervical scar, the cesarean scar pregnancy. Now, the last one is the intramural ectopic pregnancy. Again, it's an iatrogenic one. Quite often it is after manipulation that this happens. And you can see here, that is the irregularity of the endomyometrial junction. The sac was pushed into the myometrium. You can see the gestation sac here, yolk sac here, put the trophoblast, color Doppler on. You can find the trophoblastic tissue, do a 3D rendering. You find the gestation sac, you find the gestation sac in the myometrium, which is a classical intramural ectopic pregnancy. So these are the various ones. And then quite often we don't need to do anything for these patients. They just they over a period of time, they get ablated by themselves. In case if we don't, then you can do an intrasac methotrexate injection or a systemic methotrexate injection. Quite often, remember, I would prefer to you, there is one cutoff point which I definitely want to tell you is that when you are trying to do an intrasac methotrexate injection, if the beta HCG titers are more than 15,000 international units, please combine it with systemic methotrexate. Multiple dose of systemic methotrexate plus intrasac methotrexate are the ones which are going to. If you use isolated systemic methotrexate or an intrasac methotrexate, the results are very poor. So you need to couple them up, and then only the results are very good. Now, keeping all these things, summary is the same thing which I have already told. So this one flow chart which I wanted to really put across is the missed period, urine pregnancy test positive, the pregnancy clinic, do a transvaginal examination, definite intrauterine pregnancy, ask the patient to come back for a dating scan, aneuploidy screening, anomaly scan, growth scan, and delivery. If the transvaginal scan shows a definite endometrial ectopic pregnancy or a probable ectopic pregnancy, first and foremost thing is the diagnosis, beta HCG, discriminant no sac in the cavity, search for the ectopic pregnancy, adnexy, heterotopic, uterine. If it is the management, methotrexate, systemic, as well as intrasac and cassial laparoscopy. Now, if you don't find the gestation sac either in the uterine cavity or in the extrauterine, you call it as PUL, then you need to do endometrial biopsy. No more is done. We are not going to practice that. We either do a progesterone and single beta HCG ratios, and we have what's called as M6 mathematical models, which are going to be of great help in identifying the risk for ectopic pregnancy. Because in a PUL, the most worrying factor which we are all worried about is only the ectopic pregnancy. So if you can identify or stratify the risk for ectopic pregnancy, your job is done. So that is how you have to approach it. Thank you very, very much for your patience here.
Thank you very much, sir, for a very comprehensive sort of I would say that it's like I'm very happy to introduce next speaker, Dr. Megha Kamlapurkar, madam. Dr. Megha Kamlapurkar, she is a director of Devta Hospital at Kalburgi in Karnataka. Very good friend of mine. I'm very happy to introduce Dr. Megha. She has been in obstetric practice for last 20 years and she's been practicing fetal medicine and high-risk pregnancies. She has been faculty at state and national levels at many places and delivered many talks on fetal ultrasound. Fetal echo is very much near and dear to her, and she's going to enlighten us on this subject. She has presented many papers and posters, and recently in 18th World Congress of Fetal Medicine Foundation in Spain, she has presented a paper. She's been certified, UK certified Fetal Medicine Foundation member for NT and anomaly scan. She's also she has got FOXY recognized ultrasound center, and she's very much interested in training. She is no doubt a very good singer as well, especially she specializes in Hindustani classical music. Wow. I think at the end of her presentation, we would like to hear something from you, Megha. And hers is the first center in Kalburgi, Bidar, Raichur, and she's very, very academic person and a very fine human being as well. So I will be very happy to present to you Dr. Megha Kamlapurkar, please. Thank you. She is going to talk on 4-chamber view, but till the time that we actually get on to her presentation, she's getting prepared for it. So we will have some questions for Dr. Praveen sir, if he's around, or Dr. Aniruddha sir. Yes. Any questions from the audience, please? I think we are trying to see the online chat as well. Dr. Prajakta is going to help us on that. No, I will ask you, sir. We will be very happy to ask you, sir. So you demonstrated, sir, in 2-3 this thing like in cervical pregnancy, the aspiration of the contents. So can you just highlight on what kind of needle that you have used and how you have performed it, like abdominally, and how you have prepared the patient? And what is your counseling methodology?
The first and foremost thing, you are all well versed with the oocyte retrieval needle. Yes? Yeah, so the same needle I use.
Okay.
Only difference is that the tubing is very, very long, isn't it? When it comes to a oocyte retrieval, no, I'm not audible. Oh, you want me to come now? The tubing of that needle is very, very long, as you know, because it has to be connected to a test tube and it has to be connected to an aspirator and all. So what I do is I cut them off and use the hub in order to put the syringe to it.
Okay.
So I need the same, because the reason is when you do a transvaginal introduction of the needle, you need to go through a biopsy channel or an attachment, which is attached to the transvaginal probe. So in order to accommodate, you need at least at about 20 to 22 centimeters length needle. So that needle ideally fits in, and it is almost about 18 gauge needle. So it is absolutely safe and it is very comfortable. And then you can easily introduce to the channel. That is one. Second important thing is under the ultrasound guidance, I pierce through the section, to the sac, get into the sac, the central portion of the sac, aspirate. The same hub, I can use it for aspiration, I can use it for injection.
Okay.
Am I clear? So once I can aspirate it, collapse the sac, and then put 1 ml of methotrexate. The reason why I aspirate is, if you put the methotrexate into the same sac, it distends. Once it distends, there is a possibility of rupture, there is one. So not only the possibility, the patient will be having a lot of discomfort. So in order to avoid that, I aspirate and then put the methotrexate. Not only the concentration also will not be diluted, because 50 milligrams can be delivered directly. And once I inject the 50 milligrams, because it's only 1 ml and the needle is very big, so I flush it with normal saline or a distilled water.
So the concept will be the aspiration. So with that 18 gauge needle, I just wonder whether we will be able to aspirate all the tropoblasts which is around.
No, I'm not interested in injecting.
Only the sac.
Only the fluid and the content, that's all.
Okay,
now, I'm not interested in aspirate. I can't aspirate the trophoblastic tissue.
So the tropoblasts will remain there and that will be taken care of by the methotrexate.
Methotrexate.
And how long does it take? Follow-up?
Oh, it varies. It's usually about 6 weeks. So I'll come here. That's a very good question. If you really want to assess the success of your procedure, it's usually what we do is follow them up with beta HCG. No ultrasound. Ultrasound will not tell you. Okay. It's only the beta HCG that's going to tell you. If it becomes below the pregnancy levels, that is the beta HCG pregnancy rate, that is less than 25 milliliters per international units per liter, then you know that you are sure that you have ablated it, which may take about 6 weeks.
Okay.
Yeah. So that we don't do it every day. Beta HCGs. Usually what we plan it in such a way that we do it first after 7 days. Remember, the first beta hCG titer which you do after the ablation, 48 hours, there will be a raise in beta hCG. Remember, don't get worried about it, because you are actually flushing that one into the circulation. So there will be a raise in the beta hCG titers. Don't get worried. So wait for another 7 days. And if the patient is stable, nothing to worry, just follow it up with a 7-day beta hCG titers. Quite often it starts dropping down. And if the drop is by 13%, we are absolutely happy.
Okay.
We again do it only after about 1 month, 4 weeks.
Okay. That's a great thing, sir, because you have clarified now what exactly.
I know,
to
I
do. And
understand,
that
because
is,
these are practical
with
problems.
the full bladder or partially full bladder.
Transvaginal, no transabdominal.
Nah, that is
No,
what I
no,
was
no
wondering,
transabdominal.
because the needle is coming straight like that.
No, no, no.
because
Everything is transvaginal.
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 That
Oh,
is what
sorry,
I wanted to
I
get
was not clear.
Yeah, so
Yeah.
I wanted to clarify
Yes,
that.
yes, yes.
So this needle, the picture that you had shown it was a transvaginal.
Yes, same one, same needle.
Same. Okay.
Right?
Okay. Thank you so much.
Right. Sir.
Now, see, only one thing which probably I think just want to add to that is that after putting the needle, if you immediately aspirate everything from the gestational sac, you will lose the track of the needle on the vision as far as the screen is concerned. So usually what we all do is that around 80% of aspiration we do, so that we have an exact clue where the needle tip is lying on the screen. The moment you completely aspirate it, you lose the track of the needle. And then it is very difficult to understand whether am I in the sac per se or in some other non-important area for as far as the ectopic pregnancy is concerned. So 80-85% of the content you can aspirate, that is one thing. And recently few people, they have stated that if the gestational sac has got yolk sac, then you can do a little bit of nibbling so that you get an additional advantage of physically damaging the gestational sac as well as yolk sac. And then before making it sure that you are introducing methotrexate into that sac, which is almost 80% gone now, we need to be very sure that the needle tip is in the desired area of gestational sac, which you are aimed at reducing it. So very important for the beginners, make sure after putting the needle, don't aspirate in a hurry completely all the sac. Just keep at least some amount of anechogenicity, which will identify and make your life more comfortable on the screen.
Okay. Secondly, sir, if there is any bleeding inadvertently.
No. Usually
there isn't.
Usually, most of these patients, they are uneventful. Now, in terms of needle, that what he described is easily available. We can do it. But still, there is one person in Mumbai who provides needle which you can incorporate into a old-timer prosthetic biopsy guns.
Okay.
These transrectal guns are there.
Right.
So you can put that needle into that as a slot.
Okay.
So even with that, the biggest advantage is the pain received by the patient is very less, because while manipulating the transvaginal transducer in the posterior fornix or anterior fornix, you are forced to introduce the needle with little bit of pressure. So that pressure itself causes most discomfort to the patient, and patient may not allow you to proceed into the sac content. So in that case, what I do, at least in our center nowadays, is that there is a biopsy handle and there is a 18 gauge or a 20 gauge needle which fits into that, which is of a 22 centimeters in length.
Okay.
So you just give a thrust like a biopsy, put the inside needle out.
Right. Gun.
It's
that
a
is
gun.
for the prosthetic
That's commonly used by most of the urologists as well as radiologists for performing the prosthetic biopsies. That's a handle, that's a metallic handle into which that needle fits in. And with that, you can, number one, you can reduce the pain substantially to the tune of say less than 1% dead as far as pain is concerned. And with the same handle, everything, you can aspirate it and you can put the needle into, put the methotrexate into that.
Great. Yes. Wonderful.
Important factor is always, whenever you are doing these procedures, please retain the lifeline. Never do all these procedures without having a lifeline, because not that every time you get away without having any bleeding. There are some situations where we do land up into it. So we have to be careful. There is no option for us. There is nothing like being heroic in these situations. I would like to play it safe.
Yeah, I know the presentation is already, yeah, it's certain. I'll not take more than 2 minutes. This was the radiologist perspective. But as a gynecologist, you can all train yourself in this aspiration of the gestation sac. Whenever you have a patient reporting to you with residual cysts, day 2, you need not waste another 21 days giving her OC pills and allow that cyst to resolve on its own. Okay, these cysts you can aspirate, so you know what is the thrust that you have to give so that you get yourself trained in aspirating one follicle. If you can aspirate one follicle, you can do all home pickers for any IVF cycle. Point number 1. Point number 2, nowadays we get double lumen needles. Okay, so that also came into IVF. Whenever we aspirated the fluid and if we did not recover the oocytes, we would push little bit of the culture media in the same follicle and again aspirate. So whatever the oocyte was still lying in the follicle would get aspirated. So these double lumen needles, one part of the needle would aspirate the fluid, the other would inject that. Only thing we have to make sure that the lumen through which we are going to inject the methotrexate, the entire lumen should be filled with the fluid. Otherwise, that vacuum or the air content in that needle first gets pushed into the cavity, and then once the air is there, we lose the sight.
Visibility, yeah.
Thank you very much.
But then I would definitely not prefer the double lumen.
Sorry, sir?
I would definitely not prefer the double lumen. As such, you are using a 18 gauge. If you use a double lumen,
the double lumen also has the same gauge.
gauze, but
They don't come in extra size. Yeah.
We do the aspirations, oocyte retrievals, but then it is much more thicker in the outer margin than this thing. It's much more easier, and we are comfortable doing this. So, I mean, of course, as you said, it is safer.
You have been doing for years together, sir, but for those who would like to start it doing, it was for,
Thank you very much, Dr. Dabde, for illuminating on this aspiration technique, one of the techniques that you are using. Thank you very much, Dr. Praveen, sir, and Dr. Aniruddha, for your valuable inputs. Thank you. Dr. Megha, you can start your presentation. Thank you so much.
Respected President of Solapur Obstetric Gynec Society, Dr. Abuli Velankar, the office bearers of SOGS, respected eminent faculties of today's CME, respected chairpersons, and all my friends who have joined for today's CME, online and offline. A very good afternoon to you all. We all know that the congenital heart diseases are the most common congenital abnormalities we encounter in the fetus and newborn, and perhaps more common than the chromosomal abnormalities as such. And when I talk about the fetal heart, I always introspect myself. Whenever I get cases for referrals, second opinion and third opinion, this is a topic of my introspection. What's going on in the society and how we can reach the obstetricians in their busy practice to look into the fetal heart. I love these words. C is common for all. Some take pulse, some take fish, some come out with just wet legs. At 4-chamber view, though easy for all, is same. We get what we want, what we know and what we look for. We know that the 4-chamber view was proposed as the first screening view in the cardiac abnormalities screening, and it was introduced in 1980. And though recently, the other sequential segmental analysis of the heart has been recommended by various societies like ISFAG and American Institute of Ultrasound, the diagnostic range is still very wide. Can I get a help? Because I'm getting this on my slide. Okay. So moving forward. Oh. And this difference in the detection rate of congenital heart diseases depends upon the population we screen. Is it a high-risk population, or is it the screening which is offered to low-risk women? It depends upon the expertise of the examiner, the experience of the person who is doing the fetal ultrasound. It depends upon the differences and accuracy of postnatal follow-up. The difference in detection of congenital heart diseases depends upon the examination time when it is done. Is it done before 15 weeks, or is it done at 18 to 20 weeks, or at terms? It depends upon the consideration of cardiac defects or only congenital heart diseases detectable on four-chamber view. The examination of the heart is not specified sometimes. Sometimes the referral is just for anomaly scan, or just we ourselves look into the fetal heart as just a casual examination, or sometimes it's a targeted examination along with the segmental sequential analysis of the heart. And of course, it depends upon the machine which is used for ultrasound. Lindsay Allen, cardiologist in UK, she trained the sonographers and sonologists there, and she trained them to look into the four-chamber view in a specified way. And all those sonologists were asked to refer these cases which failed to meet the particular normal criteria of four-chamber view. And it was seen that there was an exponential increase in the number of referrals and obviously increase in the diagnosis of congenital heart diseases. As an obstetrician, I always feel that there are about 35 to 37,000 obstetricians in India. And if each one of us starts looking into this four-chamber view with this particular criteria and checklist, there will be exponential increase in the incidence detection rate of congenital heart diseases in India too. Because here we do ultrasounds and we take the responsibility of screening and diagnosing the fetal heart diseases. ISWAC studies also has shown that the detection rate, when it was not a targeted examination, it was done in different centers and not by a specialized team, the detection rate of this congenital heart abnormalities was up to 5 to 15%, whereas when it was targeted examination by trained person, it raised to 15 to 40%. And then when this examination was done as an extended examination at special centers with four-chamber view great vessels, the diagnosis rate increased to 40 to 80%. There is a lot of variation or wide range in the diagnostic accuracy, ranging from 5% to almost 95%. Why is it so? It is because of inadequate examination of fetal four-chamber view. Four-chamber view is not properly acquired. Sometimes if it is acquired, then four-chamber view is overlooked. There are certain abnormalities which evolve in third trimester. And if we do four-chamber view as a screening in second trimester, we'll be missing out these abnormalities unless we look into fetal heart in third trimester too. There are certain defects of the fetal heart which are not possible to diagnose in antenatal scans, like secondum ASDs and some forms of coarctation of aorta. So these defects will not be able to pick up in routine screening of fetal heart by four-chamber view. And anomalies cannot be detected by mere four-chamber view, and some anomalies, they do need extra views. So we are left with improvisation, which is possible for these things. And we'll be discussing them in next slide. So coming to the reason, first, as inadequate examination, of course, we can divide this into operator dependent and machine dependent or technique dependent inadequate examination. Operator, of course, the lack of confidence or apprehension about fetal heart examination, mostly by obstetricians, and time dedicated for examination. We all busy obstetricians, the biggest constraint is of time in our heavy OPD. OPDs indoors, we manage and struggle to dedicate our time, which is required for the examination of fetal heart, and there is a possibility of missing some abnormalities in four-chamber view. Of course, lack of expertise. The lack of expertise, I would say we are more interested to get certification for aneuploidy markers, like we are in a hurry to get certification for NT. Same way, I feel we should have certification for examination of fetal heart so that we'll have a high confidence level to look into the fetal heart. Of course, good machines is mandatory, high frequency transducers, Dopplers, cine loop facility in machine, and proper presets are needed. But I feel nowadays all these machines are updated and they can fulfill the minimum demands to look into the fetal hearts. It's like a smartphone. We used to use simple Android phones, but now we are having very high-end models of smartphones. And the same way, we have good machines which will help and pick up many abnormalities in four-chamber view. The reason for inadequate examination, we often frequently come across as normal or a limited examination due to improper fetal position when the heart is examined at inappropriate angle. Suppose if this is the case, the rib shadowing, the thick abdominal wall of the mother is concealing the details of the fetal heart. And if you try to comment upon the checklist of four-chamber view in this view, I'm sure you will get demoralized and you will leave the attempt to look into the fetal heart. So never try to comment for the fetal four-chamber view unless it's in a very proper position. Four-chamber view is not mere counting of the chambers and mere heart beating, isn't it? At whatever time of gestation we are looking into fetal heart, try to learn and try to catch maximum findings in four-chamber view, which are mentioned there in our checklist. As I said, auditing of aneuploidy markers and certification is always a major concern than our fetal cardiac assessment or our expertise in fetal cardiac assessment. Sometimes examiner is not able to obtain four-chamber view. Spine is anterior, spine is at 12 o'clock position, casting shadow, completely casting the shadow. Sometimes placenta can be anterior, sometimes there can be late gestation, or there can be oligohydramnios, improper quantity of the liquor. So these things, they will pose you the technical difficulties. But what we can do, we can overcome these difficulties, and particularly in your learning curve, we need to choose the optimum time for examination at 18 to 20 weeks. If you are an obstetrician busy and interested to learn the fetal cardiac examination, I would say to look into the fetal heart, especially between 26 to 28 weeks. If you see good spine at 6 o'clock position, heart at 11 o'clock position, never lose an opportunity to pick up maximum findings in four-chamber view. Whereas if you try to see maximum findings, try to get them at 11 to 14 week scan, I'm sure you will not be able to pick up many, and slowly you may lose your interest in looking into fetal heart. So whenever you are looking for four-chamber view, there is a common rule. The organ or the area of interest should occupy about half to 2/3 of our monitor. We should judiciously use cine loops for AV valve movements because heart is a mobile structure, it's in motion. We need to assess the heart in both systole and diastole. Despite of this, if
spine is not in a proper position, if spine is not at 6 o'clock position and heart is not at 11 o'clock position, better not to look into the fetal heart, stop the examination, reschedule the examination, let her roam or let her come next day. And when the point is that you have to counsel and you have to talk to the patient that the things are not proper, let the baby change the position and I will again look into the fetal heart. We as an obstetrician have that added advantage that we can call our patients and they believe in our words and they will definitely come as per our advice to them. And always never forget to mention the difficulties in the examination whenever you need to refer them to the specialist. Echo presets are always available on our machines. They are for the depth of the image, sector width, box zoom, pan zoom, high frame rate, and use of harmonic SSRI and CRI. We are often afraid of getting lost if we change these presets, isn't it? But what I would say, you have to just play with the machine. You have to spend some time on the machine, change the presets. Even if you are lost, you can call your application engineer and get the things done. But you have to experiment as we keep on playing with our mobiles. You have to play, you have to spend some time on the machines to know more and more features of the machines and learn the techniques of proper image optimization. We know that here we can see the transducer and the heart, fetal heart is here. The time taken for these ultrasound waves. The video is playing. To reach this fetal heart is definitely more than this. So what is happening here? The time taken for these ultrasound waves to reach this heart is definitely lesser. It will capture more and more events in the cardiac cycle than compared with the image on the left side. So what we do, we have to reduce the depth of the image to pick up more details. So reducing the depth of the image is going to increase our temporal resolution or frame rate. Frame rate is nothing but the number of images which we acquire in 1 second. So this can be increased by reducing the depth, as I have shown you. Second, by reducing the sector size and by lowering the line density. But the compromise in reducing the sector size is little bit of the resolution. So this is an image. This is a sector width. This span of spectre takes a lot of time to cover the images which are there in this sector. Whereas once we reduce the sector size, the time for ultrasound waves to capture the movements will be definitely less and we'll get more image details of the moving heart if we reduce the sector width. And line density is already, we need not change. Line density generally we need not change. It's there in the presets. Line density is nothing but how many lines per frame, and definitely lowering it will reduce the lateral resolution, but definitely it will increase the frame rate. Frame rate is important for fetal heart because it's a structure in motion. So this is a small video where we can see that this is a 13 weeks, 6 days gestation. I have reduced the sector width. And then we put the box, zoom box, and then we see the details of the heart. So this is how you have to do it manually every time, whatever may be your preset. So first you reduce the sector width, then put a box on that, reduce the depth, put a box, and then start doing the fetal examination. Use of color, and especially in dual mode, is very important because what happens, in your busy practice, you just see 4 chambers of the heart, they are there, symmetry is there, everything is there, and then you just switch on for reporting. This was a case which was referred at 32 weeks. Generally, I have a practice of just whenever patient comes to me, first visit, I do a scan. And the same day I did her scan and her previous scans were normal. And I could find that there was a muscular VSD. The only reason that was missed must be for not using the color. So the cardiac examination is not complete unless we use color, especially for the VSDs. Some VSDs will not be picked up by mere 2D imaging. It needs color. I would advise to use whole abdomen. What happens generally when we are learning to do fetal heart examination? So when first we get 4-chamber view, chalo, mil gaya. So what we just press the maternal abdomen and we see that we don't miss the view, isn't it? And that's why we don't change the position of the transducer. But what happens? If we change the position of transducer, we can bring the transducer from other side. Here, what is happening? The ribs are coming in the way. Here, what I have done, I have come from the abdominal side. I have brought the ribs to the posterior. The same way, we can use whole maternal abdomen and insulate from the different angles and try to get maximum information. So sometimes what happens in a single 4-chamber view, we may not be able to pick up all the abnormalities. Our aim is to complete the checklist. So what I do, I just complete the checklist. Maybe the number of images and the number of scenic loops we store, maybe more, but the complete checklist is seen that we see that it is completed. When we talk about 4-chamber view, there are 3 types of 4-chamber view. Each has its own significance. So when we see one 4-chamber view, don't stop there. You have to just insulate from other angles. Take apical view. Apical 4-chamber is important for looking into the fetal heart apex. Is it formed by right ventricle, left ventricle? How are the AV valves? The motion of the AV valves is better seen in apical view, whereas basal view is very important for documenting the entrance of the pulmonary veins in left atrium, and lateral 4-chamber view is important for this interventricular septum, interatrial septum, foramen ovale, and even the ventricles. So these views should be taken, not only one 4-chamber view, try to get all the 4-chamber views and try to document whatever is expected in a 4-chamber view. So this is a checklist. We can just, in initial days, we can just paste this checklist besides our ultrasound machine and try to see that you have seen all these points. Ask your assistant to remind you if you lose something, and always try to store images in cine loops, not only still images. So at least 1 or 2 10 seconds image, even if you store, you will be seeing the heart. Because if I store image in systole, I will not be able to see the image in diastole, what is occurring in diastole. So I would advise you to store the image as a cine clip and not as a still images. So after you cover the checklist in 4-chamber view, you can use heart biometry. Z scores are now available, maybe on perinatology.com, or they are incorporated in the machines. Obviously, here there is a lot of discrepancy, which is very obvious, but sometimes the discrepancy is not very obvious. In such cases, or some diseases like coarctation of aorta or aortic stenosis, which evolve over the months. So that time, the documentation of the sizes by Z scores is going to help you a lot. So here you can see the discrepancy between the right ventricle and left ventricle is not much. And when we use the Z scores, the right ventricle diameter was minus 0.4, which is normal, whereas left ventricular diameter Z score was minus 4.58. So obviously it is a small left side of the heart. 3 vessel view, what we are going to get in such cases, right pulmonary artery as such is always bigger than aorta. So it's very difficult to tell, is it there any pathology in the left side of the heart? How to comment? So here we can see that this is the aortic arch. We can see here constriction of the aortic arch and post-constriction dilatation of the aortic arch. It was a case of coarctation of aorta. This is a biplane imaging which is available in this machine, and it can give images in same section. 2 orthogonal planes we can image in same section. So this is okay. This is 3 vessel trachea view we can see, and then immediately same we can have a look for complete aortic arch. So this biplane imaging will give us, we can see this video is not being played. It's okay. But we can see little reversal of flow from the aortic arch. Here you can see the constriction. And this same will be seen in our 3VT view by this biplane imaging. So we can incorporate such type of pictorial diagrams when we are conducting trainings. So pictorial diagrams of fetal cardiac abnormalities, we can just display in our ultrasound room till we get used to this fetal cardiac screening. So like this, here we can see that this is the spine, this is left side of the heart, this is right side, this left side is small, right is dilated. We don't know which is abnormal. So the same way here, right is small, left is bigger. So what is the cause? This is how you have to go on correlating what is occurring in the heart, why this is so. And definitely once you are updated, once you are expert in 4-chamber view examination, definitely you will look into the further sequential segmental analysis of the heart, 3-vessel and 3-vessel trachea view. Okay. So when we see 4-chamber view and we follow the checklist, remember, by default, you are going to rule out these 5 important diseases by default without your knowledge. If you say, if you scan one patient and after a few days you come across, this is the thing. So you should be very confident that I have checked the checklist and it's not possible. So these 5 diseases we should never miss on 4-chamber view. Of course, these cardiomyopathy and rhabdomyomas, they are seen in 3rd trimester, not in 2nd trimester. And then left side, hypoplastic right side of the heart, AVSDs and Ipstins. These 5 abnormalities will be ruled out if you follow normal 4-chamber checklist. Other potentials for 4-chamber view, if you are expert, then we'll be able to pick up the abnormalities of the myocardium, pericardium. We'll be able to pick up the abnormalities of the pulmonary venous connections, abnormalities of the foramen ovale, azygous vein connections, and of course the abnormalities of the cardiac rhythm will be picked up by 4-chamber view. The reason second for failing the 4-chamber as in screening, remember in screening, not in examination. Screening of the fetal heart. The 4 chambers are visualized, but the anomaly is not detected. Why this happens? It is because if the examination is hurriedly done, we may bypass the checklist. And most commonly picked up abnormality in 4-chamber is just asymmetry, and most commonly missed is the area behind the left atrium. We often miss the area behind the left atrium, and we may miss small VSDs and TAPVC like serious disorders even at the hands of experts. This is because the examination is done in a hurry and with the time constraints. And if we don't use the color, again, we are going to miss small VSDs which are not picked up by grayscale. So examination of cardia is never complete without color. The third reason why 4-chamber doesn't help in screening is there are anomalies which evolve in 3rd trimester, like valvular stenotic lesions, coarctation of aorta, which are seen more in 3rd trimester. And I have told that in such cases, we can use Z scores to document that this is evolving anomaly. And the 2nd trimester, the scan was normal, and this anomaly is being evolved in 3rd trimester. Certain cardiac tumors like rhabdomyomas are always 3rd trimester surprises. They are not seen in 2nd trimester. Cardiomegalies like and cardiomyopathies, they are also seen in 3rd trimester commonly than in 2nd trimester. The third reason is there are few other defects which are detectable postnatally only, like septum secundum ASD, patent ductus arteriosus, and coarctation of aorta. You cannot screen them in prenatal life by 4-chamber view. Fourth reason is the heart anomaly is not detectable in 4-chamber view. That means there are certain diseases where the 4-chamber view will be normal. They are like transposition of great arteries. Of course, corrected transposition will have abnormal 4-chamber view. But detransposition, tetralogy of Fallot, double outlet right ventricle, truncus arteriosus, or interruption of aortic arch or arch abnormalities, they need extra views to incorporate for the complete examination of the fetal heart. So this is one case I we'll show you this case. She was a dentist. She came to me at 33 weeks one day, just for a second opinion, just inko chalo dikhayenge madam ko bolke. And then she came, there's almost normal 4-chamber view was seen. When this, I tried to take LVOT view, there was a like aortic override or single vessel, which was getting contribution from both the ventricles, right and left. And when this the color was put, I could see that this was a common arterial trunk. Believe me, at 33 weeks, one day, diagnosis of common arterial trunk, her husband was an orthopedician in Rajasthan. So she went to AIMS Delhi. Her co-sister was there in Delhi. She got delivered in AIMS. The baby had common arterial trunk. Baby was operated, but unfortunately, baby could not be salvaged. So the only thing is that maybe the 4-chamber view alone was seen and other views were not seen because of the number of patients or because of the time constraints. So this is how it's so serious. If we only 4-chamber view is not enough unless we have in mind other views and unless we have we look into the other views. So certain diseases, as I told you, they do have some clues on 4-chamber view. And these clues we have to pick up from 4-chamber, like situs. Normal situs, as we all know, that it's levocardia, and reverse of this is situs inversus. Anything in between is situs ambiguosus. So when we are not well confident that this is situs problem is there, better some situs abnormality, refer them for an expert opinion. So this is again a case where stomach is seen on left side, but gallbladder has come to the center. Stomach, left side situs solitus, but heart was on the right side, dextrocardia. 4-chamber view, this is an old case. 4-chamber view shows the left side, there is no flow across the mitral valve, where there was a little flow reversal across the right side of the heart. And this is bicaval view, where in IVC was entering and SVC was entering in right atrium. This was a case of right heterotaxy or right isomerism. Fetal autopsy was done. Then spleen was not there because left-sided structures are mirrored by right-sided structures in right isomerism. So spleen was absent, there was dextrocardia, and liver was in the center. What will happen in the lungs? Because on right side there are 3 lobes, the same symmetry will be there on the left side. So left side, instead of 2 lobes, there were 3 lobes. Even the right atrial appendage was repeated on the left side, and left atrium had right atrial appendage. And this shows dilated right side of the heart, whereas this is a stenotic small hypertrophied left ventricle because of mitral stenosis. The clue was the heart on the right side. So this is how you have to pick up the clues. So these positions of the heart, like the normal position is levo position. Meso position again is associated with abnormal ventricular connections like TGA or DORV or chaos or TAPVC. So you have to just pick up the clues about in the 4-chamber view and incorporate extra views to come to the diagnosis or to refer them for a proper cardiac evaluation. So cardiomegaly is an important clue. We have to rule out cardiac causes for cardiomegaly and extracardiac causes. What are the causes for cardiomegaly? Another clue is axis deviation, because it's very important, especially in early fetal echoes at 11 to 14 week scan. The axis deviation also very important, and it predicts 79% of this congenital heart diseases. We know that normal axis of the heart is 45 degrees plus or minus 20 degrees. So if there is excess left axis deviation, in tetralogy of Fallot, suppose their 4-chamber view will be normal, except there is left axis deviation. So you should be able to pick up the clue from 4-chamber view. In common arterial trunk, or coarctation of aorta, Epstein's anomaly, there is left axis deviation. When you see that left axis deviation, your antennas should raise, and you should now have suspicion to look into these abnormalities in other views. Whereas right axis deviation can be seen in DORV or AVSD or common arterial diseases. So area behind left atrium is always overlooked, as I have said, because this is very important. This is the only vessel behind the left atrium is aorta. If you see any excess vessel, then it's abnormal, isn't it? So maybe it's zygous or azygous connection. And here you can see the aorta. Where is the aorta? When we see a line from sternum to the spine, the aorta is to the left, isn't it? But some cases it comes to the right, and this is always missed. And obviously, when our aorta, descending aorta is seen on the right side, it is going to be right aortic arch. And then we feel, oh, she has diagnosed right aortic arch. But believe me, it is so simple. You can just pick it up from 4-chamber view. And you have to look into the area behind left atrium. There should not be any vessel behind the left atrium and aorta. If there is any vessel behind this, then there is a suspicion of abnormal pulmonary venous drainage. So this is also a case where we can see this is a small 4-chamber view, but one vessel is entering here in the right atrium. This is the aorta, spine, left atrium. This is right atrium. One vessel was here entering, and that's why right atrium was little bigger. There was small perimembranous VSD. And what happened, you know, this umbilical vein was directly entering the right atrium. This is 16-week fetus, and there was little left axis deviation. So the couple opted for termination. It was a case of ductus venosus agenesis with tetralogy of Fallot. The patient, she had come to me at 11 to 14 weeks scan. That time, this is a case in 2017. And that time, in that scan, I could not pick up ductus venosus. But, you know, I just mentioned ductus venosus could not be documented. That was the thing I gave in the report. And then she came at later gestation, and when we saw, we could see that ductus was entering. What I mean is, you have to follow the protocols. You cannot bypass. If you're not able to pick up or document something which is normal, then you have to mention it for your own sake, isn't it? Or the person to whom you are referring, the person will look into the matter. Ductus venosus is not seen, that person will look into ductus venosus and see where it is entering. So when we try to negotiate this probe from right atrium, it straightway came in the umbilical cord, confirming that the umbilical vein was directly opening in the right atrium. And here it was associated with TOF, where there is a small pulmonary artery and aorta is bigger, and aorta has come anteriorly and pulmonary artery has gone posterior. Along with this, we need to see the coronary sinus in 4-chamber view. See, when we see such cystic structure in 4-chamber view, so it is a dilated coronary sinus. Generally, there are two superior vena cavas, but left is obliterated normally, and only right superior vena cava is there. But sometimes we see 4 vessels in 3-vessel view, and that is left persistent superior vena cava, which is going to drain in coronary sinus, and that's why coronary sinus will be dilated. So when you see this is a cystic structure, which is not normal. This cystic structure is seen in left atrium, that is showing that coronary sinus is dilated. So we need to look into more views and why this is dilated. Generally, it is persistent left superior vena cava, but remember, this is a very important clue for coarctation of aorta also. So you need to look for the parasagittal view for complete aortic arch. Sometimes we see that this is 4-chamber view, and when we take a view which is little lower than the AV valves, we take a view of coronary sinus, and then we feel that septum primum is absent, and we call this as a AVSD. So this is a false positive diagnosis for AVSD. Remember that you have to just again check the septum primum in lateral 4-chamber view. That's why the importance of all the 4-chamber view, like apical, basal, and lateral. This was a case which was referred for HLHS at 38 weeks for fetal bradycardia, and she was advised urgent cesarean section. And to hear what is seen, see the foramen oval, which is completely occupying the left atrium, isn't it? And that's why it has mechanically obstructed the flow across the mitral valve, and that's why the left side of the heart is small and right side was dilated. This is a color which is also showing more flow in the right side than the left.
Hello.
This was a case of foramen oval.
5 minutes more, ma'am.
Okay,
please.
okay, sure. And patient delivered in government hospital. The patient again called back took baby, and the baby underwent fetal echo, and a foramen oval aneurysm was confirmed. The baby is doing now, baby is now 1.5 years old, doing well. What I mean to say, the prognosis of HLHS and foramen oval is completely different. So had it been HLHS as a diagnosis, the management strategy would have been different, isn't it? So we need to look into the foramen oval also in 4-chamber view only. So 4-chamber view can help us to diagnose the foramen oval abnormalities. The 3rd trimester surprise is always difficult to counsel to the patient. Always look for interventricular septum in diabetic mothers, where the ventricular walls are so thick that we are seeing very less amount of the blood in ventricles, and interventricular septum was also very thick. The cardiomyopathy in diabetes is reversible in these babies, and we need to counsel these patients that this is temporary effect of the maternal diabetes on the fetus, and soon the baby will pick up after postnatal life. So this was a case where we can see the right side of the heart is dilated, right atrium, and then the left atrium, isn't it? And otherwise the 4-chamber is normal. But why this was? Because the right pulmonary vein was directly going and entering the coronary sinus. Here you can see this is right pulmonary vein, which is in red color, and then coming back, entering in the coronary sinus, and the blood from coronary sinus is entering the right atrium, and that's why right atrium is dilated. So this is a case of partial PAPVC, partial anomalous pulmonary venous drainage. So this is simple diagnosis. If you are very keen to look into the fetal heart in 4-chamber view, you will be able to pick up these abnormalities. The take-home message, I always feel the most important potential for 4-chamber view is that it motivates the operator to learn other views for fetal cardia. I'm sure if you are very expert in looking into 4-chamber view, you will not stop there. You will have inquisition to look into 3-vessel view, 3-veti view, and complete sequential
Yeah, there is some internet issue at the hotel, so we are trying to rectify it. Just give us 2 minutes.
Done and shown us the autopsy specimens also. Thank you very much, ma'am. And let us get into the next talk, that is the twin pregnancies or multiple gestations. I made it twin because it becomes much more easier for me to convey the messages, because it becomes much easier to say twins because we are accustomed to it. We all know that the incidence of twins is increasing enormously, basically because of assisted reproductive techniques. And not only that, increased, what do you call it, as a aging maternal population, as well as late conceptions. Most important thing is here we are dealing with two aspects. That is, one is the mother, the other one is the fetus. And the risk is associated for maternal as well as the fetal risk. If you take the morbidity into consideration, it is almost twice the morbidity of a singleton, as well as 7 times the mortality of a singleton. And at the same time, complications such as the preterm birth, IUGR, anomalies occur more in frequencies in the multiple gestations or the twin gestation. And there are certain unique complications which are absolutely unique for monochorionic twins, which are such as the TOPS, TTTS, as well as the TRAP. So these are all the things that we have to keep in. That's the reason why we are much more worried. And then I'm sure in your practice, the number of twins or multiple gestations are absolutely increasing in number. So we need to have a very clear concept about what we are going to deal with this, how we are going to deal with these twins. Now, we should formulate an outline. That is, the first outline is whenever you get an early pregnancy, whether it is twins, multiple gestation, or a singleton, the first thing which we do is the dating of the pregnancy. And the dating is basically done by crown rump, right? Second thing is in a multiple gestation, it is absolutely essential that we need to identify the chorionicity and amnionicity. We know very well that the importance of chorionicity, identifying the chorionicity, because your report, if it just says twins or multiple gestations without the mention of chorionicity, it is of no use, because the management or the follow-up of these multiple gestations will be basically based on the chorionicity, and that is the reason why it is essential that we need to establish the chorionicity. I will take you through how to identify this chorionicity, and then we need to know what is twin labeling, and not only that, how often are you going to do, at what time of pregnancy we are going to do, and what are all the components that we are going to evaluate at various times and at which frequency which we are going to examine these multiple gestations. Now so let us say take the dating. We all know the ideal method of dating is by taking the crown rump length, because we know that the biological variation catches up after 12 to 13 weeks of gestation. That is the reason why the crown rump length is an ideal parameter which can give us the accurate gestation age in the same way that the expected date of delivery. That is the reason why we need to date these pregnancies early, and the crown rump length is the biometric parameter which we use. Now, when we have twin gestation, the largest crown rump length is the one which we are going to take. That is one more factor which we all know, and we have to follow that. But then, if the gestational age is more than 14 weeks, it is the head circumference that you are going to take into consideration, not the crown rump length. So that is one more factor which you have to keep in mind while evaluating the multiple gestation. And particularly if it is an IVF conception, you need to know the date of conception, or the date of particularly the date of oocyte retrieval, because as we all know, there are certain calculators. Even perinatology.com also has got a calculator in order to identify the expected date of delivery, because if you date the pregnancy at this gestational age, your management strategies are absolutely different, because you know you can identify the growth pattern, you can identify the possible abnormalities that you are going to come across based on the dating of the pregnancy. And that's the reason why it is extremely important. We basically have the oocyte retrieval date, or the time of oocyte retrieval is taken as the point of conception, because we all know it's about 12 to 24 hours that the conception or the fertilization takes place. But then there are certain loopholes in it that it can have to happen within 5 days of intercourse. So that is the reason why we have to be a little careful. But basically, on a broader perspective, this is how we are going to calculate. There is what is called as the perinatology.com. Here you can put the conception date, that is by date of ovulation, egg retrieval or insemination, day 3 embryo, day 5 embryo, and based on that, if you calculate, you can get the expected date of delivery. This is one thing which we can also make use of. Now, coming to the determination of chorionicity, amnionicity, most important thing I want to stress here is that the chorionicity is identified best in the first trimester scan. That is the time when you can really identify the chorionicity, and it is very, very easy to identify the chorionicity in the first trimester rather than in second or third trimesters. Second important thing is, the most important thing, the chorionicity is ascertained by number of gestational sacs. That means the number of gestational sacs are equivalent to number of chorions. That is the simplest way that we can understand, and it becomes very easy for us to identify the chorionicity in the first trimester. Next, second important thing is number of yolk sacs are equivalent to number of amnions. I just give the statement, but then I hold it back because it is not just the yolk sacs that I would depend upon the identifying the amnions, but also I would like to demonstrate the intertwin amniotic membrane in order to ascertain the amnionicity. But for the first trimester, it is very difficult to identify the intertwin membrane. That is the reason why we depend upon the number of yolk sacs, taking that into consideration in identifying the amnionicity. Am I clear up to here? Right. Once that is done, so what is this chorionicity? We all know when we take the fertilization, when once it is a 2-cell, 8-cell fertilization or the blastomere, then the morula. And whenever we have, as you know, this is a very simple thing that I would just want to take you through, is if you have two separate ovum as well as the sperm, you know that it will be polyzygotic, you have unidentical twins. Whereas in a monozygotic, it will be the same thing, but then it is a cleavage that is important in order to decide whether it is a dichorionic, monochorionic, or a monoamniotic. So the time of division is what is important. In a multizygotic twins, it is, or a dizygotic twin, it is the number of placentas which are going to determine the chorionicity. Whereas in a monozygotic twin, the chorionicity depends on the time of division of the morula. So that is how we have to take it into consideration. For example, if the division takes place less than 4 days, it is usually the DCDA. If the division takes place between 4 to 8 days, it is usually NCDA. And if it is after 8 to 13 days, it is a momo twin. And if it is after 13 days, it should be a conjoined twin. So this is how you are going to take into consideration as far as the monozygotic twins are concerned. Now, if you take this, so to make it much more easier and simpler, if it is a dizygotic, 100% of them are dichorionic. You agree with me? Yes. But if it is a monozygotic, 75% of them are dichorionic. That means the division has taken place before 4 days of morula, right? And if it is after that, the other 25% of them can be a monochorionic diamniotic, 1% of them can be monoamniotic, monochorionic. So momo twins. So in this, what happens is the major problem comes when you have a single placenta. Now we have decided that the number of placentas are equivalent to number of chorions. So if you don't find the number of placentas, and if you find a single placenta, that is the time when we get into trouble, where we have to differentiate between a fused placenta and a shared placenta. Fused placenta means that there are two placentas which are fused together. That obviously means it's a dichorionic twin. If it is a shared placenta, that means there is only one placenta through which both the twins are sharing the circulation. So that is the one which we have to differentiate. So that is one thing which we have to learn how to differentiate when we have a single placenta between a shared and a fused placenta. The second important thing is whenever we have a MCDA, you know that there will be an unequal division of the placenta or unequal sharing of the placenta, which results in various unique complications which are unique to monochorionic diamniotic twins. And whereas in a momo twin, there is a single placenta, single amnion, and it has its own complications which are pertinent to momo twins. So this is how we are going to understand about this multiple chorionicity. Now, how do you determine? As I said, it is very easy. That is in the first trimester, that is less than 10 weeks of gestation, number of gestational sacs is equivalent to number of chorions, and number of yolk sacs are equivalent to number of amnions. Whereas in a late gestation, after 10 weeks of gestation, or let us say after 12 weeks of gestation, then it becomes number of placentas. If you can identify the number of placentas, well and good, it tells us how many, is it a dichorionic or a monochorionic? Or if in case if it is not, and if you have a single placenta, then you need to differentiate between a shared placenta and a fused placenta. In that situation, we depend upon what is called as the lambda sign or the twin peak sign. I will explain you the twin peak sign also. Then we have the intertwin membrane thickness and at the same time the fetal gender, which we may not be able to identify. So these are the factors which will tell us whether it is a monochorionic or a diachorionic twin. Now, there are multiple papers that have been published in the White Journal, which very, very clearly says in the first trimester, the sensitivity of picking up is almost 99.8 and the specificity is almost as high as 100%. So that is the ideal time when we are going to pick up the chorionicity. Now we know, now I'm sure you all will agree with me, how many, or what is it, a multichorionic or a monochorionic? Please, shout, you have to shout. Fantastic. So it is a multichorionic twin because there are 3 gestational sacs. That's simple, isn't it? Right. Now, the problem comes with the amnionicity. Now here, I will take you through, is this 1 gestational sac or 2 gestational sacs? 1 gestation sac. How many embryos are there? 2 embryos. How many yolk sacs are there? 2 yolk sacs there. So what do you call this? Monochorionic, diamniotic. Fantastic. What about this? You have 1 sac or 2 sacs? Come on, we will fast, or else they will say you stop the lecture. 1 sac, isn't it? 1 sac, and you have only 1 yolk sac. But what are you trying to see? You can see the intertwin membrane. So you know that it is a monochorionic diamniotic. Here you have only 2 yolk sacs, isn't it? So it still can be a monochorionic monoamniotic because we are not seeing the embryo as well as we are not seeing the intertwin membrane. Here you can see 2 embryos with the yolk sac and you are not yet able to. The reason why I have shown you all these images are that, remember, to identify the intertwin membrane before 8 weeks is very, very difficult, even in spite of doing a transvaginal examination. So that is the reason why you have to be very careful. You need to depend on some feature which can guide you in future, that is either to do to identify whether it is a monochorionic monoamniotic or it's a monochorionic diamniotic, because you know there is a difference between a monochorionic diamniotic and a monochorionic monoamniotic. You agree with me? Yes. Fantastic. Now this is what do you call this as? Come on, please. It's too small to answer. Okay, there are 2 placentas, isn't it? Okay, so right. Now, when there are 2 separate placentas, we are very comfortable. We know that we are dealing with a dichorionic twin. But whereas when you have only single placenta, that is when we know that there is a problem to differentiate between a monochorionic and a dichorionic. That is a shared placenta and a fused placenta. And whenever there is a fused placenta, what you find is that there will be an invagination of the trophoblastic tissue into the intertwin membrane, and that is what is called as the lambda sign or the twin peak sign. Am I clear? When you have this sort of a lambda sign or a twin peak sign, it's obviously a fused placenta, and a fused placenta has to be a dichorionic. Am I clear up till now? Because this concept has to be very, very clear and very, clearly understood. Now, this is a classical case where you can see, I will show you 1 second. Yeah. Now, what will you say? That is a classical twin peak sign or lambda sign, isn't it? So it's a dichorion or it's a fused placenta, right? Here, what do we have? Yeah. Oh, sorry. Yeah. Sorry. Yeah. Okay. Now here, what do you have? It's a T insertion. There is no lambda sign, isn't it? I'm sorry, I'll run the video, then you can understand it better. Right. See this? You can see the intertwin membrane nicely, and then you can see that it is just getting inserted into it. So it is a classical T insertion or a T sign. So whenever you have a T sign, it is a shared placenta. Let us start using this term shared placenta and a fused placenta so that there won't be any confusion in future. Okay, right. So then that is the one. Now, another sign which I have told you about the chorionicity is to measure the intertwin membrane. The intertwin membrane in a dichorionic twin is usually thicker or thinner? Thicker. Why is it thicker? Amnion, chorion, chorion, amnion. That is the reason why it is thicker. Whereas in a monochorionic diamniotic twin, it is thinner because it is only one chorion, one amnion. But then, if you try to use this particular feature to identify the chorionicity, quite often you will be wrong. The reason is because the tangent of the ultrasound beam is extremely important to identify the thickness. So if you are inadvertently going to insunate the ultrasound beam at an angle where you find that the intertwin membrane is thicker, then you will label it as a dichorionic twin. Am I clear? So that is the reason why we don't use. We corroborate with the features of the placenta, number of placentas or a fused placenta with the intertwin membrane, but we don't take the intertwin membrane thickness as a feature which will tell you the chorionicity. Am I clear up till now? Very nice. Okay. So that is subjective. And what we can do? This is a classical MOMO, isn't it? It's a transvaginal examination, more than 8 weeks of gestation. I can see both the twins there, and there is a single amniotic fluid there, and there is a single placenta. It has to be a momo twin. Okay. Now, these are other situations where you can find this sort of a situation where the cleavage of a morula has taken place only after 13 days. In that situation, what do we have? We have what is called as the conjoined twin. This is a conjoined twin where there is a thoracophagous. This is an omphalothoracophagous, which has been fused. So, okay. So these are the different varieties of conjoined twins that we come across. Now, so in order to get a complete understanding of this situation, it can be compared to what is called as the apartment analogy. What is this apartment analogy? Suppose we both are staying in 2 separate apartments with 2 separate kitchens and 2 separate bedrooms. Are we going to have problems? No. If we are trying to live in an apartment where there are 2 bedrooms, but there is a single kitchen, there is a possibility that there can be some friction. If suppose you are living in an apartment where there is only 1 kitchen and 1 bedroom, invariably we will fight. So that is actually the dichorionic, monochorionic, and monochorionic, monoamniotic twins are concerned. So this is as simple as that. If you can understand this, it is done. My job is done. Right. So what's happening? Okay. So basically, less than 10 weeks, what we do is we count the gestational sacs. 2 gestational sacs, dichorionic, single gestational sac, monochorionic. Count the heartbeats also in each sac. And then if it is more than 10 weeks, count the placentas, 2 placentas DC, 1 placenta DC or MC, because it can be a fused placenta or a shared placenta, and check the gender, which we are not allowed to. So he was very serious about it. When he was giving his lecture, I thought I was frightened to the way he was talking. Right, and then he's not there. Right. So then we can depend upon the lambda sign or the T sign. At the same time, we identify the thickness of the intertwin membrane. In the 3rd trimester, remember, it is very, very difficult to make out the chorionicity. If you can't make out, you just mention that it is a monochorionic twin. Don't venture to say that it is a monochorionic. You make out dichorionic, you say dichorionic, where there are 2 separate placentas. If you can't make out, treat them as monochorionic. That's a lesson which we have to take it. In the 3rd trimester, don't venture to do that unless you are very sure about the placentas. Am I clear? Right. Now, twin labeling. This is again an important factor because quite often nowadays what we are trying to do is we are not only trying to, we follow them up very regularly because twins have to be followed up very regularly. I'll show you how often we are going to follow them up, but then we need to follow them up very clearly. So we need to know which twin is what you are dealing with. Because not only that, if I do a scan at Hyderabad and send it to a Solapur, here you have to know which twin I meant as what is normal, what is abnormal, what was the growth pattern, all those things. Unless I label them and unless the labeling is understood by you, it will not be possible. That is the reason why you need to label the twins, right? We can label the twins based on the right side, left side, upper, lower. That's very conventional that we can always do. And we always label the twin which is closest to the internal os as the twin A or twin 1. Am I clear? Right. Now, there are certain situations where you can also make use of the insertion of the card and say that the insertion of the card has taken place. Of twin A, the card is inserted at the lower part of the placenta. Twin B, the card is inserted at the upper part of the placenta. If you have two separate placentas, you can say that the card of the twin A has been inserted in the anteriorly placed placenta, or the twin B, the card is inserted in the posteriorly placed placenta. That is another way. Another important way is you can take the intertwin membrane and say the insertion of the intertwin membrane, depending on the intertwin membrane, is it lower to the intertwin membrane or above the intertwin membrane? So these are all the various ways by which you can label these twins. Am I clear? Am I confusing you more? Right. So that is one aspect of it. The second important is, suppose you are working in an institute where your own patients, that is your gynecologist, sends to you, and again you do it, scan and send them back. Then you can have a good understanding between your gynecologist and yourself, saying that all twin A's are on the right side, all twin B's are on the left side. So whenever the twin is on the left side, you call it as twin B, and whenever the twin is on the right side, you call it. But then, if I am doing as an individual practitioner, if I say that all twins are on the right side or A and all twins are on the, you will get confused. So that is the reason why it is not possible. It is only in the institutions that it can be possible. Now, the problem comes when there is a discordant twin. That is when it is important. And if you find out a discordant twin, particularly a recipient, which is potentially a recipient, you always label it as a twin A. That becomes much more easier for the next person who is going to take over the case. And then for you also, tomorrow when you are re-examining the patient, it becomes much easier for you to identify that all the recipients are labeled as twin A. Is that clear? Right. Now, labeling of a momo twin is always inaccurate because you don't know, they keep on moving. So it's not possible to label the momo twins. Now, I think all of you, one time or the other in your lives, you would have got into what is called as the perinatal switch phenomena. Am I correct? Yes, no? Right. This perinatal switch phenomena comes only when you are doing a LSCS, that is sections. What does this mean? I have labeled twin A as an abnormal twin. Let us say the twin A has got a congenital diaphragmatic hernia. Twin B is absolutely normal. Okay. Now you deliver it by the babies by cesarean section. Both the twins appear normal. So you are completely bowled. Then you might have taken the twin B, which got switched into twin A, and that you have delivered. That is the reason why, keeping this in mind, they have suggested that whenever you have this sort of a situation where you are going to do a cesarean section, where you have an abnormality which is not obvious externally, in that situations, before the section, you need to evaluate the twins, you need to identify the discordant twin, discordant anomaly, and then do the cesarean section. After the cesarean section, in the postnatal period, once again, you have to postnatally evaluate these babies. Am I clear? That is the reason why it is essential to understand this the perinatal switch phenomena. Am I clear? Because this is again, you are going to get into this trouble one day or the other. If you have not already gotten, you will get it. There is no doubt about it. So please understand this. Okay. So this is one more thing which, so whenever you are planning to do a cesarean section, particularly if the report says that there is an abnormal fetus, a discordant anomaly, it is always better to do a pre-section scan and a post-section postnatal scan in order to identify the abnormality. Right. Now, timing. How often are we going to do these scans? If it is a dichorionic, it's considered as a singleton, isn't it? Most of the dichorionics are considered as singletons. Okay. So you do 11 to 14 week scan, date the pregnancy, identify the chorionicity, screen for trisomy 21 or the aneuploidies. Then you do a 20 to 22 week scan to assess the detailed anatomy, because it is called as an anomaly scan. You do a biometry, amniotic fluid volume, and cervical canal length. Then between 24 to 37 weeks of gestation, you again do the assessment of fetal growth, amniotic fluid volume, and do the fetal Dopplers and deliver. So this is the protocol that you are going to follow, or timing that you are going to follow as far as the dichorionic diamniotic twins are concerned. Whereas in a monochorionic, monoamniotic twins, your approach is entirely different because you know that there are certain unique abnormalities that you can come across. So as usual, in 14 weeks, 11 to 14 weeks of gestation, you again do the dating scan chorionicity as well as the screening for aneuploidy, wherein once you have identified the chorionicity as a monochorionic twin, then your timing chart varies. So at 16 to 18 weeks of gestation, you are going to assess the fetal growth, because selective fetal growth restriction is known to happen with monochorionic because there is an unequal sharing of the placenta. Am I clear? Right. So unequal sharing of, so fetal growth is important. Not only that, there can be fluid change. Not only that, there will be a recipient and a donor. In these situations, what happens? You need to identify the vascularity or the hemodynamics of the fetus, particularly the ductus venosus. Previously, we used to categorize by Quanteros staging, where presence of bladder, absence of bladder. But now we don't do that. We still do that, but then that will be too late by the time you identify the twin transfusion and send them for a laser coagulation. So in these situations, what we do now is we try to do the ductus venosus because, as you all know, whenever there is an unequal sharing between the donor and the recipient, it is basically because of right heart overload. So what is your idea is now you need to identify the preload and afterload on the ductus venosus because the brunt goes on to the right atrium and the ductus venosus is the one which reflects on that, and the ductus venosus sampling is the most important thing which tells you whether this particular fetus or in the two fetuses, one of the twins, that is the donor as well as the recipient, the difference between and when to subject them for fetoscopic laser ablation. That is so. So at 16 to 18 weeks, you do a ductus venosus sample as well as the uterine artery sampling. At 20 weeks of gestation, do the anomaly, biometry, as well as start sampling the umbilical artery, ductus venosus, and middle cerebral artery also, because now you know that you can get into what is called as the TAPS, that is twin anemia polycythemia. So you need to sample the middle cerebral artery to identify the presence or absence of the anemia. Am I clear? So these are all very, very important factors. And remember, if you see this chart, every 2 weeks you need to interrogate them. That is an extremely important. So once you have identified a monochorionic twin, please ask the patient to come back for a Doppler examination every 2 weeks. I know it sounds very difficult, but no, to safeguard yourself, you need to ask them, because tomorrow they can always say that you didn't ask us to come after 2 weeks. So that is better that you ask for a 2-week scanning, a 2-week interval scan, so that you will do the Dopplers, identify everything, identify the discordant anomaly or discordant growth, and based on that, you can plan the management, right? Now, coming to the second outline. Second outline is, I'm not going to deal with the, twin monochorionic diamniotic unique abnormalities because it's going to take a long time. And not only that, I'm not going to deal with multi-embryo reduction or the cell-to embryo reduction, but then I will just take you through the important factors which you need to look for as a diagnostic sonologist. So screening of aneuploidy, prenatal diagnosis of aneuploidy, screening for structural abnormalities, diagnosis and management of discordant twin pregnancy, reduction, selective reduction, and preterm birth. So these are the factors that we are going to deal with. Now, whenever there is a screening for aneuploidy, it is just like the preterm, first trimester scan, the first trimester screening procedure. Whenever you have a DCDA, you take as a singleton and try to evaluate them based on the nuclear translucency, maternal age, as well as the serum beta HCG and pre-beta HCG, as well as PAPA. So this is one. Second thing is, when you do the screening for aneuploidy in twin gestation, if it is a MCDA twin, that is monochorionic diamniotic twin, the twin is calculated per pregnancy. Why? Because it is the same karyotype. So you don't need to separate them off. You take it as a single prior pregnancy, take the average of both the nuchal translucencies, use the combined screening, and risk stratify. Am I clear? Because this is a practical problem which we are going to face. Okay. So if you have a monochorionic diamniotic twin, you need to treat them as a calculated per pregnancy because it is the same karyotype and because there is no different zygotes. And at the same time, you take the average of the nuchal translucencies, put the combined screening and try to stratify this risk. That is one. If it's a DCDA, it is just like any singleton. So you don't need to really. If you take the detection rates in singleton, the detection rates by taking combined screening as well as the NT is almost 89%. DCDA is 86%. MCDA is 87%. False positive results are FPR is about 5%. So this is how you're going to as far as the combined screening plus nuchal translucency or the ultrasound marker is concerned. Now, invasive testing. How often? Yes, in twins we do quite often more number of invasive tests than the singletons. That is one. And the risk is also higher in twin invasive testing. And now we have what's called as the cell-free DNA, which has a detection rate which is higher and the false positive rate which is lower. The detection rate is as high as 94.4, whereas the false positive rate is almost 0%. So that is the reason why we need to go in for NIPT. Now, if it is an NIPT, in a monozygotic pregnancy, such as the MCD or a MOMO, where twins have identical genomes, the NIPT is very effective in identifying trisomies because once you have done an NIPT, you know that there is a abnormal NIPT or a positive NIPT, you know that there is definitely, and the karyotyping will be the same. So because of the karyotyping being same, oh, it's not seen. What happened? Am I boring you? I think the computer got bored. Okay, so whereas in a dizygotic twins, two fetuses are identical, may be discordant and haploidy. So release of different amounts of DNA, this is very, very important. And remember, total free DNA, cell-free DNA is about minimum of 4%, but it will be definitely more than 8% as far as the multiple gestations is concerned. And the lower the free cell-free DNA fraction is considered to be an abnormality, and which is called as the SNPs, SNIPS, which is the one which is used to separate off between the twin A and twin B and identify which one is the lower percentage of the cell-free DNA, and that lower percentage of cell-free DNA is identified as the abnormal or a discordant abnormality or aneuploidy. So that's how you diagnose using an NIPT. So NIPT is going to stay with us, and it's going to be of great help in identifying not only in the singletons but also in multiple gestations. Now, invasive testing, as I said, the reason why we do invasive testing is that to confirm your diagnosis, particularly when you have an NIPT, which is a screening test, which is not a diagnostic test. So you need to do an invasive test to confirm the diagnosis. And if you confirm it late in pregnancy, then what happens is the risk of inadvertent losing of the fetus is almost 14%. If you do it early selective reduction, then the rate of losing the inadvertent losing of the fetus is only 7%. But then the invasive procedure, particularly in the form of an amniocensis, should not be done before 15 weeks of gestation. I would prefer to do it only after 16 weeks of gestation. The reason is that when you do an amniocentesis and when you try to evaluate the karyotyping, you need to have the cell agglomerate, that is cell content. If the cell content is less, it becomes very difficult for them to culture. That is the reason why it is better to do it after 16 weeks. Why not before 16 weeks or why not before 15 weeks? As we all know, early amniocensis is abandoned in the sense because it is associated with limb reduction defects. That is the reason why we no more do a early amniocensis. If at all, if you want to do an early invasive procedure, it is the CDS that you are going to do. And in a monochorionic twin, as there is only one single placenta, you can do a monochorionic gut placental sampling. If it is a dichorion, you need to take from both the placentas the sample. Am I clear to now? Right, and this is the same thing which I have already said. Okay, screening. Oh yeah. Well, okay, right. Fine. I'll finish off. No problem. So screening for preterm birth. This is one of the common problems that we come across as far as the multiple gestation is concerned. As we all know, in twins, it is about 60% of the time the delivery occurs around 37 weeks, 12% of the times it is 32 weeks. Whenever there is a short cervix, what do you mean by short cervix in a multiple gestation? Less than 25 millimeters. It predicts preterm birth before 34 weeks. If the cervical canal length is less than 20 millimeters, then it's a good predictor that there will be a preterm delivery at 32 weeks of gestation. So this is one important. So this is the chart that we need to remember. When there is an exponential reduction in the size of the cervical canal, the possibility of preterm birth is very, very high. For example, if it is less than 15 millimeters, the incidence of preterm delivery is almost 66%. If it is 46%, or no, 26 to 35%, the incidence of preterm delivery is only 6 to 7%. So this is one thing, again, we have to be very clear in our thought. Now, coming to the significance of chorionicity, why do we know? We need to know because the presence of complications in the form of miscarriage, perinatal morbidity, mortality, preterm delivery, fetal growth restriction, selective fetal growth restriction, and major structural abnormalities. If you take singletons, the incidence of miscarriage is only 1%, whereas in an MCDA twin, it is almost 10%. So similarly, prenatal, postnatal mortality is about 5%, preterm delivery is 10%, selective fetal growth restriction is 30%, major anomalies is 4%. So that is the reason why we need to identify the chorionicity, and that is basically because of imbalanced blood supply, which results in all other abnormalities, unique abnormalities. And the structural abnormalities, remember that in a dichorionic twin, it is only 1 in 25 twins, in 1 in 25 pregnancies. In a MCDA, it is 1 in 15 pregnancies. In a MOMO, it is 1 in 6 pregnancies. So this is another important thing that we should keep in mind. And not only that, try to evaluate them as early as possible, because now with the transvaginal examination, we are now able to make out most of the structural abnormalities. But remember, a word of caution is that please reconfirm at about 18 weeks, and then only try to advise them counsel them regarding the termination of pregnancy. So that is the take, I think the take home messages I've already said. Thank you very much.
Excellent presentation and absolutely a fantastic strategic approach to pregnancy. Are there any questions?
You mentioned about the slips in
Yes. There is the slips is the one which they use in order to identify the percentage of cell-free DNA. No, I couldn't get you. Sorry. Most of the, I think. No, you have to ask for it. No, you have to ask. You have to mention that this is a twin gestation. You have to ask, say that this is a discordance, or in case if there is a discordance, say that there is a. Then only they will do it. Why? I mean, to me, I think. No. I tell you, LifeCell does it. Newberg does it. But then you have to ask them. If you just send them, they won't do it. As you said, they will do a parallel sequencing. They won't do a slip sequence. You see, without slips, you cannot. You cannot. Yes. Yeah.
How early can we
Pardon me?
How early can we
Taps. Trap very early. 10 weeks. 10 weeks. But you see, basically, you don't go by the vascularity at all. It's an abnormal looking fetus. A cardiac. You don't find the cranium. So that's how you diagnose it.
Thank you very much, sir.
Thank you, sir.
Thank you, chairpersons. May I request Dr. Rohini Deshpande, madam?
Thank you, sir. One of the slides I liked very much was the time interval for monitoring the twin pregnancies. It will be easy for us to counsel your patients and show them in writing that this is the time interval you have to come for follow-up, and that will make our job very easy, sir. Thank you very much.
Thank you.
May I request Dr. Rohini Deshpande, madam, and Vaibhav Meru, sir, to felicitate our speakers, Dr. Praveen, sir, and Dr. Megha, madam. Thank you, chairpersons, for conducting such wonderful session. May I request Dr. Milin Shah sir to felicitate Dr. Rohini Deshpande madam. May I request Dr. Gurram sir to felicitate Dr. Vaibhav Meru sir.
On behalf of myself and Dr. Meru, we would like to thank Dr. Aboli Velankar, President of SOGS, and the entire team for such a beautiful conference and wonderful academics. Thank you.
Thank you very much, madam. All are requested to join for lunch. We will be meeting at 2:30. We will start with the presentation by Mindray.
Good afternoon, everyone. We are starting in 5 minutes with presentation by Mindray.
Good afternoon, everyone. Please take a seat. We will be starting shortly with the afternoon session. Good afternoon, everyone. Good afternoon, everyone. I request all the delegates to please take a seat. There is a Mindray product launch, so I request the Mindray and company to take over.
Yeah, good afternoon, everyone. Welcome you all again to this wonderful session. So first and foremost, I like to thank Solapur Obstetric and Gynecology Society for giving us a wonderful opportunity to get associated with you. And also with this association, we like to do a lot of more programs in future to increase the clinical awareness. So again, just for a small duration, we like to introduce a new product in a Mindray product portfolio, something known as DC80A with our XInsight platform with a tagline of insight and intelligence. So XInsight is a new platform with the introduction of a dual core engine. With a graphics processor, we can now render out 3D, 4D images around 3 to 4 times much faster compared to a traditional imaging. So this is a technology we're calling it iLife Pro, which is a very popular in the 3D, 4D market. And it gives a realistic approach to if you're doing a 3D, 4D imaging, especially for your fetal face and 3D structures. Combined with the iLife, we have introduced something known as Hyalin, which is basically a transparent mode, which will give you a much detailed view of our internal structures of our 3D anatomy. So whenever we are doing any 3D structure or taking any in the section of the fetal face, so there's a lot of obstructions and occlusions that comes in front of the face. So this is a new solution that we have introduced, something known as Smart Face. With just a one-touch optimization, one-touch operation, you can just remove the any umbilical cord or any occlusions in front of the face, which is a much faster approach to get a much better face profile. So this is another like a breakthrough in the color Doppler imaging technology, something we call it glazing flow, which is a 3D, 4D approach of a color Doppler technique. Again, Smart Planes CNS. This is our a technology we generally, which is a little on the artificial intelligence part, where we just need to take a normal BPD sweep and machine will give you the standard 4 sections of the fetal head. That is the cerebral, thalamic, and the ventricle section. Along with that, we can get the automatic calculation as well as the annotations. The same concept has been used for fetal heart also. You just need to take a routine section of the 4th chamber and machine will give you the standard 6 views of the fetal heart. And not only in obstetric, we are now innovating a technology in pelvic imaging also. So Smart Pelvic is Mindray's unique smartness solution for the dysfunction evaluation of the pelvic floor. It provides automatic evaluation packages for your anterior compartment and the anal levator hiatus. And of course, if you're familiar with HICOSI, this is a 4D and the 3D approach for hysterosalpinography done with the contrast agent. It is a simple and well-tolerated ultrasound procedure to use to assess the patency of the fallopian tubes. And of course, this is a little, we familiar with this technology. We're calling it the Smart FLC. You just need to take a routine sweep of your ovary and machine will calculate all the sections of the follicles along with the smart chart where you get the dominant follicle and all the follicles volume. And these are some of the very fantastic images that are captured in this machine. And you can see that there are 3D structures and also anomaly structures also. And our vision and conclusion of DC80 is it's a flagship model of the XInsight series. And it's a new solution of a high efficiency with a precision imaging. Thank you. So not on further ado, I'd like to call upon some of our guest speakers for the product launch. Dr. Anuruddh Kulkarni, sir. Sir. Dr. TLN Praveen, sir. Dr. Ajit Gandhi. Dr. Megha Kamlapurkar, Dr. Rajesh Farkule, Dr. Vevar Maru sir, Dr. Aboli Velankar, Dr. Archana Shah, Dr. Rajiv Davre, and Mr. Suhas Nanivarika to the stage to launch for the machine. And Xavier also, please.
You must make people who are going to buy, not people like us. Isn't it?
Definitely.
Sir, Praveen sir, please. No, sir, please. Global,
I request Dr. Aboli Velankar madam to please felicitate the Mindray and team. Velankar madam, please felicitate Mindray and team.
Thank you, sir. Thank you.
Excuse me.
Okay.
Mindray and team, can you please come on stage? Now we move on to our third session. For this, Dr. Rajesh Dabde sir, dear chairperson. Sir is a consultant at Ashwini Sarkari Rugnalay and at Ashwini Rural Medical College, Kumbari. He is the owner of Krishna Mai Nursing Home, director of Navjivan Infertility and IVF Center. Welcome to sir.
I request Dr. Rajesh Farkule sir for this session as a chairperson. He had a distinction rank first in Shivaji University, worked as assistant lecturer, Dr. VMMC Solapur, worked as consulting radiologist, Varia Charitable Hospital, started own center, Solapur Diagnostic Ultrasound, X-ray, CT scan, and pathology, working as an interventional radiologist in Yashodhara Hospital, and done more than 5,000 renal biopsy. Thank you, sir. Hand over to you.
to continue our post-prandial session, may I invite Dr. Megha Kamlapurkar madam to give a speech on fetal environment ultrasound perspective.
respected chairpersons, faculties, and my friends. After talking on a very vibrant topic of fetal heart, talking on fetal environment, that too in a post-lunch session and keeping the audience awake is really challenging. Let's see how I take that challenge. When I was told that you have to talk on fetal environment, ultrasound markers, I just started thinking about environment as such. And while going through the references, I found this term as environment impact assessment, which I thought it's very applicable for us as a fetal environment. So environment impact assessment is defined as environmentally beneficial activities undertaken to counterbalance an adverse environmental effect, aspiring to achieve no net environment loss or a net environment benefit or outcome. And for us, it's nothing but a healthy mother and healthy baby. So when we talk about fetal environment, I would like to dedicate this talk to great David Barker, whose Barker's hypothesis is very famous. And he was a person who had thought about fetal programming, the developmental origin of health and disease, Barker's hypothesis. So what happens in prenatal life is going to influence the health of an individual. And we care this fetal programming. We and obstetricians have a lot of responsibility to make the fetal environment conducive, not only for the prenatal care, but the future care of that baby. And this makes us aware of more and more responsibilities. And this is how we take fetal environment as a perspective with the interaction of fetus, mother, and placenta. When we talk about the fetal environment, we need to know this term, great obstetrical syndromes, which constitute the complex interaction between mother, fetus, and placenta. The term, the great obstetrical syndromes, was coined to refer to conditions with the following characteristics, like multiple etiologies. They should have multiple etiologies. They have a long preclinical period. They have association for adaptivity in nature, where there is involvement of fetus, and it's the result of complex interaction between the maternal and fetal genome and the environment. So these obstetrical syndromes or great obstetric syndromes are nothing but the disorders of deep placentation. They include preterm labor, premature rupture of membranes, preeclampsia, small for gestational age or fetal growth restriction, large for gestational age, diabetes mellitus, and stillbirths. And this is the major chunk of etiologies for adverse fetal or perinatal outcome. I will be restricting myself for fetal environment only for ultrasound markers, because when we think of fetal environment, there can be a day, whole day can be dedicated for this topic. A one-day conference can be dedicated for this fetal environment. I'll be restricting for ultrasound markers, which we need to take care when we think of fetal environment. They are nothing but placenta, liquor, and umbilical cord. Placenta is the black box of prenatal journey, and we need to take into consideration the size of the placenta, thickness, the diameter or volume. Nowadays, the 3D machines with high resolutions and high-end machines, it's possible to calculate the volume of the placenta in first trimester. But on an average, we are interested in the size or thickness of the placenta, shapes of the placenta, location, hemorrhages related to placenta, placenta accreta spectrum of disorders, and placental masses. When we think of placenta, we are just worried about the separation of placenta when it separates, that's it. So we are not much worried about, we don't care much about the placenta in prenatal life, except for the location and placenta accreta syndromes. So placental thickness should be measured at the midpoint of the placenta, whole placenta, in longitudinal section. It's the distance between the chorionic plate and basilar plate. We have to be aware of fibroids or myometrial contractions and venous legs that should not be included while we measure this placental thickness. On an average, the placental thickness in millimeters corresponds with the gestational age. So obviously, placenta should never be more than 40 millimeters. 40 weeks gestation, 40 millimeters should be the higher limit for the placental thickness. And if we come across bigger placentas than this, then we have to, it's an alarm for us to look into the fetal anatomy and details of the fetus. Here again, Barker's group attaches a lot of importance to the placental size as a predictor of hypertension in middle age. It's really interesting. So we do from henceforth onwards, I'm sure, at least our PGs, they will start looking into the placental thickness, and we'll have more and more insights about the placental thickness and the fetal health as such. So when placenta is more than 40 millimeters, we call this as a placentomegaly. And then this is common in diabetic pregnancies or fetal growth restrictions or fetal CMV infections, chromosomal abnormalities or non-immune hydrops or maternal and fetal anemia. In case of big placentae, more careful examination of the neonate also is advised, though pregnancy outcome is normal. So whenever we have a big placenta, we need to consult or we need to talk to pediatricians that look into the baby in a broader perspective, because the placenta was very thick. And I here remember our great teacher, Dr. D.V. Kudukar sir. He never used to leave us unless we used to mention about the placenta in delivery notes. So he used to ask us what was the placental size, how was that, and was there any abnormality? And if we failed to that, we were heavily punished. So even for normal deliveries or after cesarean section, looking into the placenta is very important, because that is going to record the antenatal events. Various shapes of the placenta are described. We can see various shapes on ultrasound also, like circumvallate placenta or filamentous cord incision, succinturate lobe of the placentas, because these shapes are high risk factors for preterm delivery, abruption, fetal growth restriction, and sometimes retention of placenta and even vasa previa. Filamentous insertion of the cord, where cord inserts into the membranes, between the membranes, amnion and chorion, rather than directly entering the placental tissue. The incidence of this in normal pregnancy is 1%, whereas in monochorionic twins, it's very high, about 15%. And it is associated with fetal growth restriction and intrapartum fetal heart abnormalities. So placenta, filamentous insertion, we can see here placenta, the cord is getting inserted at the end of the placenta. And here in this picture, we can see the vessels of the cord entering the membranes than directly entering the placental tissue. Other variation is vasa previa, where the normal incidence of vasa previa though is very less, 0.04%, but it's a deadly variation, because it's it's associated with very high perinatal mortality. The risk factors for vasa previa are resolving second trimester low-lying placenta. If we see low-lying placenta in second trimester, and if it migrates in third trimester, but still we have to look at the level of cervix and confirm that nothing is there. So in just above the internal os, if such lines are seen, just put the color and confirm, is it not a vessel or is it a vessel? Succinsurate lobe of placenta, filamentous cord, multiple pregnancy. And as I said, echogenic lines above the internal os, they give us an alarm to look into this condition as vasa previa. This is very important, and the early diagnosis is important before the lady lands in labor and membranes are ruptured, because it increases the fetal death, and it as the membranes are ruptured, the fetal death is up to 97%. Whereas if we take care or we opt for elective cesarean section, the fetal survival chances will be more before the rupture of membranes. So key is to prevent an adverse fetal outcome and offering the lady an elective cesarean delivery before membranes rupture. What is the differential diagnosis for this vasa previa? It's a cord presentation, or the cord which is lying over the internal os. But we can see that the cord moves with the changing position of the mother. And for this, we need to reschedule the examination. So if we see a cord just above the internal os, just call her after some time and again do TVS and then see still that cord is there, confirm. Otherwise, for just cord presentation, or otherwise, if the loop of the cord is there, it may get displaced after some time. Regarding the placental masses, chorioangiomas are the commonest one with incidence of 1%, though they are benign tumors. They are hypoechoic and may show calcification. These are hypoechoic mass in the hyperechoic placenta. The differential diagnosis can be myomas or large venous legs or placental teratomas or incomplete mole. They are often third trimester surprises, and every time Doppler doesn't come for help, and it can be deceptive. Chorioangiomas, normal outcome is very well known, but more than 5 centimeters, they have poor prognosis, and the complications are because there is AV malformation. It works as a AV malformation, and therefore this is a high output state for the fetus. It's associated with polyhydramnios and preterm labor, fetal growth restriction, IUFD, non-human hydrops, and therefore the treatment for this is laser devascularization. And when we see such chorioangiomas in our scans, we need to have detailed structural survey of the fetus. These placental cysts are very common. They are subchorionic or subamniotic membranous cysts, simple cysts, and they are commonly associated with diabetes mellitus or fetal maternal RH incompatibility. One large cyst, but only large cysts, they have association with fetal growth restriction, otherwise they are benign. Differential diagnosis is venous legs, where we can see a flow on Doppler. Another important aspect for placenta is placental abruption, and it's very difficult to diagnose placental abruption on ultrasound. But we can see that placental abruption is there and ultrasound can be normal. This is possible, but the role of ultrasound here is not for the diagnosis, but it's for the management of the patient who are conservatively managed by the obstetricians. What are the clues on ultrasounds? They are bulky, enlarged, thick placenta, or sometimes we can see retroplacental or retromembranous clot. Sometimes we can see an organized clot, which is, of course, echogenic. There can be intraplacental anechoic areas or subchorionic hematomas are more common before 20 weeks of pregnancy, whereas after 20 weeks, retroplacental hematomas are more common. Myometrial contractions and myomas can mimic with placental abruption, and we need to take care for that. Placental infarction, some disturbance. Okay. So placental infarction is, of course, histopathological diagnosis. It's ill-defined area, hyperechoic area in placenta we can see. They are also associated with fetal growth restriction, PIH, preterm pregnancies, if they are large in number. But if they are small, they are insignificant. The location of placenta, we are really worried about and we need to comment in our scans. Placenta previa is a new classification of placenta previa, describes placenta previa complete as os completely covered by the placenta. Whereas incomplete is placenta partially covers or just reaches the os. And low-lying placentas are when the lower edge of the placenta is within 2 centimeters of internal os. Generally, low-lying placentas, they migrate in later part of the gestation. When one of the studies have come out with this observation that placental edge distance from the internal os matters. When this distance is more than 2 centimeters, the chances for or indication for cesarean delivery is not per se for placental location. Whereas if the distance is between 11 to 20 millimeters, there is low likelihood of bleeding, antenatal bleed, and low need for cesarean deliveries. If the placenta is within 10 millimeters or 1 centimeter of the os, there is high likelihood for bleeding and high chances for cesarean, high need, chances, better than chances, it's the need for cesarean delivery. And when it overlaps the os, cesarean section is absolutely indicated. But when placenta is posterior and if it is a vertex presentation, the lower margin of the placenta gets concealed, especially on transabdominal ultrasound, and we may overlook the placental low-lying placentas. For these cases, always have habit of having transvaginal sonography for this patient. Placenta previa, placenta posterior, lower edge not reachable, straightway go for TVS and confirm the placental location to not to miss the posterior low-lying placenta. Morbidly adherent placenta, as a lot of discussion was there since morning, I will just skip through these slides. One important point is first trimester low implanted sac, always, or previous cesarean section, always have in mind this possibility of morbidly adherent placenta. Certain ultrasound features, they have also been described by Praveen sir. So I'll just skip and we'll come to the lifeline of the fetus is umbilical cord. Umbilical cord abnormalities are as such underreported because we don't look into umbilical cord much, rather than we just mention the cord vessels and that's it. Generally, interesting fact is that at 8 to 10 weeks, the length CRL is equal to the length of the cord. Normal cord has 2 umbilical arteries and 1 umbilical vein, which is surrounded by Wharton's jelly, which gives cushioning effect and prevents the compression of the umbilical cord. The average length of the cord is 60 centimeter and less than 32 centimeters or 30 to 32 centimeters, we call it as a short cord. These are very important features. We cannot calculate cord length on ultrasound, but we postnatally, we can just look into the cord length. We were supposed to do that exercise in labor room by Kudukar sir. We had a tape, then we used to measure the cord length and he used to randomly call us and ask what was the cord length for this patient. So this is important because cord length is dependent upon so many factors. I'll come to that in the next slide. So cord thickness, when we say take a transverse section or axial section of the umbilical cord, so always we have to measure that cord thickness near the fetal end, and there are normograms available. Generally large cords and preeclampsia are associated, lean cords, small cords and preeclampsia are associated, whereas thick cords are seen in diabetic pregnancies. Thickness of cord more than 95th centile between 10 to 14 weeks is significantly associated with aneuploidies. I have not encountered, but I have this reference. We'll keep on seeing the diameter of the umbilical cord at NT scan also. As I was saying, that cord length is very important because the length of the cord is determined by the amniotic fluid and fetal movements. And sometimes it can be hereditary. Miller and Associates, they have identified cord to be short if the fetal movements are less. So when are the fetal movement less? The movements can be less in cases of oligohydramnios or limb abnormalities or fetal hypokinesia syndromes. So these short cords are associated with adverse perinatal outcome, fetal growth restriction, and abruption. Whereas excess cord length are because of excess movement, fetal excess movements, and these cords are at the risk of having cord knots. The cord length, as such, total cord length, we cannot predict by ultrasound, and there are such attempts to comment about the coiling index. So coiling index can be prenatal and postnatal, or antenatal and postnatal, where we can start counting the distance from this artery to artery, umbilical artery to artery, and one by this distance is nothing but the umbilical cord coiling index, which is there in the antenatal. We don't do that, just eyeballing is enough. We can just by eyeballing we can tell this is hypocoiled cord, or we can see that this is hypercoiling of the cord, which are very important. Hypercoiling and hypocoiling of the cord, they have increased incidence for fetal demise, intrapartum fetal decelerations, operative deliveries for fetal distress, and they are also associated with anatomic karyotyping abnormalities and chorioamnionitis. So if we find such cord, then we have to be little careful about the management or about the pregnancy monitoring. So cord knots, of course, true cord knots are very difficult to predict on the prenatal ultrasound. Cord clumping can give a clue, but we cannot diagnose this with confidence. The abnormalities of the cord insertion, we have seen that normally inserted cord is in the center of the placenta, and we can document that cord insertion in the placenta in our images. So where we see that the cord is marginally inserted, or we can see that Furket insertion scene, or filamentous cord insertion, or vasa previa. So if we have a habit of looking at the cord insertion site, we'll be able to pick up these abnormalities. Umbilical cords is, we often come across such pictures, beautiful pictures as we see in first trimester. These are, they regress generally spontaneously. They are of two types, true and pseudocyst, and sometimes they are associated with T13 and T18 trisomies, omphalocele and patent urachus. So we cannot just ignore them. Umbilical vein varix, when caliber of the umbilical vein is more than 9 millimeters, and if it is isolated, the prognosis is good. But there is a prevalence of congenital chromosomal abnormalities in 12% and IUFDs in 24%. When we see the umbilical cord varix, we can measure the thickness and see the aliasing here at the site of insertion of umbilical cord in the fetus. So Doppler differentiates this from hepatic cystic lesions and colorectal cysts. Whenever there is an umbilical varix, close monitoring of the pregnancy and careful search for other fetal abnormalities is mandated. Persistent right umbilical vein, we know that left umbilical vein is there and right resolves. So ultrasound features, we can see that this is a stomach, spine, and this is a curve of left umbilical vein. But what will happen, and gallbladder is here, but what will happen in persistent right umbilical vein, the gallbladder will come between the right umbilical vein and stomach. So always go on seeing where is the gallbladder. Is it after the umbilical vein, or it is in between the umbilical vein and the stomach? And it is associated with highest fetal abnormalities. Otherwise, isolated has a good prognosis. Single umbilical artery is a major concern. Of course, it's only one umbilical artery which is seen that can be confirmed at the level of this bladder. And generally, it is seen in 0.3% of the normal cases, whereas it is associated with perinatal deaths in 1.9%, and it's in twins, it is up to 3%. But the incidence is more common in women with diabetes or liker abnormalities and other chromosomal abnormalities. Important is that about 30% they have chromosomal abnormalities. So when we have single abnormalities, we need to have a fetal survey for the chromosomal abnormalities. Almost all, practically no system is spared to look for if we come across single umbilical artery. Nuchal cord, this is the most controversial issue as far as reporting is concerned. It is to be reported or not reported, but with increasing incidence, For this incidence of cesarean section, for this indication, we need to rethink about reporting of this nuchal cord, especially to the couple or the relatives. If they see in the report that nuchal cord is there, they themselves will opt for elective cesarean sections. So this is a small flow chart. I'll not go into details because of the time constraint. You can take a picture and we can just have practical tips from that.
Madam,
amniotic fluid.
Your last 2 minutes and 35 seconds.
Okay. So amniotic fluid is a major concern for environmental influence on the pregnancy outcome, and abnormalities of the amniotic fluid are oligo extremes, oligo or poly. I want to give a very important message here is that rather than relying for amniotic fluid index, always rely for mean vertical pocket of the single vertical pocket where there is no any limb or cord is not seen during the measurement. And 0 to 2 centimeter single vertical pocket, we call this as an oligohydramnios. 2 to 8 is normal, and more than 8 is of course polyhydramnios. So when we come across oligohydramnios, because of time constraints, you can click the picture. I can skip this slide. So these are the very important conditions. When we see very less liquor, the most probable cause is rupture of membranes, leaking, normal fetal growth and normal Dopplers and normal fetal anatomy will be there. The cause of oligohydramnios here is just the rupture of membranes. Whereas we can see urinary tract abnormalities like renal agenesis when it is by abnormalities in oligohydramnios with normal Dopplers. So if oligohydramnios is there, Doppler is normal, always suspect some chromosomal abnormalities and accordingly offer the test to the couple. Polyhydramnios, as I told, MVP more than 8 millimeter, there can be either impaired swallowing or there can be excess urine production. So when there is impaired swallowing, like GI obstructions or neuromuscular diseases or craniofacial abnormalities, where the swallowing is not proper, then polyhydramnios will be seen. Or if there is excess urine production, like urinary UPJ obstruction or Bartus syndrome or mesoblastic nephroma or cardiac structural abnormality, tachyarrhythmias, or choreoangiomas or osmotic diuresis in pregnancies like diabetes, hydrops, idiopathic, we can have polyhydramnios in such cases. The approach to the polyhydramnios should be, if we come across polyhydramnios, look for the fetal growth. If there is excess fetal growth or are there any signs of fetal infection, anatomy of the face, rule out clefts, placenta, look for the placenta, look for such choreoangiomas, look for the fetal movements for the neurological function, then look for the positioning of the limbs, arthrogryposis, you have to rule out. Positioning of the neck, is there any neck mass which is obstructing the swallowing of the fetus? Or look for the fetal kidneys, lower spine and pelvis to rule out sacrococcygeal teratomas. Polyhydramnios, the difficulty is that the fetus is deeply sunk and the distance between the transducer and the fetus is very high, and it's very difficult to comment upon the abnormality as such. Anterior placenta adds to the problem. We can just opt for high penetration mode in such cases and get into the details of the fetal anatomy. Amniotic fluid content, particulate matter, we can such amniotic fluid is anechoic, but particulate matter can be seen, severe particulate matter which can be seen in dermatological disease like ichthyosis, where the liquor can be very high. This was a case where liquor was too thick and I could not say anything, and postnatally we could see that this is a minor form of ichthyosis which we could not predict by any ultrasound feature on, for this baby. Amniotic bands, they originate from wrapping of the chorioamniotic membranes and uterine synecdoche. Amniotic band syndrome is a serious disorder. On the other hand, which results in multiple skeletal abnormalities, chest abnormality, compression, and because of the entrapment of the fetal parts. So fetal environment gives us clues regarding the future health of the fetus, and we need to care for it, and we need to be environment friendly for the fetus. Thank you. Thank you very much.
Thank you, madam, for your talk. Unfortunately, he's not with us, but I would really thank Dr. Kurdukar for punishing you for not looking at the placenta and the cord. Otherwise, we would not have had such a good presentation from you. Thank you very much. As the chairpersons, we take the privilege to reschedule the program, and I request Praveen sir and Aniruddha Kulkarni sir to proceed with the question answer and the case-wise discussion, which will be followed by talk on MUSA by Dr. Aniruddha Kulkarni.
No, but see, it will save 30-40 minutes so that sir can move faster to Hyderabad. That was the basic intention behind that, nothing else.
मैं तो करा
Recording in progress.
So we'll start with interesting question.
Answers from us as far as ultrasound is concerned. So in case of a difficult scenario in terms of
Either clinical history or the ultrasound findings.
And unless and until we follow the previous cases in a meticulous fashion, then only you can do the better job eventually in the next cases. So this is what usually the scenario is. The aim to chase those cases is that it increases the level of confidence when you see the similar kind of imaging findings in due course of time. At the same time, in your own academic credentials, you can have good cases with a complete follow-up, as Dr. Megha has done a few of the cases, including the out-of-source. So it's always good to get good follow-up of what you have given on ultrasound. It's always better. So we'll deal with two clinical scenarios in which there is a huge solid dwelling mass, and primary impression is that probably this doesn't look like a fibroid. That is clinical scenario number one. And the post-MTP, particularly post-MTP with either bleeding or some degree of other sequelae that can happen because of post-MTP. So these are the two commonest headache entities as far as imaging guy is concerned, and similar it is for the clinicians as well. So these two entities I will deal with, and few of the complex fetal conditions Dr. TLN sir will deal with. So this was a 48 years female protruding mass at the vaginal introitus, and at the vaginal introitus the clinician says that there is something which is ballooning out at the external os, and she can palpate that, and it was a very soft or voguing situation. So I did ultrasound, and then I realized that the uterus entirely was lifted anterosuperiorly because of the mass which was there, which was seen on transabdominal scan. Then I realized that transabdominal scan alone may not be suffice for giving the answer. So perform the transvaginal ultrasound. Then I realized that it was a huge, completely solid mass. There were a few vessels which were appearing like a pedicle, but at the same time, we were showing some branching, but that branching was not arising from the primary vessels which was seen within the vessel. So it was a completely solid looking mass behind the uterus. So we were thinking what it could be. So eventually, this was the comparative between a grayscale ultrasound and color Doppler. Then we asked for one of my friend, Dr. Sharad Konde, for MR. So he said that there is a mass definitely which is behind the uterus and again protruding outside, but the mass is having variable appearance on MR as well as on CT. It takes a lot of contrast, but still he was not very sure in stating that probably there is some amount of malignant nature of that mass. So we decided to go ahead with biopsy. This is again, you can see multiple whirling kind of appearance on MR. Then we did a biopsy. So one of the prominent features during the biopsy was as the needle was coming out, you can see that the entire mass or certain substances is getting pulled up. I think you must have seen that something is pulling. It's very easy. You can identify that. Can you see that needle is pulling the entire tissue? Yes. So I was thinking that there is something which is behind the uterus and it is pulling, probably with the needle during the biopsy, but no clue whatsoever. Ultrasound, I said that it is something related to fibroma, but it turned out to be angiomyxoma. So angiomyxoma or angiomyxofibroblastoma are the two entities in the paravaginal space which is having very high degree of recurrence. So fortunately, after 2 to 3 years, we received one more patient with a similar background. So there was a 41 years female with a distension of abdomen, and ultrasound revealed that again the uterus is there, which is being lifted because of hyperechoic solid-looking mass, which is more like a bilobe structure. But in this individual, there was no mass which was protruding out of the vagina, but still this mass was quite evident. Now, in this mass, as compared to previous mass which I have shown you, you can appear that the cystic areas are more in nature. So there was a history of one case which was seen in the past. So immediately, without anything, I reported it as an angiomyxoma. But the patient came back with asking for a biopsy by the clinician. So we did a biopsy. So this is the vessels. The vessels were quite prominent, which were corresponding to that. So we put a diagnosis of angiomyxoma. And again, the biopsy. So again, look at the biopsy once again. Now, during the biopsy, can you see the tissue being pulled? Yes. Yes, it is again pulled. Okay. It is again pulled. So again, looking at that, again, my level of confidence is setting that it is angiomyxoma for that matter. But the eventual, again, the diagnosis was different. And it was another variant of. So again, MR was done. Again, he had some clue that what we reported earlier. He reported again as angiomyxoma, but it turned out to be the other variant of that. That was angiomyofibroblastoma. That was the entity. So it is not that you have seen one case, that means every patient which falls into that category will be of the same thing. It was a little bit different, but at least I had a pleasure in stating that yes, the fibrotic element which I was looking at from first case, at least in the diagnosis, the element of fibro came in the second case. So I was a little bit happy in this. So now with the background of two cases, now the confidence of saying that everything which looks solid, having vascularity in the pelvis may not be a fibroid. And these are the two entities which are there in my gallery to say that it is there. Next. So this was the patient. Now tell me, there is a pregnancy along with that also. I think you can appreciate the pregnancy over there. Okay. So apart from pregnancy, there is a mass over there. Yeah. Again, the mass is solid in nature. Do not show any calcifications or any abnormal vascularity, variegated component. No. So as soon as this case comes, the first diagnosis was query angiomyxoma. The second diagnosis was angiomyxofibroblastoma. So it was very obvious, no? It is solid and not fibroid. So either these two, and I was confident that it has to be there. Okay. Next, please. Then I decided that looking at the entire structure with vascularity, everything, I said that probably this time we may not require a biopsy because I have an experience of two cases stating that it is something related to angioma, angiomyxoma, or angiomyxofibroblastoma. So we did MR in this patient. Next, please. And on the diagnosis on MR, it was a schwannoma. So everything in the pelvis may not be what you have seen earlier or reported. This was pre-sacral schwannoma. So this was a diagnosis which was given on MR. So finally, I decided that let us go back to once again to fibroid. and report everything in the pelvis which is solid looking as a fibroid only, because your likelihood of ratio of saying that it's a fibroid is likely to be more. But you should always keep some that beyond fibroid, there are few masses which are solid in nature, again, which may not be a malignant. Angiomyxoma and angiomyxofibroblastoma, these are locally malignant conditions, out of which angiomyxofibroblastoma has very high incidence of local recurrence. But that too, they say that the distant metastasis or the complication because of invasion of the disease process into adjoining structures are very, very less. So this, I found that it quite to be interesting, so I thought that I will share it. Thank you.
Thank you, Anirudh. It was wonderful. I think he woke you all up. I was sitting there and seeing many heads were cooling down. And that's why we thought we'll shift the cases in front so that we'll wake you up and then start his lecture. Right. So let me also take you through 3 interesting cases. They are not as interesting as Anirudh's, but then it is more to the fetals. So, because, pelvis is a Pandora box. I mean, see, once he says angiomyxoma, the other time he says angiomyxofibroma, the third time he says schwannoma. What to remember? It's very difficult. Right. So I had a patient who was 29-year-old and a non-consanguineous marriage. First trimester NT scan was done. It was normal, 1.4. And then the combined screening was low risk. Nasal bone was present, no tricuspid, ductus normal, uterine artery 1.88. First trimester structural evaluation, absolutely normal fetus. Then she came back to me at about 24 weeks. Actually, I asked her to come back at 20 weeks, but she came back to me at 24 weeks, and this is what I could find. See, this is the, as you know, Dr. Morning, she has shown us how to do a systematic approach, wherein we find that we start from the abdomen and take it to the 4-chamber outflow tracts. Similarly, I did the same thing, sequential examination, where I could see that the situs was normal, abdominal situs was normal. Apex of the heart was corresponding to the left. And at the same time, you can see that the apex was corresponding to left, 4-chamber size was normal, morphology was normal, atrioventricular and ventriculo-arterial concordance was there. So basically, as far as the 4-chamber view was concerned, it was absolutely normal. Abdominal situs, normal. So normal situs, normal levocardia with normal 4-chamber view. Then, see, as she has already told us that we need to go to the 3-vessel view, and this is what has been demonstrated in the 3-vessel view. As you can see here, very nicely, can you see this communication? Right? So in the 3-vessel view, it demonstrates a normal relationship. That is, the pulmonary artery is on the left side, aorta in the middle, superior vena cava onto the right. So pulmonary artery was large, aorta was smaller than the pulmonary artery, superior vena cava was normal. Only thing in the cross-sectional examination, I could find that there was a moderate 5 millimeter communication between the pulmonary artery and the aorta. This is what is called as the aortopulmonary window, which is absolutely rare. In the sense, when I searched the literature, they said that it is only 0.1% of all congenital heart diseases. So it is such a rare thing. Now, in this, what happens is, it is just to confirm the diagnosis that we put the color on, and you can see that, I'll show you this. You can see the communication here. Yeah. Can you see that this is the dual mode where I can demonstrate the pulmonary artery, aorta, communication. On the color, there is a turbulence. So put the color Doppler on, you can find the turbulent flow across the vessel. So this is exactly what we are looking for, is the abdomen, the aortopulmonary window. And there are 3 types which have been demonstrated, described by Richardson classification, where type 1 is the commonest, which communicates with the main pulmonary artery and aorta. Whereas in type 2, it communicates with the right pulmonary branch. In type 3, it is an extensive communication from the main pulmonary artery to the right pulmonary artery. So these are the 3 varieties, but the commonest being the communication between the main trunk of the aorta as well as the pulmonary artery. So the communication between the aorta pulmonary artery beyond the semilunar valves, that is what is important. If it is at the semilunar valves, what do you call it as? If it is at the semilunar valves, what do you call it as? Common arterial trunk,
Isn't it? There is no differentiation because semilunar walls are single. From there, the trunk comes. Then because of the spiraling effect, it gets divided. If it doesn't divide, with this common semilunar walls, you call it as common aortic trunk. Whereas here, there are two vessels. There are two separate vessels. That is, the pulmonary artery has its pulmonary valves. The aorta has got its aortic valve. Whereas the communication is between the trunks of the pulmonary artery and the aorta. So this is what is called as the aortopulmonary window. So you need to differentiate between the two, establishing the site of a communication. If it is to the right pulmonary artery or it is an extensive one, these are all the types of three types of the aortopulmonary window. Now the incidence is 1.1 to 6. Most of them, almost 50% of them are associated with congenital heart disease, associated congenital heart disease. Rarely it can be isolated. If it is isolated, the outcome is very, very good. So this lady has an isolated one, and then we need to do a 3-vessel view in order to identify that, because quite often the 4-chamber view is absolutely normal. So that is the reason why we don't stop at the 4-chamber view. You go to the outflow tracts as well as the 3-vessel view. In a busy schedule, if you ask me to do a fetal echo, what I will do, I will choose 2 things. One is the 4-chamber view. No, I start with the abdomen, C for the stomach, 4-chamber view, and then the 3-vessel view. These are the 2 things I'll 100% look for before I say anything about the fetal heart. So that is the habit that we should all cultivate, so that it becomes much more easier. And we don't see, the reason is, as she has shown us beautifully the 4-chamber view and what are all the things. If you take into consideration, only 40% of abnormalities can be suspected or detected on a 4-chamber view. The conotruncal abnormalities cannot be made out on a 4-chamber view. So that is the most important thing. And the conotruncal abnormalities are the ones which account to almost about 60% of the congenital heart diseases. So that is the reason why we need to look for the 3-vessel check. So this is again the same thing. Now, another case. This was a very interesting lady, primary, 22 years. History of consanguinity was there, but she has a normotensive normal GTT. And then her blood parameters were normal. Hemoglobin was 12 grams. Fundal height was corresponding to the gestational age. She was perceiving good fetal movements. And then I did the ultrasound examination. This was the ultrasound findings. What do you think? This is the placenta. Just now she has taken us through placenta, card and everything. You can see, and remember, another important point which she told us is very important, that please start identifying the origin of the card and insertion of the card. That has to become a part of your protocol, because that makes, that allows you to diagnose many conditions. Here you can nicely see a hypoechoic area, isn't it? Sorry. You can see a hypoechoic area. You can see the card insertion, and this hypoechoic area is well circumscribed. The echogenicity is definitely varying from the normal placental tissue. So we diagnosed it as a chorioangioma. And this is the chorioangioma. You can see the vessels skirting. And I did the 3D power Doppler, where I could see the mapping of the vessels very nicely, so that we are sure that we can see the whole vasculature. Why should we know all these things? First and foremost thing, I need to identify the arterial communication. I need to identify whether there are any AV communications, AV malformations, and then advise the management of this. This is where we are going to play an important role. That is, okay. Now, so when we have a large chorioangioma, there are 3 things that we are worried about. 1, hydrops, pericardial effusion, polyhydramnias, as well as fetal anemia. So these are the things that have to be kept in mind. If they have started, the salvaging of the fetus becomes very difficult. Quite often they result with stillbirth. So this is the play time, and the intervention, if at all, if you are planning, it should be planned between 22 to 24 weeks of gestation. Fortunately, this lady came to us at that time. And at the same time, when we saw, there was a minimal pericardial effusion. Would you agree with me? Because the fluid is crossing the atrioventricular groove. When do you call it as a normal pericardial fluid, and when do you call it as a pericardial effusion? There are only 2 features. 1, if the pericardial effusion extends beyond the atrioventricular groove, it is abnormal. That is 1. 2, if the width of the pericardial fluid is more than 2 millimeters, it is abnormal. So these are the features which tells you whether the fetus has got a pericardial effusion or not. That is 1. This was a polyhydramnios was already setting in, and not only that, We did the Doppler and we could find that the fetal anemia was not there because it's only 31. So we can rule out the fetal anemia. So keeping all these things, we thought that it was an ideal time because it was just developing pericardial effusion, polyhydramnios, large chorioangioma, no anemia, ideal case to do something for this fetus. So what did we do? We try to evaluate. There are various management strategies. One is the fetoscopic ligation. Two is interstitial laser ablation, radiofrequency ablation, microcoil embolization, intratumoral absolute alcohol injection, and then the tumor glue or the tissue glue tumor embolization. So of all the things, see, fetoscopy and intralaser coagulation, they are associated with some amount of morbidity. So that is the reason. And then radiofrequency ablation is definitely a little high risk. And the efficacy of intratumoral absolute alcohol ablation is not that good as you can see in these other methods of management. So what we thought was, we thought to embolize this one to using what is called as the tissue glue. So first and foremost thing, what we did is we mapped the vascularity very nicely. We could find the arterial feed. Always remember, you need to identify the arterial. Why should you identify the arterial vein? Why not the umbilical vein? Why umbilical artery? If you put the gel into the umbilical vein is the one which goes into the fetus. So you're going to ablate the fetus. So you should identify the umbilical artery, put the glue in the umbilical artery, because umbilical artery gets filtered there in the placenta. So it stays in the placenta. It doesn't go into the umbilical vein circulation into the fetus. So that is the reason why you need to do that one. Once that is done, this is the N-bricylate 2-cyanoacrylate. And this is a glue. This is called as a tissue glue. This can be mixed with lipoidol. 1 ml of glue, 0.5 ml of glue, and 1 to 2 ml of lipoidol. The lipoidol is used because this glue is such a sensitive one. The moment it comes in contact with tissue fluid or blood, it gets solidified. So in order to delay the solidification, you need to mix it up with lipoidol. Once you mix it up with the lipoidol and flush your 20 cc gauze needle with saline and the lipoidol, then inject the glue, preparing the glue, and then inject the glue. And you can see this is how you inject it. This is the needle, and I could identify the arterial supply. I inserted the needle into it, and once that is there, well placed, then I injected the glue into it. So this is the result that you can get. How here, see this one? This is post-embolization. Absolutely no vascularity within the tumor. You have seen I'll show you the other slide where pre-embolization and post-embolization. I just wanted to show you that there is no umbilical artery was absolutely patent, and where I was sure that I was not injected into the umbilical vein, and then it was only the umbilical artery. So yeah, I am much more safer. Now this is the pre-embolization where I could see the vascularity, and this is post-embolization. So absolutely normal, and this baby has delivered, and it's absolutely normal. So this is how we are going to take care of this chorioangiomas. This was the post-delivery placental tissue with the chorioangioma, nicely seen chorioangioma, right? Okay, case 3. Are you still interested? Are you with me? Very good. Right. So this you are going to take. I am not going to talk about it. You tell me. I'll give you one clue. This is absolutely normal. So this is obviously abnormal, isn't it? So what is normal? What is abnormal?
Just look at the normal changes that we do as far as this this section is.
Okay, I'll give you one more clue. Whenever you do a fetal brain evaluation, there are 3 sections that you are going to take. Am I right? What are the 3 sections? Transcerebellar, transventricular, transthalamic, isn't it? In all the 3 sections, what is one most important structure you are going to look for? Huh? CSP. Fantastic. So whenever you see the CSP here. Is it normal, abnormal? Is it present or absent? Sorry, first. It is present. It is normal or abnormal? If it is normal, I won't show you, no. So it is abnormal. So that's the reason why I put a normal CSP here. See, CSP is always a rectangular fluid-filled structure, more length and less width. Okay, am I clear? So it is not just looking at the presence or absence of CSP that is important. It is also important to identify whether the CSP is of normal morphology or abnormal morphology. That is the message that I wanted to convey. That is why. Right. So with this, what are the factors which I am going to look for? First and foremost thing I am going to look for the interhemispherical fissure, and these are the single-edge gyri, and that should be the callosal sulcus, which I am not seeing the callosal sulcus. Genu of the corpus callosum I am not seeing. The rectangular CSP has become distorted and it's abnormal. Third ventricle is seen nicely. Thalamus is seen good, and the parieto-occipital sulcus as well as the lateral horns of the lateral ventricles are seen clearly. So keeping that in mind, so let us know a little bit about the CSP. First and foremost thing, as I said, it is first and foremost thing is you have to see the CSP in all the 3 axial sections. That is one. CSP starts appearing from 18 to 20 weeks of gestation and disappears by about 37 weeks. So remember, if you don't see a CSP at 19 weeks, don't report it as agenesis of corpus callosum, because it still has time to appear. So we have to be patient. Not only that, if you don't see the CSP at 37 weeks, patient comes to you for a second opinion, and then you jump and say CSP is not, say the other person has missed agenesis of corpus callosum. No, 37 weeks it starts disappearing because it shrinks, it gets dried up. Okay. Then we have another thing is you need to look for the put the color Doppler on, and normally whenever there is a normal corpus callosum, you will see the pericallosal artery, the callosal marginal artery skirting the corpus callosum. Then we need to find the CSP ratio. CSP ratio is the length by width. It should be more than 1.5. If it is less than 1.5 with distorted morphology, it has to tell you that there is something wrong with the corpus callosum. If it is absent, you will say absent corpus callosum. If it CSP is absent, you say absent corpus callosum. If it is present but distorted, you say partial agenesis or dysgenesis of corpus callosum. Fantastic, great. So this is the CSP ratio. This is the normal CSP ratio. This is the abnormal CSP ratio. We have to keep this in mind. And now, what will you do next? Immediately, you have to do a sagittal section. So this is what the sagittal section. Can you find what is wrong with this? This is the this is what is this? This is vermis. Vermis. This is the tectum. Okay, that is the cavum septum pellucidum, and you can see only a part of the corpus callosum. You don't see the rostrum and the genu. You don't see the splenium. Corpus callosum develops from the center and extends on either sides. Okay, and the first and foremost thing that gets involved because of vascular insult is the genu, rostrum, as well as the splenium. Okay, so this is how it looks like, and you put the color Doppler on, you see that there is an abnormal coursing of the pericallosal artery, which confirms your diagnosis of partial agenesis of corpus callosum. So this is the video where you can see the corpus callosum nicely, part of it, genu, rostrum is not seen, splenium is not seen. Okay, so this is what you have to learn, and the learning points are that CSP basic exam, screening examination, where it has to be seen presence or absence, size, morphology are extremely important in order to identify corpus callosal abnormalities. So this is how we are going to take about as far as the corpus callosum is concerned. Okay, thank you very, very much.
Just we will wind up with one post-MTP case scenario, which usually is a headache for every one of us. So this was the case, post-MTP 1 week severe abdominal pain and bleeding, and it was a non-supervised oral agents provided at a rural setup. So what is your diagnosis? This? So primarily we are looking at distorted endometrial echo-complex, loss of endomyometrial junction halo, various areas of hyperechoic heterogeneity within the cavity where there is aggressive vascularity of arterial and venous nature extending beyond the cavity and endomyometrial junction into the structures. And for years together, we used to call it as a AV malformation, but the new terminology nowadays used for all the RPOCs showing features of abnormal AV communication, wherein it is not a pelvic congestion syndrome. In case of a pelvic congestion syndrome, it is the subserosal vessels which are dilated, which are extending into the broad ligament and the parametrium and not into the endomyometrial junction region or cavity involvement. So all such lesions secondary to retained products of conception showing features of abnormal AV communication is termed as a enhanced myometrial vascularity and not termed as a AV malformation. So it is called as enhanced myometrial vascularity. What is the POC spectrum that we usually get? After any medical termination of pregnancy, there is a minimal amount of fluid, there is air reservation, it goes into the cavity. But as you can see here, the heterogeneity within the cavity giving rise to echogenicity, complex pseudo-echogenic mass, ballooning of the cavity and extending of the hyperechoic content with abnormal vascularity into the adjoining component, increasing chances of you stating it to be retained products of conception. So whenever endomyometrial junction halo is lost and there is aggressive vascularity entering into the myometrial substance showing features of arterial and venous communications abnormal, it is called as a EMV, that is enhanced myometrial vascularity. This term was coined by Van de Bosch, stating that it's a tangle of tortuous blood vessels with a peak systolic velocity more than 20 centimeters per second. And usually there is some or the other history of early pregnancy, either loss or some degree of medical termination of abortion. Now, depending upon the velocities and the blood picture in terms of a clinical scenario as hypovolemic shock, if the velocity is less than 40 centimeters per second, it is said to be safe zone, where you can monitor that lady sequentially, and it is called what you can say expectant management treatment. But whenever there is a more than 80 centimeters per second with a significant amount of history of bleeding PV, all those patients will definitely require some or the other interaction. At the same time, isolated only increased peak systolic velocity beyond 80 centimeter may not be sufficient enough in doing active intervention. If it is associated with clinical significant blood loss, which is obviously evident depending upon the clinical condition and biological markers, then only active intervention is required. The active intervention could be either methotrexate systemically or maybe uterine artery embolization in few instances, or many instances even it could be a total abdominal hysterectomy or sometimes histoscopic removal along with the uterine artery embolization. So always remember, clinical scenario and peak systolic velocity and transvaginal color Doppler are both should be given equal weightage, and this terminology, don't label it as a AV malformation. AV malformation for all practical purpose has to be congenital in nature. In terms of a post-MTP cases, we cannot say it's a post-acquired or acquired AVM. We have to label this terminology as a enhanced myometrial vascularity. These are different cases, and the outcome which I want to show you. This patient was enhanced myometrial vascularity for which uterine artery embolization was done. The velocities were closer to 80 centimeters per second. Now here it was a adherent placental substance within the cavity behaving like that of adherent placental polyp, for which it was a post-term delivery, but still was behaving like of that of a enhanced myometrial vascularity, for which histoscopy DMC was required. Again, you can see retained products of conception, typical behavior that of enhanced myometrial vascularity, for which histoscopic removal was done. Even though the velocities were closer to 30 centimeters per second, the bleeding was quite significant one for which the intervention was required. So just if it is possible, take this protocol, which is very important. In all cases of post-termination of pregnancy, this is how we should look at in each and every cases, starting from surface to inside. That is the surface contour, endometrial thickness, endometrial cavity in terms of complexity, presence or absence of enhanced myometrial vascularity, any adnexal complex lesion, presence or absence of POD collection, broad ligament for presence or absence of small collection, bowel loops, urinary bladder, and nourishment. So this is a 10-point protocol for post-MTP cases. And this will, along with presence or absence of a blood loss or presence or absence of enhanced myometrial vascularity, still you can decide upon depending upon the velocities and the clinical conditions. Now, the frequent questions usually at radiological platforms is asked is that how to get follow-up. I mean, in radiology setups, you report the case and it goes to the clinician. So in my center, what I usually do is that I usually keep the track of that patient on WhatsApp, and whoever gives me number one further discharge card, I pay him or her 100 rupees on Google Pay or Phone Pay. So that's the way in which usually most of the times I get my follow-ups, because I am working in an independent setup. But eventually those who can definitely have their own follow-up, it is easy for them to take the follow-up. But at least for independent imaging setups, this is how one can do it. Anyway, 50-100 rupees, say on 4 to 5 occasions in a month, is not a big amount to get good follow-up in terms of outcome of the patient, the clinical progress of the patient, the prognostication. On many instances, I get a follow-up stating that your diagnosis was X, it turned out to be Y, eventually on histopathology, it turned out to be Z. But at least I learned some or the other point, which eventually is unlikely to be repeated as a mistake in due course of time. So that's how I usually improve myself. Thank you.
Suppose your diagnosis was wrong, you refuse giving up.
No, still I will give you.
Okay, I have two questions more. One is, okay, you said that you have reported as enhanced myometric vascularity, they did a DNC. What was the histopath like?
It was a product of RPOCs only.
In the sense they could find the RPOs.
RPOCs, yes.
Okay, that's what I want.
Yes.
And did you ever try to give a methotrexate intra?
So presently, I try to search for the literature in terms of giving something as a sclerosant into that area. But still now, at least I have never tried myself. Neither I could trace any literature stating whether it works or not.
Right. Thank you. Thank you very much.
Yeah.
There was a possibility of postpartum.
It can be.
Determining obstetrics, postpartum bleeding, unless otherwise.
I mean, this is due to me. At least I preterm they were retained placenta with features of enhanced myometric vascularity.
Later on, she played, no, you told.
He was bleeding.
He was bleeding. So any post-term bleed, unless otherwise, should be considered as a choriocarcinoma, is a dictum for obstetricians.
So that means that you have the histopath positive.
Yeah. It has to, even choriocarcinoma will also
why I am
have
asking
very high vascularity. Beta-SCG would definitely help us.
Help us, yes. The reason why I asked is recently there was one patient in Hyderabad, doctor by herself. She had postpartum hemorrhage. The obstetrician sent her home. Then she bled. So a scan was done, which was reported as retained products of conception. Lady came back. She checked her. She was in septic shock. So she was treated. She refused continuation of treatment and absconded. And she went to some other doctor who gave a report saying that histopath was done and the histopath showed only retained products of conception. And there was no mention about the beta HCG, or there was no mention about it. And then the couple has come back to this doctor saying that you have ruined our life. So that's the reason why I've been specifically asking, if that is the situation, then they have to definitely look for the choriocarcinoma, and then histopath is a must, because they didn't get the histopath done for the evacuation, from the evacuation. That is the reason why I have asked. Very nice. Thank you. Thank you very much. I'll take leave of all of you. And it was wonderful being with you all. And not only that, I could see that in the hybrid morning, there were almost about 333 people who have logged in. And still in the post-lunch period, I think some of them are sleeping and we can't help them because they are at home. And it's only 2:36, but still good. Thank you very much.
Thank you, sir. Thanks a lot. Thanks a lot.
Yes. Yes. You wind it up?
Yes. Yeah. Bye.
Now I request Dr. Aniruddha Kulkarni sir to take up his talk on fibroid mapping, fibroid adenomyosis.
Okay.
In the morning, he played so well and he was so humble in telling us that he was just an average student. But the way you played just reminded me of a talk on IUGR by Dr. Suresh, who said that one scan, don't label the patient as IUGR because some of them can cope up with the growth. Okay, so please continue. Thank you.
No, at least from the present appearance, it doesn't feel that there is any history of IUGR in at least 3 generations prior to me. Okay, it's good to see that there are still few people on Sunday post lunch. So I will try to stick it to the 30-minute talk so that you all can move back to home. Myometrial abnormalities present approach morphological uterus sonographic assessment criteria, that is a MUSA. I took it seriously when I listened to Dr. Praveen sir's talk on MUSA and IOTA in one Shirdi conference, I think 4 years back. Okay. Just give me a 2 minutes. Huh? I need to log in for Zoom.
Share the screen. Can you share the screen now? Yes. Yeah. Share the screen.
Can you just check with the people? It's working? Okay. So, no financial disclosures, no copyright dispute. The articles which has been mentioned in the literature, in the talk, has been duly acknowledged. And I am grateful to all clinician team who provided me material. Thank you very much. See, MUSA guidelines is basically to come to a common unified platform where we use common terminologies which is acceptable all over, imaging guy as well as the treating guy. On the similar ground, we have what is called the IETA or IOTA. On the same line, it is there. It is primarily for uterine myometrial component pertaining to fibroid and adenomyosis as a common. And there is a special mention about ACM, broad ligament fibroid, and pedunculated cervical fibroid. So we'll be dealing how we report rather than specifically looking at features of those diseases. So this is how. So MUSA first reminded me the movie called Parinda during my younger age, where the main villain was played in that. So MUSA dekho wo isko kya karna hai. So that terminology clicked into that mind, and then I really took it very seriously. Just go back and read this. This is very important article by Van de Bosch, which defines all the terminologies. So it is either we connect that audio to our laptop, so that I think people will enjoy more looking at the presentations rather than anything. But it's quite mandatory to go back and read this article, that is terms definition as a measurements to describe the sonographic features. It's a very good article. Again, there is a specific system which has come into play for reporting adenomyosis. I will show you a few cases. And finally, what is important is symptoms classification. What is a management protocol for those cases that you report it is an abnormality in terms of fibroid or adenomyosis. So it is the clinical implications of findings that we encounter and we report, and what is a protocol for that? That is more important. So you must go back and read what are the indications and contraindications for salvageable uterine surgery, particularly for either fibroid or adenomyosis, because depending upon those indications and contraindications only, all the imaging spectrum has been designed now to report everything in detail. So let us go with that. So again, this was one article which helped me really to design this talk, that is uterus sparing treatment options, then management options for uterine adenomyosis. All this I am very thankful to Dr. Mahesh Tandale, who is one of the very great academician in my town, who forces me, not only me, to so many imaging guys to read more and more, because he asks so many questions after reporting the cases that you are forced to read so many things. So thank you, Dr. Tandale, for the same. This is an imaging multi-specialty approach, whether by looking at the fibroid, if the pregnancy is required or not, or whether it is pregnancy is required, depending upon whether it's a postmenopausal lady or a perimenopausal lady. There are different practical approach which has been given now clearly in the literature, that how you go about as far as the fibroids are concerned. And depending upon this protocol, all the MUSA finding, all the adenomyosis finding now has been classified and graded, so that depending upon what I label, at least the clinician will understand what is a case under trial is all about. So the aim of the MUSA is terms definition and measurements which are uniform all over, to reduce the intra-observer and inter-observer variation and become a uniform reporting protocol for that matter. We all know for years together we have been doing pelvic ultrasound followed by the transvaginal ultrasound. So we do abdominal ultrasound with low frequencies and a higher frequency transvaginal ultrasound. So starting from uterus, myometrium, adnexa, ovaries, but it is very important whenever you find anything abnormal from MUSA guidelines in the endomyometrial junction, myometrium, then always extend your examination and search for deep infiltrating endometriosis in the component behind the posterior fornix, behind the uterine wall. Those are very, very common. Now here you can see both the ovaries are in the POD and one ovary is showing features of a endometrioma right over there. So in the same patient, when I did a detailed ultrasound, you can find that not only the ovaries were kissing each other with a feature of endometrioma in one ovary, but here you can appreciate that it was involving the more than 5 millimeter of bowel outside wall, that is serosa and muscularis mucosa, which is a classical feature of deep infiltrating endometriosis. So it's mandatory. Whatever finding that you get of adenomyosis or fibroid with adenomyosis, always look for that. In terms of a myometrial tissue that you encounter, the first thing that you have to see is homogeneity, the equality of distribution along the endometrial stripe, which is obviously noted on a sagittal scan of a transvaginal ultrasound. So look for serosa, look for endometrial triple line configuration and the surrounding hypoechonicity. Now, because of the comparative mode of transvaginal 3D ultrasound and the endomyometrial junction at the MR, now a lot of comparative studies are coming, and now endomyometrial junction zone is known as a busy junctional zone, because all the findings which previously we used to say as a bulky uterus or say adenomyosis, so all these findings, it is mandatory to look at the endomyometrial junction, which is nicely seen on 3D. So how do we describe? So description of uterus is uterus, myometrium and myometrial lesion. So uterus is corpus, cervix and serosa. Size, we know all how to take. Myometrium in terms of wall symmetry, overall iconicity, and depending upon the size, focal size, diffuse lesion, vascularity, all the terminologies have come, and that has been put into a tabulated form so that it becomes a reporting protocol. So starting from uterine corpus, myometrial lesion, numbers, size, location, shadowing, age. So this is what is called as a MUSA reporting protocol for myometrial lesion, and we will try to cover one or few examples depending upon that. So uterine size, in case of adenomyosis, we have to exclude the cervical size and take the remaining size. So it is a fundus, cavity of the fundus, cavity and cervix in non-adenomatous condition, but in case of adenomyosis, excluding the cervix. So length, epidiameter and transfer diameter, then again a volume, still people do not give much significance to that. Coming to junctional zone, so on 2D and 3D, you have to see whether the endomyometrial junctional zone is in continuation, whether it is irregular or interrupted, or whether it is completely absent in nature. So depending upon endomyometrial junctional zone per se, now looking at the irregularity or focal defects, we have to say that the endomyometrial junctional zone is uniformly seen in all part, or it is interrupted, or it is irregular, or it is completely not demonstrable. So it is a junctional zone. So after the junctional zone, so this is how I said, this is a coronal 3D view. Can you see the beautiful hypoechoic endomyometrial junction zone form all around? And here you can appreciate some amount of hyperechoic nodularity, which is extending from the cavity into the endomyometrial junction zone. This is a classical, what is called as the hyperechoic strands or nodules or islands of adenomyosis. Now, can you see here it is interrupted endomyometrial junction zone? Interrupted endomyometrial junction zone. Now here you can see, appreciate EMG, but it's diffusely irregular, and posteriorly again it is more irregular. Here you can see it's a interrupted endomyometrial junction zone. So endomyometrial junction zone, normal or abnormal, and what kind of abnormality is there. Then suppose if you have found out something focal in nature, is well defined, it is called a typical fibroid or a focal adenomyoma. Then again, location, size, and site. Then you can classify the fibroids depending upon FIBO and palm and going. So grossly, in terms of what is important from management point of view, are the submucous fibroids. Usually they are responsible for extensive symptomatology as far as the bleeding PV is concerned. So 0, 1, 2 is submucous fibroid. 0, 1, 2. 1 is more into the cavity, brushing the endomyometrial junction zone. Here it is more into the intramural cavity, and this is completely. So 0, 1, 2 is submucous. 3, 4, 5 is intramural. Then whenever it is affecting the endomyometrial junction as well as reaching up to the cavity, what we say? We say it is 2 to 5. So what does my report should say? There is a large fibroid brushing the endomyometrial junction and cavity, reaching beyond the serosal circumferences outside. It is of the category 2-5. So this is how I am going to report. So I am going to say whether it's a completely submucosal, completely intramural, or a variant in which all the walls are involved. So submucosal, all cavity, more than 50% is grade 1, less than 50% into the gravity is grade 2. Intramural can be a transmural one, that is 2 to 5, which we have seen earlier. Or if it is subserosal, we have to see whether it is just subserosal or a pedunculated subserosal one. And that is how the complete report. So the best way of doing it is take all the sizes, report where it is, give this kind of a cartoon to the clinician, which is more useful. And always remember, whenever it's a cervical fibroid, cornual fibroid, or a broad ligament fibroid, these are labeled as a different entities altogether by the MUSA classification. They do not come into any category of MUSA criterization for that matter. So this is how we classify the fibroids. Now tell me, what about this? Now this is a submucous pedunculated fibroid. Can you appreciate the vessel pedicle over there? Now, in case of a submucosal pedunculated fibroid, there is always an echo dropout area which is seen at the level of internal os. Probably I can demonstrate you here in next one of the cases. Now here, can you see this dropout area? Whenever you see that the cavity you are not unable to define, there is a dropout area at the level of internal os. That is because of something is getting prolapse from the cavity into the cervical canal. Then you withdraw the transducers, which is primarily into anterior or posterior fornix, more outside the external cervical canal, and look at whether that entire is coming into the cervical canal and it is also protruding outside the cervical canal. So it's very, very important. Now this is classical focal adenomyoma. Now, as we know, in case of fibroids, the vessels, they are circumscribed circumferentially, and here in case of focal adenomyoma, they are traversing and branching within the substance of that focal mass. Now, can you see the focal adenomyoma in the posterior wall? And it is showing some degree of vascularity, which is through the lesion. Now, can you appreciate the calcifications over there? So there is a subserous fibroid, again a partly into the myometrial component. There is another fibroid which is there in the anterior wall as well, but this dense calcification. So all you can report it as a location and subclassification, but whenever it has got some complication in terms of number 1 calcification, number 2 degeneration, number 3 dread degeneration, or subsequent higher degree of sepsis involving either because of increased blood flow or on many occasions because of even pregnancy. So that is subclassified and need to be mentioned differently apart from just doing the fibroid mapping. Now coming down to ill-defined lesion, if less than 50% of the myometrial substance is involved, it is localized. Not localized, it is more otherwise as a diffuse. It is difficult to delineate and measure specific size in such lesion. We need to calculate the penetration ratio between the lesion and the remaining normal myometrium. So when we say echogenicity of the lesion, it can be uniform or non-uniform, homogeneous or heterogeneous, hypo, iso, or hyperechoic, depending to remaining myometrial component into that patient. Whenever we found cyst, calcification, or rim, need to be labeled separately. So MUSA has defined it very clearly. So this is a globular enlargement. Here we are not going to measure the cervical component. We are going to take this measurement. It's a asymmetrical thickening, presence of a tiny cyst at the endomyometrial junction layer, evidence of a hyperechoic islands or hyperechoic streak sign. This is called a fan kind of a shadowing over there. The vascularity is translesional over, and in patients where obviously signs of hyperechoic islands or streaks are noted, we will find that the endomyometrial junctional zone, which is a busy zone, will be showing interrupted irregularity within the endomyometrial junctional zone, which again can be better picked up on 3D ultrasound. Now coming down to shadowing, can you appreciate the shadowing over here? This is classical shadowing. So the shadowing can be edge shadowing, it can be internal shadowing, fan shadowing, and you need to mention the uniformity or inhomogeneity in terms of shadowing or presence of calcification along with the shadowing. This shadowing is not of a calcification, but it is because of the inhomogeneity or heterogeneity of different component within that. Now, what are the things that you can see here? Can you see a tiny cystic lesion over there having a hyperechoic rim over there? This is classical adenomyosis. Now, here we have seen one more this initial fibroid which was there, and again it is showing shadowing which was seen in earlier. So whenever we say myometrial cyst, don't label it as a myometrial cyst, need to follow it for presence or absence of a adenomyotic changes. So they are usually rounded in size, less than 5 millimeter, anechoic. On many instances may contain little bit of hyperechogenicity within the shape. Many times it can be even echogenic depending upon stage of menstruation. You have to mention number of tiny cysts all over, number one, and you can mention the largest cyst for that matter. Now can you see here multiple tiny cysts? Now here, can you see this is a pregnancy. Okay, along with the pregnancy, can you see this here? And there is a little bit of comet tail artifact which we have seen earlier, that there can be a hyperechoic element within the cyst also. So whenever there is a cyst component, measure it, number it, measure the overall number in terms of cystic lesion, and give the largest measurement for that matter. Now, apart from the cystic areas that we mentioned adjoining to endomyometrial junction, the next thing that you should look at is some endometrial echogenic linear striations. Now, can you see these echogenic striations? Is it appreciable? There is an interrupted endomyometrial junctional zone. Is it okay with you all? Okay. Then there are different linear striations which are extending from endometrium into the endomyometrial junctional zone. This is classical linear striations affecting the busy endomyometrial junction. So next stage beyond this is hyperechoic islands. What we call it the hyperechoic island signs, which are usually irregular in shape. Now you can all will appreciate that adjoining to the busy endomyometrial junctional zone, can you appreciate hyperechoic various islands along the endomyometrial junction zone? So these are nothing but the distantly away placed ectopic endometrial tissue in the endomyometrial junction zone and adjoining myometrial substance. And not only on the B mode, you can appreciate it well. As soon as, can you see on the reconstructed 3D mode? This is the island. And again, these are all streak signs, which we have seen in earlier slide. So streak sign and presence of a hyperechoic island involving endomyometrial junction and adjoining tissue are said to be very specific sign of adenomyosis with a specificity more than 93%. So abnormal endomyometrial junction zone interrupted 1, number 2 hyperechoic strand sign, and number 3 multiple hyperechoic island affecting causing endomyometrial junction irregularity is very, very specific sign. Now coming down to vascularity, we can see that as a whole, the uterine vascularity may be increased, or in some focal area, depending upon fibroid or adenomyosis, the pattern of vascularity may say. So we are going to comment in case of a globular enlarged bulky uterus as a uniform increased vascularity into the myometrial component. What is adenomyosis? Adenomyosis is multiple punctate hyperechoic area intermixed with hypoechoic substance. It is because of the muscular hyperplasia. Okay. So then when it is circumferential in a focal lesion, think of a fibroid. When it is traversing through the lesion in a focal with features of some certain amount of adenomyosis in myometrial substance, it is focal adenomyoma. But in spite of the fact that it looks so easy while explaining and the reading, we always know that both the conditions can occur together also. There can be a fibroid coexisting with the few of the adenomyosis changes, or fibroid with focal adenomyosis also. So it's not easier on day-to-day practice, but still, if you go systematically starting from all the MUSA criteria, it will be very nice for you to look at it. Now, can you see this now? Large mass over there and the vascularity. Now there is a focal adenomyosis area involving the cervical canal. Now can you see this vascularity which is within the lesion and sparing, but it is not showing much aggressive branching vascularity, which in turn we take it as a feature of a malignancy. Not only that, on one side, can you appreciate over here? So this is one. Sorry. So there was a lesion on this, in the right adnexa over here. This is the right ovary. Then what is this? Can you see? This was in fact hematosalpinx on that side. So ovary was normal, there was a hematosalpinx. And this is classical adenomyosis. So overall bulky nature, ballooning with distorted ecotexture, symmetrically on either side, no asymmetrical thickening. But at the same time, looking at the lesion itself, we will say that probability we are looking at the adenomyosis. So again, the first slide which we decided, that is uterine corpus, myometrial lesion, number, size, location, shadowing, cyst, hyperechoic strands, islands, junctional zone, vascularity, type of vascularity. So similarly, you start reporting the same, and fibroid we have seen depending upon its location characterized, you are going to measure. And again, whether it's less than 50% within the cavity or beyond that. And as soon as you do a coronal scan using 3D, you can very well say that whether it is only submucous or also extending beyond the cavity. So it depending upon that only. As I have stated, fibroid and adenomyosis can exist together. So can you see the fibroid here? But at the same time, I can appreciate multiple heterogeneous areas intermixed with hypoechoic spaces, which is nothing but adenomyosis. So on instances, there can be both entity together. As we have seen adenomyosis and leiomyoma, how to differentiate, this is a just tabular form to represent the same depending upon borders, shadowing, ecotexture, ecogenicity, calcification, cyst and vascularity, and it is easily can be differentiated. Now, what is the finding in this patient? You can see, can you see the globular enlargement of the uterus on transabdominal scan? Very easy. Now, can you see the remaining cervix and the portion of vagina appears to be more or less normal looking or appearing? This is classical adenomyosis. So this kind of pictures, don't label it as a just bulky uterus. Just give a dedicated 10 to 12 minute scan on transvaginal ultrasound, and you confidently can report it as a focal adenomyosis or a diffuse adenomyosis depending upon various areas. The terminology which radiographics has used is called as a myometrial heterogeneity, mimicking to that of a cirrhosis of liver, though they labeled it as a cirrhosis of uterus. So primarily responsible for adeno and meiosis. Adeno means ectopic gland, meiosis means smooth muscle hyperplasia. So in combination of this leads to what is called as the myometrial hyperechogenicity. Along with that, you search for vascularity. So you can say on many instances the features mimicking to that of a cirrhosis of the uterus. This terminology was coined. So up till now, what we have seen, adenomyosis presence or absence, location, anterior wall, posterior wall, left lateral wall or fundus, differentiation, whether it is focal, whether it is diffuse or mixed, cystic variety or a non-cystic variety, and then coming to which uterine layer is involved, whether it is a junctional zone, middle myometrium, or reaching up to the serosal surface or going beyond the serosal surface. So apart from labeling focal lesion or a diffuse lesion, now it is my duty to say which wall is involved and up to what extent the deeper extension of adenomyosis is there. So the reporting 7-point criteria is presence or absence of normal or abnormal myometrium, location, differentiation between focal or diffuse, cystic and non-cystic, and which layer is involved. That is type 1, type 2, type 3 or all three. Now, how do you identify that? See, this is the endometrium. This is the inner zone, this is a middle zone, and this is a subserosal zone. Now only one is involved, it is 1. It is when 2 is involved, it is 1 plus 2. And when it is 3 is involved, that is subserosal surface, we say it is a 3. So it is 1, 1, 2 or 1, 2, 3. And whenever it is going beyond the serosal surface, if you are able to make out irregularity, hypoechogenicity involving the serosal surface, always and always look for all the features of deep infiltrating endometriosis in the POD for fixity of structure of cervix to the posterior vaginal wall or the posterior pouch of Douglas. So that is called as the cervical sliding sign. Okay, so type 1, type 2 and type 3, or you can say type 1 to 2, 2 to 3 or 1 to 3. Then you can put a color Doppler and look for sliding sign of deep infiltrating adenomyosis. Now let us see what kind of lesion is this. You can see diffuse changes here. There is a IUCD over there. But again, sorry, this focal changes here and diffuse changes here. This is classically over there. So this is one case. Now how I am going to report this case, just look at the cine loop and I will describe whatever is mentioned here. So abnormal myometrium, adenomyosis, location is fundal in nature, type cystic or non-cystic, it appears to be more cystic in nature. Okay, so the uterine layer only one extent is mild. The size is 18 millimeter. So report description comes fundal, cystic, mild adenomyosis involving uterine layer 1. That's the complete description. So one more case here, you can say mild variety, but can you appreciate the cystic area surrounded by hypoechoic rim? So here description would be mild adenomyosis, mixed type, that is the focal plus diffuse with involvement of fundus and posterior wall, both. So both walls are involved, and we will mention what kind of wall. So here the uterine wall is 1, 2, 3. Now can you appreciate the irregularity which is extending beyond the serosal surface here? Very easy to see. So that means the layer 3 is also involved. So here you have to see 1, 2, 3. So this is abnormal. So these are the few cases. We will just wind up to that and come to one more important entry, that is called the ACCM. ACCM has been specially mentioned as a separate entity in MUSA. It's a juvenile cystic adenomyoma. It is insertion of round ligament and below the insertion of interstitial portion of fallopian tube. It gives to abnormal contour on 3D or volumetric images, and usually typical history in case of a young female, it's a severe dysmenorrhea. Now can you appreciate here? Here the endometrial cavity appears to be absolutely normal. It is mimicking to that of a, say, arcuate uterus for that matter. And can you appreciate this? This is classically ACCM. Now, ACCM can have various features. Even on many instances, it may appear like that of a ectopic pregnancy also. But looking at this lesion, the primary diagnosis which glitched into my mind was again a ectopic pregnancy involving this area, but eventually we evaluated and it turned out to be focal juvenile adenomyoma. That is nothing but what is called the ACCM. In terms of cervical masses, as we have seen, it could be a cervical mass which is coming from the endometrial cavity in terms of a submucous fibroid polypoid into that, in which again, can you see the echo dropout area here? Whenever you see ill-defined endometrial cavity with echo dropout area near the internal os, always suspect for some amount of submucous fibroid. Now, can you see this here? Echo dropout area here, and there is a large mass within the cervical canal. It was nothing but a cervical fibroid. Now, this is a pedicle which is classically seen here, echo dropout area at the level of internal os, and there is a widening of cervical canal, and this entire fibroid is almost reaching up to the level of external os, which was obviously noted as I withdraw the transducer at the level of introitus. Broad ligament fibroid, whenever they are present, usually anterior posterior wall and bicornual widths is absolutely normal. And you can see that there is a classical feature of a fibroid which is there in one or the other cornu. Then you need to mention it as a non-classified fibroid, broad ligament fibroid, or non-classified fibroid as a cervical pedunculated fibroid, giving a mentioning about its vascularity, size, and different areas of interest in the same. There are certain complications of fibroid which needs to be mentioned, and those do not come into any category of palm and coing in terms of submucous or other fibroids. They need to be mentioned as a special condition. So here I am going to say that it's a non-classified variety of palm and coing, where depending upon the size of the lesion, depending upon the clinical presentation, only the judgment as far as treatment protocol will change. This is what is called as a lipoleomyoma. So lipoleomyoma, angiomyolipoleomyomas, they are not uncommon in uterine environment. The feature is that you will get a lot of hyperechoic area surrounded by hypoechoic rim, and this shows posterior strong echo enhancement and not the shorting. So this is classical lipoleomyoma or angiomyolipoleomyoma in few instances. Again, reiterating what we said on the first slide, starting from the corpus till the external os, from the cornual region to the broad ligament region, everything needs to be mentioned in detail in terms of site, size, location, focal, diffuse, which area of uterine wall is involved, how do you identify the amount of vascularity and type of vascularity that it has. And if you follow mathematically, then definitely you can decide into which category this patient is lying, and it is very helpful. This was an interesting case, and yesterday only I have received. This patient came to me for upper abdominal pain, and you can see that there is a liver abscess in the left lobe of liver. But usually in nowadays, according to protocol, there is nothing called upper abdominal ultrasound, lower abdominal ultrasound, renal ultrasound, or a pelvic ultrasound. All ultrasound needs to be abdomen pelvic ultrasound in case of females. So immediately I followed that patient, and I found so many interesting findings in the pelvis. After talking to the patient, realized that she was having this lesion. So this was a classical endometrioma on right ovary. This is again, I think, yesterday's patient only, 12th of February. Now, what more? Can you see a tiny cystic area over there? So this was adjoining to the uterine scar. In the morning, I had demonstrated the uterine scar now. So this patient on MR, I have sent in it for MR. I will not be surprised if this is a focal adenomyoma over there because of cystic component. So not only that, remaining portion, can you appreciate it, adenomyosis over here? So areas of adenomyosis over there. Okay, so completely what I can say, not reported. The patient did not come for pelvic ultrasound, but fortunately I could see many patients. So as I stated, immediately if it was adenomyosis, I extended my examination for search for deep pelvic endometriosis. And what do you find? This is classically what is called as a red Indian hat sign. Can you see this? This is a classical red Indian hat sign, which is seen very nicely. So deep infiltrating endometriosis is when, see, usually bowel wall has, say, serosa, muscularis mucosa, submucosa, and mucosa. So all out of which, if more than 5 millimeter of serosa and muscularis mucosa is involved in endometriosis, we label it as a deep infiltrating endometriosis, and we need to search for deep infiltrating endometriosis in all the patient who shows some or the other features of adenomyosis. So thank you very much for your patient listening. And once again, I just love Harsh Bogle for years together. He says across all professions, including imaging guy and clinician, consistency is a direct product of work ethics. So if we follow work ethics meticulously in normal patients also, then only you can find out some good abnormalities whenever it is required. So thank you very much once again. I always enjoy coming to Solapur for some or the other reasons. Nowadays, there is an additional attraction that from Solapur to Aurangabad, I can reach in 3 hours 20 minutes. So my record time is 3 hours 20 minutes when I last came to Solapur. And the first place that you see after leaving the Solapur is the board of Aurangabad only. You will not find any place in between. And eventually now it is said that the Aurangabad also will not be seen. The first board which will be seen is a Dhule. So almost now 90% of the work between Aurangabad and Dhule is also complete. So eventually probably for Aurangabad, I have to take one exit closer to Aurangabad and go for 14 kilometers. And it's a wonderful road. I think, I mean, any event in Aurangabad, you all are invited. And we regularly conduct many meetings in ultrasound in Aurangabad. So once again, thank you society for inviting me. Thank you Mindray for giving opportunity to share dais. It is always wonderful to share something or the other with audience. Thank you.
Thank you, Aniruddha. I have 2 WhatsApp messages for you. But before that, me on behalf of Obstetric Gynaecological Society and my dear friend from Radiology, on behalf of Radiology Society, like to thank you for coming here so long. I will not say so long. Thank you for traveling 3.5 hours to Solapur and really giving us an academic feast. Now, the first message is from the president of our society, asking for apology because of the sound disturbance in the near hall. And the second message is from the treasurer of our society. He has asked me to give you the bank details so that the GPay transfer would enable us to book this nearby hall also, so that there will be no disturbance hereafter. Thank you very much.
Surrounding the scar.
That anechoic lesion, we should say to the query focal adenomyosis. I would think first possibility as a Nebothian sonica. What do you say?
No, see, I do agree, but if you closely look at that loop, no, the endocervical canal was absolutely normal. That tiny cystic, see, when you have one pathology in the fundic region showing adenomyosis, there is a pathology involving deep infiltrating adenomyosis in the posterior component. The first thing probably that came into my mind, whether it's a focal, tiny, cystic component adjoining to the scar area. See, I have seen so many cases of scar endometriosis. I am talking about, and not only anterior abdominal wall, I am talking about the lower segment scar area. So lower segment scar area, when it is a teardrop sign, what is called, where you get a near just superior to the internal os, we get a teardrop sign with previous history of lower segment scar and other features of adenomyosis involving, then in those instances probably I would go for focal cystic lesion of adenomyosis.
Yeah. Another question, sir. In how many cases you have faced an ambiguity where it is fibroid or adenomyosis, and you had to send the patient for MRI, and what were the findings?
See, nowadays, with the standard protocol of labeling focal, diffuse, involvement of layer and vascularity, more or less MRI is a problem solving tool wherein you want to comment about the adjoining structure involvement apart from what we have labeled in terms of deep infiltrating endometriosis. Primarily for adenomyosis, primarily for fibroids, very few people they go for MR nowadays because ultrasound transvaginally really show beautiful signs of male lesions.
Thank you very much.
But MRI still is useful in problem solving too.
Hello, sir. Sir, regarding EMV, is there any role of uterine artery embolization in EMV?
Yes. See, because we were having a little bit of time constraint, I have not discussed the management options. And I think there are so many people in the hall who are quite expert in terms of management. But there are, in terms of uterine artery embolization, number one, even for adenomyosis nowadays, it is being asked at many centers. There are centers depending to reduce the size of the fibroid lesions causing pressure symptoms. Uterine artery embolization is done. Again, the other option which is done is what is called as the HIFU or MR or ultrasound guided focal compressive technology used to reduce the fibroid size. So these are different techniques which are used. I am not very familiar with those techniques, so I am not going to go into the much detail as far as the management options are concerned. But it is mentioned in the literature, uterine artery embolization. I have seen few cases in Bajaj Hospital done by Dr. Ajit Bhagwat for adenomyosis as well as for large size uterine fibroids responsible for dysfunctional or AUB. Yes. There is see, in terms of a gestational trophoblastic disease, in terms of its spectrum, it's a number one is gestational trophoblastic disease, invasive mole or a choriocarcinoma, and then there is a one disease from intermediate trophoblast is also there. In case of intermediate trophoblast, you will not see increase in the beta HCG, but the placental lactogen will increase. So beta HCG all the time will be normal. There on ultrasound and MRI, all the features will be similar to that of a invasive choriocarcinoma, but the blood markers will not say. But the practicality, what I can say is that if there is no documented earlier thing, the first thing that you can mention is enhanced myometrial vascularity with known history of some insult in terms of medical termination of pregnancy. However, looking at the echo-characterization of the lumen as multiple hyperechoic heterogeneous area intermixed with cystic spaces goes in favor of some or the other variation of a gestational trophoblastic disease, needs to be correlated with beta HCG. Placental lactogen serum estimation is costly. It takes 8,000 rupees. So I think still you can go for MR rather than going for placental lactogen. Thank you, sir.
Thank you, sir. Thank you, audience. Now I request Magai Madam to please felicitate our chairpersons, Dr. Dabde, sir. And I request Anjali Jamma Madam to please felicitate Fadkule, sir. Aboli Velankar Madam, please join. Dena, sir. I request Dr. Archana Shah ma'am to please give the vote of thanks.
So we all are at the end of the session, and I am here to propose the vote of thanks on behalf of Solapur OBGYN Society. It is said that the mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. So I thank all the speakers for their excellent informative talk, demonstrations that inspired and motivated all of us to use ultrasound as a diagnostic tool for betterment of women's life. The cherry on the top of the cake was the case-based interactive session. Thank you so much for the great academic feast. How I can forget all the delegates who are attending the CME the whole day, either physically or online. Thank you for making this event a great success. I thank my organizing team for extending their help. I'll fail in my duties if I forget to thank Mindray team. They are our academic partners, and this event is possible due to their great efforts. I thank Hotel Balaji Sarovar team, Mr. Ambuj for your great arrangements. I thank audiovisual teams, Mr. Chedzae for uninterrupted sessions. Please excuse me if unknowingly I forgot anyone's name. I thank all once again who participated in this event. Without you, this event would not have been possible. A big thank to all of you.